Good morning. So after the very successful culmination of day one, we are now on day two. And I'm extremely thrilled to begin this Meet the Professor session. And I know that many people are still yet to come, but in the interest of time and we have to go, all the sessions should be very bang on time, so we are starting here. And I was just mentioning that everybody is a professor here, so in this Meet the Professor, all professors are meeting everybody. And we have with us Dr. Betty Kim from MD Anderson, Dr. Sangeeta Goswami from MD Anderson, and these are the stalwarts who are leading the Cancer Moonshot program there. They have done pioneer work in Immuno-Oncology and many, many other accolades, but I should not be taking much time. And I'll invite Dr. Sangeeta Goswami to the dais and Dr. Betty Kim. Along with them, I would like to invite Dr. Jalali, Dr. Hari Bhakti, also on the dais. And we have with us Dr. Santhil Rajappa. We have with us Dr. Dr. Ramesh Namigada is here. That's what I'm saying. Do we have Amit Avasthi here?
Yeah, he's there.
Yes, Amit, come please. Santhil, I'll call already. Santhil, please come. Come on the dais.
And Dr. Ramesh.
Dr. Ramesh Namigada, please come on the dais. And then everybody can participate from the floor, definitely. So we have adequate representation from medical oncology, immuno-oncology, radiation oncology, surgery, and basic scientists. And now we can take, this is a very informal kind of session. We'll begin with, Gaurav is here too. Gaurav, please join in. So I think it's fine, so both face that way. So please feel free. This is an open conversation session as mentioned, and anybody and everybody can ask any question. Dr. Jim Allison is very jet-lagged, so he just sent his apologies that he might be late because there will be an oration speech for him today and busy day otherwise with panel and other things. So he will be late, so we have to start. We are beginning. So 2 stars are there, and the others will follow later. So to begin with, maybe I'll open the forum with Dr. Jilani. You want to take something, and then we can take it forward.
No, I'd request my overseas colleagues to give us a little background about the cancer moonshot, how it started. 2 questions, basically, how it started, what is the current state, and little provocatively, has it really met with the expectation when it started, or there are still some things to go forward?
So sir, just one caveat, because we are in the afternoon, we are discussing about the cancer moonshot program, so it will be duplication.
Oh, I thought today we are discussing this morning that.
Yeah, no, that was in the afternoon.
Okay.
Yes.
This is a general forum.
Correct. It's a general forum. So maybe, Sangeeta, you can begin general, your immunology work, and then we can, anything in general. What do you feel applicability in clinics, etc.?
Hello, it's working, right? Okay. First of all, thank you so much, Jyoti, for inviting me to the forum. It's been a really great pleasure to be in Bhubaneswar at attending this conference. I would say the general remark in terms of the field, and I kind of outlined a little bit in my talk yesterday. This has, in the past year, I have been frequently visiting India for different conferences, and very recently I was in the US-India Cancer Dialogue, and you're also part of, Gaurav and others were also part of it. And one thing what I have observed is that clinicians or oncologists are doing a tremendous work considering the density of the population and number of cancer patients that we are seeing in different centers, and this is incredible. And it is truly amazing that even with such high clinical volume, that clinical trials, right, thoughtful clinical trials are going on. But however, as I mentioned, that sometimes what is happening, the clinical trials are outpacing the basic scientific knowledge that we can learn from every patient. And sometimes it can get difficult in the clinical setting to include everything. And I also know from Amit's work and others, and I have friends who are doing incredible fundamental research work. If the integration is there, what we think that translational, like we need all the different funds. And India is leading in the IT. The computational is a big asset. And the new AI tools and others are now really, really an integral part of how should we think about science and medicine. So the integration is really important. And I think in US that integration is coming along because maybe the process started like a few decades earlier, and having like the physician scientists, like people who do research, and that gives a little bit of a perspective which question is important to us, which is more relevant clinically. So those integration would be important, I guess, and I feel all the resources are there. It just some leadership or some insight is required to how to kind of merge these fields. I mean, that's what I would say.
So thank you very much. I think very insightful. So Betty, I want to ask you now, you are a neurosurgeon, and from surgeon to immunology, what is your journey? And very informally, I'm asking this question because it is intriguing. Many people ask me this. Then how a neurosurgeon become very ignited for immuno-oncology? So please tell something.
Sure. So as you know, I'm a neurosurgeon, and so I am an expert in one organ up here, and it's really small. And so, when you look at our practice, where glioblastoma therapy has really not changed over the last 20 years, survival curve really hasn't changed very much. It's frustrating. And I think more and more you see a lot of younger patients now coming in where they just had a baby or they're going through graduate school and they have this disease and they're normal yesterday, but today, for the rest of their life, they're different. So it's very frustrating that as a surgeon, I don't think glioblastoma is a surgical disease. We're providing tissue for diagnosis, but ultimately it's already very diffuse. So I've always been very frustrated with the fact that as a surgeon, we make a dent, we do make a different, impactful sort of way for that patient, but just transiently. It was very frustrating. So I knew that research was the way where it doesn't give you this immediate gratification where we're going to see it in the patient right away. And I think that's a plea, I think, from Dr. Goswami and myself, is that we always look at the endpoint, that clinical trial that's going to change the survival curve, the New England Journal, Lancet, these huge sort of trials that we're sort of really aiming to really make an impact. But I think that right now is a short-term gain, because in 10 years, the field's going to be very, very different. And what's going to drive that is innovation, creativity, and the funding has to be there for people to innovate. And I think in a place like India, it was just my first time here, just really blown away by the people, the amount of knowledge that's here. And I think it's going to be the people who are going to be the leaders, who are the next generation leaders that are like here, that are going to think outside the box. And immunology, how did I get into that? Well, I'm also one of many millions that sort of jumped into the bandwagon. But my PhD was in nanomaterial design. I was trying to develop devices, handheld devices at the time, to detect CSF, or cerebrospinal fluid leakage that comes from the nose as we operate through the nose into the pituitary gland, and realized that through that work, how nanoparticles interact with our body. It was all immune system, the myeloid system, and so this is how we ended up sort of bridging into immunotherapy. I think as a drug development, an area that our lab works quite often in drug delivery, drug development, I then realized that traditionally, cytotoxic agents, as you know, you blast the host to the point where every dividing cell is going to die, and hoping that it's going to kill that cancer cell. But I think with immunotherapy and immune-mediated therapy, you don't really need to kill off every cancer cell, because then you're educating the rest of your body to attack the foreign invasion. So I find that a really exciting challenge. Certainly having Dr. Sharma and Dr. Allison in the institution with a great support, and colleagues like Dr. Goswami, where we could just talk about science and think outside of our narrow sort of spectrum of clinical practice, which is brain surgery. I think that's really helped as well.
Yeah, I think very, very important. And as you rightly said, it's essentially a teamwork, and you have an excellent team. A lot of things are happening, and definitely it makes a lot of sense. So, Dr. Haribhakti, you are one of the lead surgeon in the country, and how you take this and these new avenues, immuno-oncology, precision oncology, many things which are developing in the field. Fifth, sixth modality of care. So how you perceive this?
So it's interesting, when I first walked up on the dais and I introduced myself to her, I said, I'm the odd one out, I'm a surgeon. But I realized I was talking to a surgeon, so let me correct myself. And yeah, so I think it's, I really want to pick up where Dr. Petty left off, because I think it is so very true. The two major subsites I treat are head and neck cancer and breast cancer. And I think as a surgeon, it is singularly frustrating to see recurrence after recurrence. In our tumor boards, case after case is about recurrences and more recurrences. So I think, it is a frustrating reality that we live in, and clearly all of us are looking for some shift, and I think we are beginning to see it with immunology, because I will say without any doubt that today, amongst my own personally treated patients, I have a large number of them who I know are alive because of immunotherapy. They would not have been alive, because by the law of averages, after 2 recurrences, after neck recurrences, you lose those patients within months. But we are seeing them live. So I think it's a learning point. However, I believe when I read through the literature that a lot of the immunotherapy work is on histologies other than squamous cell carcinoma, and I would hope that such an important subtype, which really riddles our country in a way. It's the most important cancer in Indian males, and we can see that when used correctly, immunotherapy can make a huge difference. So I think I would say I feel I'm learning all over again.
Very well said, and truly that, this is essentially a mutual learning, and, what we see in predominance here in this part of the world is not so prevalent in other part of the world, and many unresolved, questions we need to answer. So certainly with you on this. And with this, we have our radiation oncology lead, Dr. Jalali here. So Dr. Jalali, I want to hear from you that, how you see the scope of combinatorial therapies, especially with the radiation, immuno-oncology, and what is your take on this?
So I echo the sentiments of all the previous speakers. So we had reached a kind of plateau, and it was, I'm just telling you very practical aspect of it, that few years ago, it was like a breath of fresh air to see the science, but also relatively very rapid acceptance of the field. That's also very important, because many a times there are quite a bit of innovations, and there are many, many hurdles which come into the clinic. And unfortunately, we have all realized some of the potential promises have not been translated into the clinic. But it is with great satisfaction that we have realized two things. One, a quick adaptation of the whole technology and the whole science behind it, which exemplifies the fundamental science, and the translational aspect was very robust. But as Dr. Goswami said, sometimes we outpace. So to keep up with the rapid development of science is a challenge. And we also have humbly realized that occasionally, and sometimes in many sites alone, it may not work. So therefore, the need of combinatorial therapy, and that was the interest that I developed a few years ago. So whether it is the combination of conventional chemotherapy, the optimal timings of surgery, the radiation, of course, and because I work in a proton center, the tremendous impact of a charged particle, but the challenge that when to do it, how to do it, which agent is the most appropriate, which is the proper indication, because in our enthusiasm, if you don't do it right, it can actually be a setback. So, but there is clearly a need, and I've heard Professor Allison himself telling us that there is that judicious use of combinatorial therapy is very important. And I am a neuro-oncologist myself, so I share the frustration of gliomas, but I put some slides in my talk later on. But my final point is, maybe Senthil can take up, because I assume that you're going to ask him now, is the theme of this meeting is choosing precisely and wisely. And that is a conundrum which many of us face, not only in India, but I guess across the world. Because when you have so much hope and you have success stories, there is also a bit of hype. And how to balance this? Initially, if you put in clinical trials, very controlled environment, you do it very judiciously, meticulously, it's fine. But then clearly sometimes it tends to outgrow the boundaries that we define our patients into, and that could be a challenge. So how to do that is also going to be, I guess, a challenge in the next decade or so.
Absolutely. So I think very well said, and I'm in agreement with all my panelists. What is being discussed, we have to really choose wisely and precisely, and that's where we are. We are discussing and brainstorming here today. Also, what the advancement of immunotherapy and the beauty that, in many deadly cancers, in a couple of decades, I would say when I was a resident some 15, 20 years ago, and when a metastatic melanoma used to come, it is kind of a death sentence, and patient used to write their will. But at present, with the advent of immunotherapy and with the Professor Jim Allison's pioneer work, actually, and we are so much honored that he himself is here and joining us in these forums today. So we are having a chance to talk to our patients about 10-year survival, or maybe we can say indefinite survival for that matter. So that is where we are, and definitely we have to be very, very judicious, and we have to choose our patient carefully in the clinics. And with this, I will move to Senthil. So Senthil, what challenges you face? And definitely it's not a panacea. A lot of time, we are seeing in the best of the tumors also around 30% response. And those who respond, they keep on and doing beautifully many a times, but what about others?
So thank you, Jyoti, for asking me to sit here first. I feel very humbled sitting, in this, with this set of very illustrious people here. Thank you for putting me here. So taking from Dr. Jalali's question and yours, I think has immunotherapy made a difference? Yes, it's made a really good difference. Has it lived up to its potential? At least in my mind, I think there's still a lot of scope for it to get much better. Dr. Jalali rightly said that it looks like we don't know how to use it. right? Today there was a tweet and somebody had put it in the group saying if you see 100 patients with cancer, about a half of them are eligible for immunotherapy at some point in time during the course of their illness. What is the response rate? It's about 25 to 30%. Okay, so if you look back to the chemotherapy era, in so many situations, it was not beyond that 25 to 30%. So you could flip it around and say, have we really made a big difference? We made a big difference because we are able to sustain that response. So when you talk to patients, I generally say, look, this 3-month difference in the median overall survival or the risk reduction in terms of 25% is not what I'm going to use this therapy on you for. It is with the hope that you will fall in that tail of the curve and hopefully you will be cured. Now, are we able to identify these patients when we are talking to them? Absolutely not. We've got some clinical predictors, we've got some lab predictors, but it's very humbling to say that after 15 years of it being in the clinic, we have not moved beyond PD-L1 and MSI. In my mind, I don't believe that TMB is a great predictor. But beyond this, we have not moved. There are predictive, biomarkers which are there in some academic institutions, but it's not reproducible. It's not been scalable across the rest of the world. And now we are moving to the next frontier, which is combinatorial therapy. So we are kind of leaving behind some work half done. And we're now going to move and then say a combination of these two is going to be better. It'll go up by another 10%, and that tail will go up by another 5%, and we may again get stuck there. So if you allow me, I want to ask Dr. Goswami and Dr. Betty here, do you agree with what I'm saying? If you agree, what is it that you are doing at this point in time to make this therapy much better? Help us choose patients better and patients benefiting better, because it's humongously expensive in this country. Okay, so there's data from Tata Hospital that about 5% were able to access it, and then maybe say in the clinic about a third of them who deserve it will be able to take it. And if I tell patients the numbers that I usually tell in an academic forum, I don't think the majority who pay from their pocket will take this. So sorry for this long drab. But I wanted to just set that context so that it'll put things in place. So
absolutely. So this is a question which is very, very important. That what is being happened. Sorry. Yeah, what is happening in this space, and how can we choose more wisely and precisely, and what is MD Anderson doing in this regard? Yes. So biomarkers.
Yeah, I was going to say, did you want to talk about your biomarker and maybe give the audience?
Sure. That's a very relevant question, and that is a challenge. I think it's a global challenge. It's not only like one continent versus other. Like, how do we choose wisely? PD-L1, as it was mentioned very correctly, is not a good. It was a good start. It was a good start, but definitely it doesn't have it didn't come across as a good predictive biomarker across tumor types. So we need to do more. And that is where I was kind of coming into that, understand the gap, bridging the gap of fundamental science and clinical science, clinical research. What we are doing in MD Anderson is that every time a patient comes to my clinic, I make sure that I get a next generation sequencing done, irrespective what setting is whether I'm doing it in a neoadjuvant setting or in a metastatic setting. Because it's very important to know. Therefore, like having NGS where it's more affordable in a country like India where patients can actually afford, because we also have to be cognizant about the financial toxicity that cancer brings, because as Hingjo mentioned yesterday that cancer is the #1 cause of bankruptcy in various countries. We were fortunate to have the insurance system there because most of the insurance NGS are covered by insurance, and now I'm also integrating circulatory tumor DNA in the MRD state to know, for example, the clinical trials, I treat a lot of GU malignancies, so for kidney cancer, there have been multiple trials in the adjuvant setting, and then Pembro showed survival benefits, so urologists would always send the patients to us to initiate Pembro. Should it be a blanket statement, right? Should I give it to everyone who has a rhabdoid feature or some other high-risk features? How do I choose wisely on those? Because once I give Pembro, if the patient becomes metastatic, that also exclude him from some other good trials in the metastatic setting. So therefore, it is important to know more beyond histology. Because if you look at the trials, and they would say that these are the high-risk features. But based on my clinical experience, that every patient, even though they have very similar histological evidence, but they behave very, very differently. So biomarker work, I agree with you, the challenge is universal. We need to know more from every patient. We need to integrate NGS as far and all the other assays that's coming up, without putting the patient through the financial toxicity for sure. That is important because what we have learned so far based on my research, because my lab focuses on the epigenetic regulation of immune cells and tumor cells. And one thing what we have seen that when the tumor evolves, it doesn't remain the same. It evolves, like immune cells evolve, tumor cells evolve. So having just a snapshot of one biopsy, one NGS, it doesn't give us enough idea. Subsequently, how should we think about the patient? So one thing we have been doing is a longitudinal biopsy, if possible. We often do that in clinical trial, but sometimes I also try to do it off-trial setting so that I understand the evolution of the cancer. When it started, I have the tissue. And another thing that I want to highlight from the research standpoint, earlier, to integrate research was a little difficult because most of the assays were single cell level or you need fresh tissues, and it was very difficult to kind of, logistically it was difficult, but a lot of assays are now coming up where you can actually understand the spatial biology of the tumor, and you just need FFPE samples. So we are also trying to integrate. We are still a long way to go, because what we have learned is some of the biomarkers that we have thought are good biomarkers, like correlating with CD8 T cells or TMB or PD-L1, it's not the way to go, and we should also think about combinatorial biomarker. When we are thinking of combination therapy, tumor never works in silo. So the stromal cells, the immune cells. Also, I want to highlight the host-specific factors, the microbiome. And we have a big platform going in MD Anderson, Prime TR led by Jen Vargo. So they have showed that your specific microbiota is correlated with immune checkpoint therapy response. And this would be interesting, right, that those work were started in Caucasian population. Here in Indian population, where we have different diets, different, culture, how is it correlating with response? So I think we need to think more holistically when we think about biomarkers and not really think in one particular setting. And we have to be cognizant that it evolves over the course of time.
Absolutely, I think very well said. And we are at the era of imperfect biomarker. We need to really move the needle in this space as well. That how perfect biomarker or towards perfection we can choose. So Dr. Malhotra is on the mic and.
So have attended lots of conferences, immuno-oncology conferences. Keep hearing that our biomarker field is imperfect. So now in the world, we have thousands of patients who have received immunotherapy. We have a subset who respond. We have a subset who don't respond. We have their tissue samples. We have their blood samples. So why can somebody not put this data together and come up with, okay, this is a good biomarker, this is a bad biomarker, this is a new biomarker. Get the, a leading institution like MD Anderson, get all the industry in line, tell them that we are going to do this study, we want all the samples. It can, I think, be done in the most advanced country of the world, in inverted commas. Why has that not been done?
In a certain sense that it's actually happening now at MD Anderson. So, for my clinical practice, we have a multidisciplinary brain metastasis clinic. I think it's the first of its kind where the patient literally sits in a room and all the specialists who are involved in brain metastases come and see them. And now half an hour before seeing them, we all gather and talk about this patient's clinical care, from neuroradiologists going through their imaging, all of their treatment, their tissue, all of their sort of samples and biomarkers, et cetera. So we have a neurosurgeon, a medical oncologist, a radiation oncologist that specializes in brain tumors, but also a research team that are there to figure out if there are any clinical trials. So we have a list of all the trials that are available at MD Anderson that's easily accessible. That's one. Number two is that every patient who enters MD Anderson are automatically they sign up for this institutional tumor bowel bank, where any tissue that we obtain from them, whether it be blood, tissue, microbiome, what have you, gets stored. Now, can we do a better job in which our goal is to really study each patient and personalize it, but be able to, as you were saying, why not have an algorithm now that we have AI and all this fancy information integrated? Well, we have a data science institute now where MD Anderson is pouring a lot of investment in integrating a lot of these complex sort of data sets that go beyond just a linear knowledge that we are, the state we are at, where PD-1, is there PD-1? Yes or no, is HER2 elevated? That's like a simpler sort of way of doing biomarker studies right now, but we're making it sort of a little bit more complex, if you will, in terms of analysis. The other is, Dr. Sharma had mentioned yesterday, the immunotherapy platform, which is under the umbrella of the James B. Allison Institute. That's a major institute that the institution at MD Anderson is pouring their sort of investments and attention to, because every patient undergoing immunotherapy is they're tied into the institutional tissue bank, but their sort of tissues are being collected, and as Dr. Goswami has mentioned, longitudinally. And it's a machinery. I mean, it's just amazing how just a group of people can sort of analyze all of this data and put it in. And I think the goal is to try and learn from them and personalize therapy. I don't think we're quite there yet. And hopefully in time we'll get there and sort of be the leader. Yeah.
And one thing I would like to highlight with all the positives that Betty has said, and I just want to play the devil's advocate a little bit, that this is not an easy job, even for an institute like MD Anderson, right? Because every patient is heterogeneous from every aspect. The tumor, the way that it would evolve, I mean, and there is so much like how chemo, like when we give chemo and then we feel that, okay, patient is responding, but chemo can also change the DNA repair machinery and how it will evolve. So it's difficult just by kind of having an algorithm and then have a blanket statement to generalize it to other patients. So, and then there is tumor-specific differences, right? What works for kidney cancer would not work for GBM. We have learned that, even for prostate cancer. So it's a uphill battle. But we are putting all our resources and hopeful that we will get there once we put everyone's minds together.
Absolutely, I think you're absolutely spot on this, that this looks like low-hanging fruit, but perhaps it is not, and a lot of work is happening all across the world. But we really need to move, with these infantile steps to peep into the future. That at some point perhaps we will be able to really identify. So one important, okay, I'll take first the question from Poonam. Yes.
More than question. So good morning, my name is Dr. Poonam. I'm from TMH basically, and Madam's junior. So I would say, sir, as we have seen over the years, I just wanted to share, I'm a surgeon, and we have seen other than squamous, like Madam rightly said, for melanoma, we have seen a paradigm shift in the management of advanced thyroid cancers. So I think in last 3-4 months, in fact, we have seen anaplastic cancers being operated with R0 resections with less than 1% viable tumor. So this is my personal experience. The another one is the advanced thyroid cancers, like where this is infiltrating the TO groove, sir would know, that involving the vessels, and we have seen that combination of various, in fact, we have seen pembrolizumab with lenvatinib. So I may not be the best person to go into the detail, but I have seen that one of our patients had PD-L1 expression of more than 50%. This was an anaplastic BRAF negative. And she's a 68-year-old female. We had R0 resection when the vessel was engulfed, but she was inoperable. And we would have said she will die a miserable death. So this has not been a single experience. We have another 37-year-old female, big, large fungating tumors. We gave lenvatinib again, and she has responded beautifully. Even though I have to see, it has melted away. I have the photographs also. So with big, large tumor, it has melted completely. So I think that is another field, and a lot of data I know is evolving in the Western world also. But in fact, in our TMH, as a part of practice also, we are seeing paradigm shift, especially in advanced thyroid cancer. Squamous, a lot of work is going on.
Absolutely. So I think these are the wonder stories which actually motivates us to keep going. And every patient is different, and it's truly an era of personalized or individualized care. And as just mentioned by Dr. Kim and Dr. Goswami also, that it depends on many, many factors. What is the tumor? Even if it is, one histology, there can be many nuances. And what is the host microenvironment? What is the, interaction between those factors? That's very, very important too. So I'm having Dr. Bharat Rekhi and Dr. Banavali. So I want a quick comment from you on histology and then from microenvironment. And then I'll come to the question because the clock is also ticking and I think 2 of the panelists are also not spoken. So. Yeah, actually it was an open conversation session and we thought that, it should be that, all 4 international faculty, they will be here and we can bombard with all the questions. Because Dr. Allison and Dr. Pam Sharma is pretty jet-lagged, so they will join us a little later. So we slightly changed the format and, we are having another kind of open conversation. Dr. Bharat.
Yeah, so thank you so much, Dr. Jyoti, and I completely echo, with the tagline of your conference, choosing precisely and wisely. And in pathology, we have been doing that. We've been trying to identify histologies for which certain therapies work well. So we've learned from melanomas. We've been working together in sarcomas, and now, because of the high TMBs, these undifferentiated pleomorphic sarcomas are also candidates. Alveolar soft part sarcomas are. So I think it's good if we are exploring the unusual to look at, something like a TMB. We've seen PDL1 success story, we know, and certain histologies are very important to look for. Like an example, we've just come across of an anaplastic carcinoma. So similarly, I think it's interesting to see which histologies will be candidates for these expensive treatments. Yeah.
Thank you.
Good morning, thank you. So, it's for long we are going after single agents to cure cancer. It's very difficult. As we all know, the cancer, you have to consider it to be a tumor along with its microenvironment and the body's immunity. So to think that you can cure cancer, it's very rare that you will cure it with single thing. So we'll require combination. And I always tell, yesterday there was this use of immunotherapy in solid tumor versus hematological malignancies. And I always tell my colleagues that, the immunotherapy is like a Lamborghini and the hematological malignancies are like highways. You can run smoothly on that. But solid tumor is like a road full of potholes. If you want to use that Lamborghini, first smoothen the road with, and I always use, I use my, metronomic therapies, which act on the negative immunity, the suppressor immunity, which, the other don't, like a Treg, the MDSCs, your macrophages. So use that, use the combination, and then basically smoothen the road, then your Lamborghini will run on that. So I think we have to be more open and not go for a single thing. We'll have to use combination, like Senthil told, what to use when. We'll have to really work hard on it, but I think we are doing. A lot of work is already being done, but it will improve.
So thank you very much. I completely agree that, we have to be Roman in Rome, and we have to really learn what tumor, what is the, host factors, and that's where we can take different approaches, and that's where also there is a role of combinatorial therapies and different. Amit, a quick comment. You are doing a lot of work on, these resistant mechanism, and a couple of times we are brainstorming that how can we take these things into clinics.
Yeah, so from the immunology perspective, first of all, I think that this is a 6th meeting, and this is a wonderful platform what we, especially you, put a lot of hard work and put together clinicians and the immunologist and the basic researcher, and I think this is something is really important for all of us. Otherwise, we were kind of in silos. We know the immune system is so diverse, as Sangeeta is mentioning about the tumor is diverse because every tumor is like, personalized medicines like sequencing and all, but immune system is also diverse. And if you really go in one cell, you have like not one checkpoint, you have multiple checkpoints, and they come in the kind of, in a fashion like they come together, right? So you have a lot of opportunity not to target one, then which one to pick in the combination, right? TIM3, PD1, LAG3, a lot of things are coming. The other thing is like, nonetheless, these things are working in a like 25 to 30%, so there is a lot of work need to be done. But if I talk about the Indian perspective, one of the things which is really major hurdle for the patient in India is really these are the expensive therapies. And obviously that comes to the point that obviously if you have like a predictive biomarker, then you tell the patient beforehand, you will go for this therapy and you will not go for this therapy. I see a lot of effort. In fact, some of the work what we are doing, not in the patient, but in the mice model and melanoma and MC38 and a lot of things, the SALT story what we published. And we combine the paper from the Honjo, and then we identify some biomarker which is like could be a predictive biomarker. But the problem is, I think it's not a one biomarker, what Dr. Sangeeta is mentioning. You have to have like large data set, and then you have to have some sort of AI-based algorithm. Maybe it's possible, not now, but in future, that can give you a kind of predictive biomarker, and that will be very helpful. The second thing what I want to mention about India is the two important events happened that actually brings a lot of confidence in the scientific fraternity, also in the funders. One is obviously COVID happened, and then we did a lot of work in the COVID, and a lot of indigenous things happened. The second thing is really the CAR T-cell therapy, and he's sitting here with me. So these are the things bring a lot of confidence that, yes, we can do a lot of things. The infrastructure is changing, and there's a lot of opportunity for all of us. However, there's a certain challenges. The clinicians are really busy in India. I mean, I go to AIMS and I talk to these oncologists, but I see they have like so many patients they have to see in a day. I mean, it's very, very challenging. But, some people are really interested. So then the basic immunologists and then the scientific people, and then we are trying to make some progress. And hopefully this will really turn out to be a good kind of, collaborations. And we are looking forward for new therapy for cancer patients. Yeah.
Absolutely. So I think, we have to be cognizant about the fact that every time there is a, that when there are recurrences or progressions, there is not only tumor become more heterogeneous and evolved, there is microenvironment also, there is some evolution. There is the immune system also which is evolved, and there are biomarkers which also evolved. So we have to every time, kind of, adjust time and then make predictions. So that's why these predictions are so much difficult. So we are really running towards the end. So Gaurav, 30 seconds, you are very crisp. I know that you can do this job in 30 seconds. So you make your concluding comments, and Jyoti, we will handle this in the lunch hours because we are having many, many things. Okay. And thank you very much for your understanding.
So I'll keep it brief. I think immuno-oncology is a perfect example of team science. No one is going to do it by themselves. We all got to come together. That's what we had thought when we founded the society, that we need everybody on board, all clinical fields, all scientific fields, different areas to come together. Tumor microenvironment, everybody, we need to work together to get the responses. And I'd just like to add to what Sangeeta had said, how the tumor system evolves. It's also the immune system which responds to it. I would just like to liken it to think of it as an orchestra where 100 pieces are playing. They're all playing together for this harmonious music, but at sometimes the cello takes the lead, sometimes the bass takes the lead, sometimes there's the percussion which takes over. Sometimes everybody goes quiet and there's a solitary flute which is doing the magic. But they're all needed. So when we study it, we don't know which one. We study at one point, we may have missed one section entirely of what it was doing over there. It's a very complex field, and it requires all of us to come together to get the responses we can.
Thank you very much. And, indeed, it was a very intense discussion. There are many, many questions which are unanswered, which keep coming. But I want you to be similarly engaged over the day. There will be many more interesting sessions which will be coming up. And all these questions will keep popping, and we will, try to brainstorm. I also want to say in the end that, apart from all these factors, one has to be really intuitive. And the sixth sense, which works, many times we don't know the reason for it. And that's where I really respect a lot of my colleagues and who are sitting here, who are sitting in the crowd, that, they have something different, and that's where we can do better for our patients.
Sixth sense is your microbiome, your gut feeling.
So perhaps I'm talking about seventh. So thank you very much on this note, and, then we will, we are, kind of concluding this Meet the Professor session, and we are moving to the main conference sessions. Thank you very much. One picture, yeah. So we will have a picture here. Yeah.
finished.
Also, I wish to announce that after the Dr. Allison's oration, we will be having a group picture for everybody. So please be here because then we can have everybody in one frame. Thank you.
So, very good morning to you all. Our first session of the day is gynecological and breast cancer. And for that, I would like to invite our chairperson, Dr. Sushil Giri, gynecology-oncology specialist from Cuttack, and Dr. Kshitij Mishra, radiation oncologist from Cuttack.
Dr. Nikhilesh Gadial Patil for his presentation on immuno-oncology in gynecological cancer. Dr. Nikhil, please come.
Good morning, everyone. At the outset, let me thank Jyoti, Dr. Hemant, Ghanshyam for this opportunity, and it's quite a privilege to be here amongst our close friends as well as senior immuno-oncologists of the world, and it's quite an honor for me also. So thank you so much, Jyoti, for the invite. And my job is to talk about the current landscape of immuno-oncology in gynecological cancers. As we understand, immuno-oncology has made a massive impact in the last decade, especially from, let's say, 2013-14. And it has practically impacted almost all the cancers, if not every, but almost all the cancers. And one of the success stories remains the gynecological cancers in this regard. So what I would do in next 10-15 minutes is basically to just give major overview about role of immuno-oncology in cervical cancer, both in the early as well as advanced setting, endometrial cancers, first line as well as in the subsequent lines, and if time permits, a bit about ovarian cancer, as I don't have much to talk about in the ovarian cancers. And to really understand how the things have evolved in the last few years, we started with the platinum for cervical cancer, then we found taxanes, eventually we found the anti-VEGFs. And eventually, as we are almost on the cusp of this 2020, thankfully, we started getting a lot of data about the immuno-oncological drugs, more in the form of pembrolizumab, not only in the metastatic setting, but also in the curative setting, and that is quite heartening to see. So when you look at 4 immune checkpoint inhibitors in 5 phase 3 clinical cervical cancer trials, this is the list. And here we will focus both on the first line, second line, and also with the chemoradiation. So that is what we'll look into for cervical cancers. Now, coming back to the important study, what we all are aware of is a Keynote 826, which basically told us that when the patients who received taxane platinum with or without bevacizumab and received pembrolizumab versus placebo, the outcomes of the patients who received pembrolizumab had much better as compared to those patients who did not receive. Combination, single agents, yes, we are all looking into that more and more. Yet I would concede here that ovarian cancer still remains a struggle. So there is a lot of optimism and there is a lot of hope, and I'm sure with more advent of newer and newer drugs, especially and more trials in this setting, like as I just now showed about one bispecific, and we are again also in the era of ADCs and bispecifics, I believe the outcomes continue to move northwards for our patients. So with this, I stop here, and thank you so much for the hearing.
Thank you, Nikhil. So, I'd like to have some interaction from the audience. Any question to Nikhil?
Doctor, any insights on treatment of carcinosarcoma of endometrium with immune checkpoint inhibitors?
So carcinosarcoma per se only as a single study group has not been really evaluated, but subset analyses are available. And there is a bit of a data about use of dostarlimab, which has some more stronger data in this setting. And there also seems to be a positive data in this area.
Anybody else? So my job is to just summarize this thing. So Nikhil, it is a very lucid talk in the sense you have covered all the subjects in only less than 15 minutes. But the problem lies here that we have adjusted all the model of treatment in cancers, gynae cancers, surgery, radiation therapy and chemotherapy. Almost we have adjusted. We have reached the peak. Now still there are recurrences, there are advanced cases. So the immunotherapy is a hope. It's a hope, and it is acting. It is acting in a great way. And in near future, I hope this will be a most alternative therapy, most important alternative therapy in gynecology. So thank you, Nikhil, for your lucid presentation. Thank you very much.
Thank you so much.
So for the next session, I would like to call the chairperson, Dr. Bhagyalakshmi Nayak from Cuttack, Dr. Bhavesh B. Parekh, and Dr. Vijay V. Haribhakti.
May I please invite Dr. Jogamaya Patnaik, medical oncologist at Bhubaneswar, to deliver the next talk. And the subject is redefining treatment outcomes with immunotherapy in early triple-negative breast cancer. Dr. Patnaik, please.
Good morning. Good morning, everyone. Welcome to the Temple City. So in the session for breast and gynecological malignancies, let us go to the first most important topic in breast cancer, that is triple negative breast cancer. So my topic is redefining the treatment outcomes with immunotherapy. This is a sponsored talk from MSD. So I'll be discussing about the role of pembrolizumab in early triple negative breast cancer. So as we all know, breast cancer is the most common malignancy today in the whole world, and with more than 170,000 cases annually detected and almost 90,000 deaths per year. And triple negative breast cancer, which is characterized by not expression or non-expression of ERPR and HER2. It accounts for almost 15 to 20% of breast cancer. And in India, triple negative breast cancer incidences are little higher compared to the Western country. It's almost up to 30 to 35%. And the patients in the triple negative breast cancer, mostly they are detected in the advanced stage. They're mostly younger women. They're mostly more higher burden of disease, more T size, more lymph nodal burden, and definitely the occurrence of recurrence is higher and sooner in this group of patients. If we see the time of recurrence of breast cancer patients, it's around, if it is for breast cancer as a whole, if it is 35 to 67 months, in TNBC it is 19 to 40 months. Loco-regional and distant recurrences both are common in triple negative, and if we have a loco-regional recurrence, 1 year survival rate is around 80%. Distant recurrence, the 1 year survival rate is around 47%. If both, then it is very dismal with 40%. The characteristics of TNBC makes this the most important and the most deadly of all the breast cancer subtypes. It grows quickly, spreads. Most of the patients are presented at the time with metastasis. And the 5-year survival rate, if we consider as the SEER data for all stages combined, it is around 77% for 5 years. But sometimes we see that some breast cancer patients in TNBC category also do well. So why is that? Breast cancer has been molecularly subtyped into 6 varieties: basal, like 1, 2, luminal androgen receptor type, mesenchymal stem cell like, immunomodulatory type. Amongst them, the immunomodulatory time has higher incidences of increased TIL infiltrations, high CTLA4 expression, high PD-L1 expression, and it is more likely to be responsive to the immunotherapy drugs. So, as we know, in all stages of triple negative breast cancer, we have some role of chemotherapy, and chemotherapy is the most important part of the treatment modality, along with surgery and radiotherapy was the mainstay of treatment of triple negative breast cancer till we got this data of Keynote 522 regarding immunotherapy. So after this data for this Keynote 522 trial, we got a rapid approval of using this drug in early triple negative breast cancer. So almost most of the patients in triple negative breast cancer present with metastasis. Early presentation of triple negative breast cancer actually is rare. It may be in clinical practice 20 to 30%. But can we improve the survival of this group of patients by adding something to the chemotherapy? So let us see about this. So pathological complete response is the most important parameter of survival in breast cancer patients, if we see. And who has more pathological complete response has better survival, better event-free survival, better recurrence-free survival as per the data. So if we see 30 to 35% or up to 45% pathological complete response is seen with chemotherapy. If we add some other drugs like immunotherapy, it can increase up to 60%. That's what it has been shown in this immunotherapy trial. So what is the role of preoperative or neoadjuvant chemotherapy in triple negative breast cancer? One is that definitely it controls the systemic spread of the disease, because as we all know, breast cancer is a systemic disease. Whatever early stage it is detected, it facilitates breast conservation. It can make inoperable tumors operable for breast conservation, allows time for genetic testing, And we can also have the discussion with the patient whether the tumor is chemo-responsive or it is not responsive, so that early surgery can be planned. So as per guidelines now in triple-negative and HER2-positive breast cancer patients, early breast cancer also, there is role of chemotherapy, and surgery will be followed after the neoadjuvant chemotherapy. Triple-negative breast cancer is one of the most immunogenic tumors of breast cancer with high PD-L1 and TIL expression, as we have already discussed, and Keynote 522 trial also tells us that this particular point can be taken into account in deciding the therapy and improving their survival. Let us come to the trial. So what they have done, they have taken 2 arms in which early triple-negative breast cancer patients who have tumor size more than 1 centimeter, less than 2 centimeter with node-positive disease, or any triple-negative breast cancer with more than 2 centimeter size with or without nodal involvement, regardless of PD-L1 status, they have taken. And 1 arm they have given along with chemotherapy, Keytruda 200 milligram 3 weekly on day 1. And in other arm, they have given just placebo. So chemotherapy arm was either paclitaxel weekly, carboplatin either weekly or 3 weekly. Along with that, after 4 cycles of this and followed by the anthracycline combination, along with that also they have given Keytruda for 8 cycles before surgery, and patients after surgery also received up to 9 doses of adjuvant pembrolizumab. So the exclusion criteria, as we know, for all immunotherapy trials are autoimmune diseases. We require continuous treatment with immunosuppressant drugs. So the median age of the patients were 49 years, mostly females, and whites were more. Good performance status patients, more were premenopausal, less were postmenopausal, and higher were T1, T2 diseases, lesser were T3, T4 diseases, and N0, N1 diseases, around 80% were N0 or N1 diseases. So with this, they have got the continued the trial, and what they have found in the results that the pathological complete response in node-negative patients, addition of Keytruda, the pathological complete response was almost 64%. And compared to the chemotherapy arm, which was 58%, in node-positive diseases, it was 64%, and in chemotherapy arm, it was 44%. So there was not much benefit in node-negative diseases, but definitely there was benefit for node-positive diseases. And if we see the pathological complete response, as we have already discussed in meta-analysis previously, have mentioned that pathological complete response has been translated into better overall survival and recurrence-free survivals in breast cancer. And in triple-negative breast cancer patients, those who have achieved pathological complete response, the 5-year event-free survival was almost 90%. Without pathological complete response, it is 57%. And this has also been translated into the overall survival in another study. They have achieved higher overall survival, those who have achieved pathological complete response as far as TNBC is concerned. So in the intention to treat population of Keynote 522 trial, the patients who have received Keytruda, they have almost 64% patients amongst them achieved pathological complete response compared to 51% of the patients with only chemotherapy arm. After 18 months, when they compared the event-free survival, it was almost 90% for the pembrolizumab arm, and in the placebo group, it was 83%. In the intention to treat population, when the events were almost 16% with Keytruda arm compared to chemotherapy arm, only 24%, and addition of pembrolizumab reduced the presence or a risk of an event with a hazard ratio of 0.63, and then the patients who had PCR, their event-free survival, if we see, then it is 94% for Keytruda arm and 92% for their chemotherapy counterpart. But those patients who have not achieved PCR, their event-free survival was 67% compared to 56%. So if the patient anyway achieves PCR, Pembrolizumab will not add much to the event-free survival, but if the patient does not have PCR, definitely along with chemotherapy, the role of Keytruda or pembrolizumab is more. And if we see the toxicity data, then all grade toxicity was 41% in the Keytruda arm compared to the 34 in the chemotherapy arm. And this common toxicities were rash, diarrhea, pyrexia, decreased appetite, all these things, which were mostly manageable. Grade 3, grade 4 toxicities were 3.2% compared to 1.8%, not much. Then if we see the EFS, the combination resulted statistically improved event-free survival compared to placebo in all subgroup of patients, and may it node positive, node negative, or more benefit was there in lower tumor size patients, or PD-L1 positive patients and negative patients both benefited from addition of Keytruda. And 16% of the patients had event in Keytruda arm compared to 24% patients in the chemotherapy arm. Estimated 24 months EFS was 87% in the Keytruda arm compared to 81%. And also the 36-month estimated EFS was also higher. And obviously there was a documented better PCR rates compared to the chemotherapy arm, 64% versus 51% in the chemotherapy arm. Also there was an update of ESMO 2024 for this trial, in which there was a updated 5-year event-free survival data of almost 81% compared to 72% in Keytruda arm compared to the chemotherapy, with a good hazard ratio of 0.65%. Overall survival also improved, with almost 5-year overall survival was 86% compared to 81% in the chemotherapy arm. So irrespective of the nodal status, tumor size, schedule of carboplatin, PD-L1 status, age, pembrolizumab improved the 5-year event-free survival, PCR rates, and overall survival in this group of patients. So related to adverse events, as per the updated data, any grade of adverse events almost all patients had. But the grade 3, grade 4 side effect or death, all these things were less. But definitely due to the addition of Keytruda, higher patients had discontinuation of the drugs, almost double compared to the chemotherapy arm. And the the immune-mediated adverse event, these were the all-grade adverse events. Immune-mediated adverse events were 35% in the Keytruda arm compared to 13% in the chemotherapy arm. And discontinuation of drug due to immune-related adverse events were 7.7% in the Keytruda arm compared to 1% in the chemotherapy arm. And the common side effects were hypothyroidism, skin reactions, adrenal insufficiency, pneumonitis, they were, and others were lesser. So as we see in common practice, mostly skin reactions and hypothyroidism, colitis or gastritis, these are the common side effects of mostly the immunotherapy drugs, whatever we use. And in this trial also, this was not much difference. So therefore, the NCCN guideline has mentioned also, it is in the first line recommendation for early triple-negative breast cancer as pre-operative chemotherapy regimen. So the summary is that triple-negative breast cancer is a very important subset of patients which needs special care and special mention and attention. And we always tend to try to improve their event-free survival and prevent the occurrence of metastasis. And definitely, because immunotherapy drugs have, in all settings of malignancies, have shifted from metastatic setting to the early cancer setting. So definitely, triple-negative breast cancer should also get a chance to get benefit from this drug. So this trial is a very important trial which has shown that neoadjuvant chemotherapy, immunotherapy combination regimen in triple-negative breast cancer can give overall survival benefit also. Thank you. Thank you so much. Thank you for patient hearing. Any questions? I'll be happy to answer.
Any questions, comments from the audience? It's a very important presentation, very well done.
Thank you, sir.
Yeah. Yeah.
Again, the same thing, the patients who do not achieve pathological CR are the ones who do poorly, because after the surgery, we are not giving them any treatment. Whereas if we are like I've been using metronomic therapy for years now, and we have exactly the same outcome as that with the immunotherapy. So if they continue on some treatment, they will be doing better. Like in ER/PR positive, we give them basically the hormone therapy. In HER2/neu, we treat them with the Herceptin, whereas here we leave them alone. So if you give them something, I think, and we have shown that it's nearly the same as using the triple negatives, basically immunotherapy. So I think something has to be given after. You cannot leave them alone after knowing that they are ER/PR, the pathological CR they have not achieved.
Yes, sir. Sir, actually in triple negative breast cancer, we achieve highest PCR rates amongst all breast cancer subtypes with chemotherapy. So if the patient achieved, like 92% patients, if they achieved PCR, only 2% event-free survival benefit was added by pembrolizumab. But the patients who have not achieved pathological complete response, almost 20% benefit was added by pembrolizumab. So that is a very important catch point for this trial.
That's it. So either you use, immunotherapy which costs in lakhs, or metronomic therapy which costs 100, 150 rupees. So, it's the outcome. That's what I'm telling. So you have to give. You cannot leave them alone. What we are doing now, or we were doing till recently. Now we don't do that. So if you continue on therapy, they will do better one way or the other. But they have to be treated. You cannot leave them alone after knowing that they are PAT-CR positive.
Yes, sir.
Any other questions from the audience? Yeah, I just wanted to raise a quick point. In one of your earlier slides, you brought out how there are nearly 5 or 6 types of TNBCs, of which you showed that one of them is conspicuously responsive to immunotherapy.
Immunomodulatory type.
They're immunomodulated type. Now, however, we find that immunotherapy is just dished out to everybody. So any comments on that, and any thoughts about better, because we are choosing wisely now, so any thoughts on that?
Sir, actually this trial has not taken PD-L1 positive cut-ups and all. So most of the trials we have, and immunotherapy drugs usually they perform better if the PD-L1 is positive. But this trial has taken patients regardless of PD-L1 status. But definitely if we see or stratify patients based on PD-L1 status, there may be more benefit, which we don't know. So immunomodulatory variety in triple negative breast cancer is immune rich, but can we have a biomarker for immunomodulatory variety? That is not in clinical practice now. So definitely that should be a better option to think about. That can we give in PD-L1 positive so that we'll get more benefit. So
in early breast cancer, it's been shown to be irrespective of this.
Yes, sir.
And I think that's the interesting aspect. One way of it is to look at the difference between the chemo and the immunotherapy arm. The other thing is to see that the immunotherapy seems to be working irrespective of all this. Lymph node positive, lymph node negative, and in the different thing. So there is something else that's happening in the mechanism which we are not able to say. But what we are now finding out, interestingly, is that the PD-L1, which we wanted, the mutational burden, we wanted something to identify, we are still not able to identify, but the truth is it's just working.
Yes.
Absolutely. So I think, the beauty lies that we are still learning to tame the beast. And there are several subtyping, and as we are refining our diagnostics and our prediction abilities, we are getting more and more complex also. And there comes the role of combinatorial therapies also. And perhaps with the judicious combination, other immunomodulatory varieties, definitely immune hot. But those who are not, perhaps by using another agent together, chemo, radiation, some other targeted, anything else, perhaps we can make convert them in immune hot environment. That's where, the science is working. So thank you very much for those comments.
Thank you, madam.
Thank you.
Now I am inviting the next speaker. The topic is IO in breast cancer, that's immunotherapy in breast cancer. And speaker is Dr. T.P. Sahu, medical oncologist from Bhopal. Over to Dr. Sahu.
I didn't do anything. So thank you, Ghanshyam bhai, for giving me this opportunity. And in the next 15 minutes that has been allocated to me, I'll be speaking on immunotherapy in breast cancer. It's a vast topic in itself. So I'll be putting 70 to 80% of time, maybe more, to the early breast cancer, because 522 has been just spoken. I will just put my viewpoints on what could have been better, and then we will go to another aspect of breast cancer when immunotherapy in the early breast cancer is not spoken much, the hormone positive, HER2 negative group, where a lot of evidence has come in the last 1 year in the early breast cancer scenario, and last 1 to 2 minutes on the metastatic setting. So this is a typical case which any one of us would see on a Monday morning, a 42-year-old female with a T3N0, or it could be anything beyond 1.5 to 1 centimeter and beyond. That could be it, with a node positive, or maybe T3, T4 and plus. What next? We have been practicing till the last 1 year or 2 years that more than 1 centimeter, some people believe 0.5 centimeter to go for adjuvant chemotherapy. AC, EC followed by taxanes or in combination has been the standard of care. Anthracycline-free regimen may be popular in HER2 positive, but not popular till now, and is still being an integral part in the triple negative. So if you look at it, this is how the neoadjuvant space has evolved. And we all do know that the neoadjuvant chemotherapy probably is the best way to go forward in a triple negative breast cancer. The role of immunotherapy has been addressed in multiple trials, and this is few of them. There have been few more additions to this. We have been lately speaking a lot about the Keynote 522, which had the overall survival data published few months back, and that was a positive trial. I'll come to 1 or 2 criticisms, what I felt was being put up in the text in the publication itself. We have the IM Passion, which was unfortunately, as all Atizo trials, and Sendil rightly tells, I remember one of his quote, in previously if you had to do a trial, and if you had to have a negative trial, do it in UK. And if you have immunotherapy trial and you want a negative, use Atizo as your partner. So that is what it has been mostly. And I like that quote of his. And this is what, unfortunately, most of the Atizo trials have failed, except for a select few. So this, I'll go to 522. I am not going to the data which you have already seen. Just to tell you, the events was around 0.67 towards in favor of the Pembro plus the chemotherapy perioperative. This is the OS mature data curves. So point is, all the subgroups do benefit. The test of heterogeneity was not significant for any group. So in the triple negative space, there is a point that irrespective of what it is, the PDL1 score was spoken right now. I will come to that in a minute. That is also irrespective of them, although the benefit, and it looked like the CPS less than 1 numerically had a better benefit. But to cut the thing short, I am just concerned there is no divergence of the survival graphs, at least for around 1.5 to 2 years. And the graphs of OS is crisscrossing each other. But then the graph after 2 years starts to diverge, and there is a progressive incremental benefit, and that we can see on the survival. But the first 1.5 to 2 years is a concern which is very less often spoken. And this is the OS, not the PFS, where we normally see this crisscrossing of the curve. And in the article, there is a beautiful thing that comes up in the NEGM article. And one more thing, the hazards in the first 2 years is around 0.87. And post the 2 years, the hazards comes to around 0.54. So there is a differential p-value in the first 2 years and post 2 years. Although there is a significance, and the significance is showing in the later part of the graph, and the authors going to put the RMSTs, which we may criticize or not criticize, but this is something for us to take it. And when you have when the p-value is something which is not proportional across, RMST could be a good way of looking at it. And they've looked at the RMST, which is the absolute difference that happens within that time period. And it's actually calculated as per area under curve with that Kaplan-Meier graph. At the 3 years, the difference of adding an immune checkpoint versus not was 0.2 months. At 4 years, it was 0.6, and 5 years, it was 1.2 years. So the 1.2 months, sorry. So this is something we have to also acknowledge, and this is what I have to say in additional to what was already spoken for the Keynote 522. This was already done, that irrespective of the PDL1 PATCR had a delta of around 15 to 18%. and that was very significantly seen. That was also seen equally in the IM Passion 031 with atezo, positive or negative PD-L1. It did not matter, maybe little bit of more towards positive, but it did not matter much. And this is something all of us have seen, that if you do not achieve a PathCR, maybe the residual disease score 1, 2 did benefit more, and this is shown in the RCB2, the benefit is the maximal. So I'll go to something that is new. I have just the one point which is highlighted. This is the new data set which has been put up in SABCS last 2 months. And this is again atezo design, same typical what you would see, the triple negative. They have taken anything beyond 1 centimeter to be inclusion criteria, but those had to have node positive, but T3, T4 irrespective of nodal status, or N2, N3. So this was the inclusion criteria. And they did the carboplatin with the taxanes weekly plus minus atezolizumab. It was a double-blinded study, and they continued with atezo as the standard treatment arm. And if you look at it, they also first time they put up the EC and AC 2 and 3 weekly. So normally we do it dose dense, but here and in the 522, if I'm not wrong, it was a 3 weekly. Here they put it the 2 versus 3. So again, what we normally practice, they have done that. And this is the thing here is, if you look at the nodal size, there was more of the PDL was positive in approximately 36%. The nodes were positive in around 40%. And if you look at it, more than 1 centimeter to 3 centimeter was around 60%, and they had to be node positive. So that we have to take into account. The EFS is a hazard is 0.8, statistically not significant. The confidence interval is wide. It is in contrast to what we saw in the Pembro 522. It's around 0.6768, if I'm not wrong. But the most interesting thing comes here. If you look at the forest plot here in the atezo data set, there is a p-value significant for the interaction for the clinical node status, and the positives do and have done better. This trial data showed you that. That could be because of the bulk of the disease or something of the new antigens. We do not know the reason, but this is what the data set is. Interestingly, this data set also told something which is different from what the 522 set told. If you look at the persons who did not achieve a PathCR, and irrespective of what you gave or did not give atezo, they did not benefit, in contrast to what we saw in 522, that patients who did not, there was a difference in the event-free survival curves in the lower part. And I hope that is pretty clear, the 4-year EFS. The OS is, again, it was similar, not different of adding atezo. This is, then I'll shift little bit gears. Can we choose more wisely, and can we do it in hormone positive? So if you look at it, the Americans and we have traditionally been giving and accepting that anything more than 1 is a positive for hormone. But the French and the European, some countries tell it that less than 10% they consider to be hormone negative. So they have looked into this data, and this data comes with a preset, and I'll talk about Keynote 756 in a difference. This is a single country, multicentric, retrospective analysis. And what they looked at and told you that if you have a ER 1 to 10%, so typically the low ER, those patients, if you talk as PathCR as an endpoint, the ER low did achieve a PathCR which was much, much higher, even that was seen in the other landmark trials. So can and should we be talking and treating these patients differently, something we have to reconsider. This is not one data set. Even the NIVO data set in the hormone positive also points to a similar thing. Now we come to 2 additional data sets, which I hope the panel will also discuss. One is the Pembro and chemotherapy in a high-risk, early-stage ER positive. So we are shifting gears from triple negative to hormone positive, HER2 negative in a randomized way. And then we have the Keynote neoadjuvant NIVO in the similar setting. So basically they had a 1 to 2.53 centimeters, which had to be node positive, and beyond that, T3, T4 could be a nodal status or N2, N3. They took this as a ER positive, HER2 negative, and these patients were given chemotherapy. In addition, they are given the pembrolizumab versus nivolumab. So this is a standard thing what it was. The NIVO arm, the NIVO trial was little numerically with a lesser number of patients compared to the Pembro. The NIVO was approximately 517 patients, the trial data set, and the Pembro was around 1100 odd patient data set. Cutting short to the main point, if you look at the PathCR, which was one of the primary endpoints, and if you look at the PathCR, which happens for all patients intent to treat, is in the left upper part of it. And if you look at it, it looked at that the addition of immune checkpoint to this subset of patients did benefit in the terms of PathCR from 13.8%. In the control arm, it raised to 25%. Point number 2, if you add the RCB0 also, then you find that the percentage advantage was still there. The delta was around 9 to 10%. But the important thing comes here, which we did not see in the triple negative early breast cancer scene. And this is replicated in both the trials. In the next 1 minute, please look into this trials data set very carefully. If you look at it, the nivolumab, the trials PDL more than 1, and the trial with the data set with PDL less than 1. You see there's a starkingly difference in the PathCR rates. In the negative PDL1, you see there is absolutely not much of a difference. But in the PDL1 positive, which is beyond 1%, there is a delta of around 24%. And this is staggering. Number 2, if you look at it, the TILs, again there are controversies of TILs, how to calculate is there is a concordance with the TILs. But if there's a high TIL, more than 1 or less than 1, there's again the delta is around 24 with a high TIL. And the median TIL in this trial was 1, more than 1. Interestingly, again this trial looked at 3 IHC markers, the SP142, the 28.8, and also they looked at TIL. And if there's a high concordance within these 3, the patients achieved a more PathCR, which was in the tune of 25 to 30 delta. But if the concordance was not there, still the benefit was there, but not to that extent. Number 2, look at this part of the graph, which is on that side. Look at more than 1, more than 3, more than equal to 5, and more than equal to 10. You see that there is a gradient effect in the PathCR delta as there is the shift of the score of the PDL moves from 1 to 3 to 5 to 10. And the delta for patients who have a CPS on 28.8 more than equal to 10 is 32%. Number 2, if you look at the TILs, similar delta is coming if there's a high TIL beyond and equal to 10. And remember what we saw in the triple negative. I'll come to a minute. Look at the Pembro data set. 2 things come out. If the CPS score is high, more than 10 or more than 20, just look at the amount of benefit you are going to achieve in a PathCR regards. And if you have an ER which is less than 10, the benefit of PathCR increases, which is in concordance, which the French data set told you, and the similar data set is in nivolumab again. So 2 things come out of this as per me. One thing, if the role of PDL is much more significantly pronounced in the hormone positive subset rather than the triple negative. This could be because of the tissue heterogeneity where we do the PDL1 on a small core biopsy. The triple negative have more heterogeneity in contrast to hormone positive. Number 2 that comes out is ER low, which in most of the definitions has been less than 10. They probably behave more towards the triple negative, and we should be probably considering this subset of patients towards a neoadjuvant approach or perioperative approach of an immune checkpoint. Last 2 slides on adjuvant. Do they play a role? There is one data set which I want to talk, and there have been more than one actually. And the A-BRAVE, which was read out last year in the ASCO. Very simple cohort, stratum A, stratum B. Stratum A was upfront surgery. They had minor 20% patients. Stratum B, which was post-neoadjuvant, they had majorly those who did not achieve a PathCR. And in the stratum B, if you look at it, the RCB2 were the maximum number of patients, in which we did see a benefit in the 522. To the whole, the primary endpoint was negative. The CI was wide, but the OS was beneficial in this. The point goes that if someone in the triple negative has missed and has not received a neoadjuvant immune checkpoint, and if, I'll take 1 more minute, and if somehow they have not achieved a PathCR, can we give an adjuvant atezo? It is not approved. It's up to your decision. I'll just end up with this meta-analysis, which is the best form of meta-analysis I could find. It's a trial level meta-analysis, not an individual patient level meta-analysis. This again tells you triple negative PD-L1 does not matter. Her positive, receptor positive, it matters. And even in the ERB2, where the data set is the weakest, again, probably it does not matter, but probably little benefit. And the second thing that comes in meta-analysis is beautiful. What we always ask, should I give immune checkpoint post-PATCR? That has not been, there is an ongoing trial for Pembro. The data set will be out quickly. But till that, this meta-analysis tells you there is no benefit of an adjuvant component of immune checkpoint irrespective of the PATCR or residual disease. In contrast to what 522 told, if you have residual disease, there will be some advantage. This is the metastatic, my only one slide of metastatic. We have spoken about it enough. We know that IMPassion 130 was positive, 131 was negative. We know the criticism for each of it. The Pembro 355 is positive, but only for CPS more than 10 is something that we should consider this. And this is where I'll stop on the metastatic setting to tell you that immune checkpoint expression are important. This should be considered in the field I have spoken to. The tumor mutational burden, the MSI high at least is something that is important. The TILs, we do not know how to best utilize it. The concordance is the issue which we should look at. To conclude, early breast cancer, TNBC 522 has proved the efficacy of Pembro and chemo in the neoadjuvant and perioperative setting. In hormone positive, HER2 negative data is evolving. There's increased PATCR, especially in the PD-L1 positive and the low ER. Is it behaving in the TNBC type early breast cancer? Adjuvant Atezo, I've spoken where probably you can think of, but there's no level 1 evidence for that. Role of immune checkpoint in patients achieving PATCR. Some data set is there which I showed you in the meta-analysis, but probably the trial which is being run with Pembro will give the answers. In the advanced, IMPassion 130-31 data has been contradictory. Reasons we know. Pembro in CPS beyond 10% shows benefit. How to integrate TILs and other biomarkers into practice, which was the point of discussion in the morning, is something which is open for discussion. How to combine PARP inhibitors and other novel agents with immunocheckpoints is something, a research area again. And with more of immune checkpoint in the EBC, can we reuse them in select patients on recurrence and metastasis? Is something which again we have to answer. With that, I stop. Sorry for exceeding by 2 minutes. I stop here. Thank you.
Thank you, Dr. Sahu. It was really good overall view of immuno in breast cancer that includes triple negative as well as in neoadjuvant as well as in the adjuvant and metastatic setting. Any questions from audience? Any comment?
Yeah, please. Are there a subset of triple negative breast cancer patients who do not benefit from a neoadjuvant approach?
How do we predict them?
I think the forest plot tells you in the 522 all benefit. So you cannot choose now. The negative trial of Atezo did tell you that node positive probably do benefit more in terms of PATCR. I don't think there is anything beyond this in the triple negative scenario. I don't think I can answer that beyond that. I think in the panel, Sandil can take the question, what she spoke, if they have something else to add. I think it is all comers at this point of time as per the inclusion criteria of the specific trial.
I want to know, the interesting data on adjuvant Atezo.
Yeah.
We still see a lot of patients, node positive TNBC or large tumors, being operated and then sent to us. So would you now apply this data in your clinical practice?
Okay, I'll do 2 things here. Because you asked this, I had it in the second slide. It is again that is open to criticism because it's not a level 1. The trial was not bound to answer this. The patients in stratum A were those who were operated upfront, but only 20% of patient load in that I am brave. And what it showed that the hazards were not that good. The best hazards push came from actually the patients who were not achieved a PATCR post neoadjuvant chemotherapy. Those when given Atezo actually did benefit better than those who were upfront given it. With that caveat that it was negative for the primary endpoint and only positive for the OS. So that's why I told the probable patients without a level 1 evidence is someone who did not receive immune checkpoint, had a RCB 1 or 2, maybe 2. I'd probably reconsider it, but I will not push the patient because I don't have approval for that. So that's where I'll stop in this point.
Okay.
Thank you.
Last question, sir. So as a surgeon, how do you choose when you send to patient for neoadjuvant chemotherapy, which is PD-L1 negative, and one oncologist say, yes, we can start neoadjuvant with Pembro, and one is a no. So as a surgeon, what need to advise to the patient then?
As a surgeon, I'll advise you go to a tumor board and give it to medical oncologist. Let us decide. Sorry, cut jokes apart. So I think the entry criteria was very clear that in hormone positive, we have to start doing PDL1s. And the higher PDL1s should be one who we should push for immune checkpoints.
In practice, we have seen that not even the PD-L1 negative do respond very well also.
That is for triple negative.
I'm talking TNBC only, TNBC.
TNBC, I think it is only the clinical stage that would matter.
And from your presentation, you mean to say more extension of the immune is not required, right?
No, I didn't say that. I told the meta-analysis is concluded that with its limitations, the trial which is there in Pembro will give you the final answer. I think Sendil will answer a lot more questions on this in his...
Thank you, sir.
Yeah,
so thank you, Dr. Sahu. I think you're going to be swamped at lunch hour. There are many questions for you. So let's move on to the panel discussion. Immunotherapy in women's cancer. Moderator, Dr. Senthil Rajappa. I think I will request you to introduce the panelists, please.
Morning, everybody. Thank you, Jyoti, Viswas, for calling me here this morning. After that very explosive talk by Sahu, we will have a much more sober panel discussion, I suppose, because the panelists are sober. Let me call
so many answers should be given by Dr. Senthil. That's
then there
the
won't be time for
conclusion
the
is
panelists. Time is running out. Bhavesh, Sunu, Sudeep, Vashisht, Dr. Vinay Deshpande, Dr. Richa Bansal, Dr. Namita Pandey, and Saurabh.
Radhakrishna.
Pardon me? Correct. So people whom I know who well, I call by first names. People whom I don't know well, and women, for sure, with their full names. Okay, so I'm not going to answer any of Sahu's questions left unanswered, because that's not part of the panel today. Also because I thought I will discuss some lesser discussed issues in the panel rather than Keynote 522. I will not talk about Keynote 522 at all. Okay, so let's start with this case. So this is a 45-year-old lady, T2N1M0, carcinoma breast. ER is 4%, PR is 6%, HER2 is 1+, 76% Ki67. I will manage this patient like an ER positive, TNBC both. For people who like PDL1, the CPS is 35. Let me start with Dr. Vinay.
I refer this patient for neoadjuvant chemotherapy.
No.
And that's what I do in my routine.
That's not the
making
question. That's not the question. The question is, do you think this patient should be treated? No, as a surgeon.
As both. As both.
As both. Excellent. Very good. Dr. Namita.
I will agree with sir, as both.
As both. Medical oncologist. Sunu, we can start with you. You're sitting in the corner.
ER very low, PR very low. I think I would... and
how low is very low, Sunu?
So it's 4%.
4% is very low. How low is low? I'll come to that point in a minute, but I just want you to tell me how low is low based on consensus and clinical trials?
Usually if you have the Aldred score, so like something less than 2 or 3, I think I would consider it as a very low sort of...
Okay, very low. And low is?
Yeah, low and very low, I think. I'll use
okay, so you're classifying low and very low. Yeah. Okay, so for people in the audience...
consider it as a TNBC.
Okay, people in the audience, you'll be surprised to know that in clinical trials, people with less than 50% ER are classified as low. People with less than 30% PR are classified as low, not 10% and 1%. I also thought the way you thought, but that's not the way. I'll show you some slides to substantiate what I'm saying. So that's what low means, less than 50. Very low, maybe less than 10%. Very, very, very low, maybe 1%, right? Okay, never mind. Vasisht, what would be your approach? And okay, so Vinay, I sent to you for neoadjuvant. What would you do with this patient? What would be your prescription for neoadjuvant therapy for this patient?
So, sir, I would want to treat as neoadjuvant as a triple-negative breast cancer. I would definitely discuss role of immune checkpoint inhibitors in the neoadjuvant setting. Now that more and more data is coming of response in low ER positive, PDL1 positive patients of achieving a higher likelihood of a PAT-CR.
Okay.
Also would want to understand the eventual surgical planning in my decision making. Also would
okay,
want
so
to
let's
know
say this lady is breast conservable at this point in time. It's not big enough. So if at all you're doing neoadjuvant, it is more for other reasons, many of the other within
CR.
quote unquote.
And obviously, as I think
Okay,
Dr.
so
Deshmane mentioned, small points, sir. Also, as Dr. Deshmane mentioned, want to remember that this patient is ER positive. Often what happens is in our notes, we start writing TNBC and we forget to add eventual hormone therapy in the adjuvant setting.
Excellent. So this decision to treat it as neoadjuvant TNBC, these patients who had low ER were not included in any of the TNBC clinical trials. So your decision is based on your judgment, or is it based on what Sahu read out 10 minutes ago? Was it based on all these Keynote 756 and Checkmate 7 FL? Is this what is driving you to do that? Or do you think that irrespective of that, I would have treated it like 522? What would be?
I think, sir, it's largely based on the recent data of having role of immune checkpoint inhibitors in ER
even
low
though it's not
positive.
officially approved, do you think we should start using it in daily practice? Bhavesh, you also agree with Vasisht?
I think we, as he said, we will start with considering
Mike.
as a TNBC patient and
Start as TNBC, end as ER. Okay, never mind. That's easy for people here to understand. Start as TNBC and end as ER. It's fine to do it. I do it, so I'm sure some of you in the panel are already doing it. It's fine to do it. But Bhavesh, let me ask you this. Is PCR a good surrogate for EFS or OS in patients with ER-positive breast cancer?
No.
Because Vasisht now said that he is impressed with the PCR, and because of that, he's going to adopt this in daily practice, which is absolutely fine. But do we know that PCR is a good surrogate in patients with ER-positive breast cancer?
As of now, we don't know. In hormone positive, maybe in future we'll, once this data mature and come up with their overall survivals, probably yes at that time.
Okay, so Vasisht, back to you. PCR's surrogate for EFS OS?
Sir, I think we should now all agree that ER positive diseases are very, very heterogeneous. While in very high ER positivity, we never even bother chasing a PAT-CR. But in very low ER positive, high PDL1 patients, they would behave more like TNBC.
Okay, excellent. So we will move on. So the point is that if it's very low, as per Sunu's definition of low, we will treat it like TNBC. That's absolutely fine. There is some data that in patients with grade 3 luminal B ER, there is some weak correlation between pathological complete response and event-free survival, not overall survival. So I think it's fine. There is data to substantiate. If you want to treat this based on your judgment data, all put together as a TNBC patient to begin with and end as an ER-positive patient. So that's fine. We next come to this very important point. So I did make that point, 50% ER is low ER, and I've underlined that at the bottom of the slide. Okay, so that 50% is what is taken as low ER in these clinical studies. So Sahu again made this point during his talk. You see that the difference in PAT-CRs are actually driven by this patient set, which is less than 10%. As you climb to higher levels of ER expression, the delta for PAT-CR actually keeps coming down progressively. And also, when you read these bar charts with these divisions as quartiles, you have to read it as the next category has the previous category within, the following category has the next category within. So you shouldn't get carried away by these numbers as the way they are represented on these slides. So the point is, this less than 10% that I marked with an arrow, the delta is 27%. Less than 50%, you see a delta of 29%. Please remember that this less than 50 contains the less than 10 also. So it's a less than 10 that is actually driving the PCRs in the less than 50%. Less than 80%, there's a 21% difference in delta. But remember, this contains the less than 10, the less than 20, the less than 30. So whenever you read bar charts like this, please remember that you need to separate this into smaller subsets and make sure that you don't get carried away the way they are represented on all of these. The same is the case with PDL1. Again, Sahu pointed out he didn't have time. I'll take 30 seconds to show you that. I pointed out less than 1 CPS, 5% is the delta. If you go to greater than 3, it is 27%. But when you come to less than 3, it's 2.9. So this contains all the PDL1s that are less than. You go to greater than 20, less than 20, you see that less than 20 is 6%, greater than 20 is 52%. Now this less than 20 contains the 10, this 10, this 5, this 5. So less than 20 actually does not have any benefit. If you read this as all patients who have a PD-L1 of more than 10 have benefit, that's the wrong way of interpreting this data. Now, I would like to know what's more than 50% and less than 50%, what's more than 70 and less than 70, because I have a feeling that the PCRs are actually driven by that set of patients who have the highest PD-L1 expression. Lung cancer, less than 50, there's no difference. More than 50, there's difference. You could say more than 40 is also different, but if you look at the 40 to 50, there won't be any difference. So when this ultimately gets the approval, Saurabh, how would you interpret it? Because the FDA is not going to split this into parts as I have split it today. It's going to say all patients with more than one PD-L1 will end up benefiting. This is how the approval will very likely come. So how do you incorporate this into practice if that's what the FDA ultimately does?
Sir, I think probably higher the PD-L1, more is the response.
Correct. Which is the PD-L1 that you will probably take in practice to say to your patient, okay, you have a PD-L1 of X, so I am reasonably sure that you will benefit from this intervention, so I'm good. So this is not yet approved, okay, but tomorrow it will come, is what my feeling is with the results that we are seeing, because one of these studies has event-free survival as one of the primary endpoints. The NEVO study has EFS, the Pembro study does not. So if the EFS comes positive, super, we are done with the study. It's left to the clinician to break his head. So at what point PD-L1 cutoff do you think it would be reasonable to use it?
Even I'm not sure, because all the
I'm
studies
also not
now,
sure, so I'm just asking for a number.
It's less than 1, more than 1. So most of the studies now just
So it's
say
easy,
that.
less than 1, more for the more the merrier.
Yeah. Whatever is more than 1, you can give.
Okay. So let's say somebody has got 5% PD-L1 CPS, not percent, 5 CPS with an ER expression of 50. What would be your treatment for that patient?
That is a dicey question.
That's a dicey question.
But
anybody wants to take that? How would you now? Yeah, Vinay, I'll come back to you in a moment.
So I would be most comfortable with the PD-L1 of more than 10%.
Okay. So you're comfortable. It doesn't matter. We just don't know. I'm just asking for random numbers. Yes, Vinay.
Well, just a comment. You know, we keep saying, if you look at these deltas, you can say they're varying from 3 to 7. Now, how can we say that someone who's getting a 4% difference with the PD-L1 is not as good as the ones that you're giving chemotherapy for more than 1% benefit?
So we just don't know.
So it's a thing that you have to consider, that even if your PD-L1 or your score is not correct, what you're looking for is a difference in outcome. So if you're likely to get an outcome difference which you consider significant in your practice, very often they say less than 3% you can consider avoiding, 3 to 5 you discuss, and more than 5 you give. That's one of the things also which comes up. And some of the guidelines, more than 1% you start giving the treatment, or you start considering the treatment. So if you're getting a 4%, 3% difference, you have to consider it.
But is a 4% difference in the PCR significant? That's the question in an ER positive patient, because even in triple negative it's not significant.
PCR, well, let me come to that other thing.
You're talking about event-free survival or PCR?
I'm a surgeon. So I say PCR doesn't matter.
Yes, good. I'm glad you made that point.
The reason is because there is still no data which shows that if you give neoadjuvant chemotherapy or neoadjuvant treatment versus adjuvant, your survivals are different. The day you have that, you know that PCRs are so important. Of course, it identifies a segment of patients who are going to do well.
So I finally didn't understand what the point you were trying to make.
What I'm saying is that we are crazy about PCRs.
No, I'm not bothered about the PCR. The point I'm trying to make is that a lot of patients may not actually benefit. When you get the approval for the whole cohort of patients, how are you going to dissect this out and then say, this patient is more likely, this patient is less likely to benefit? That's the point I'm trying to drive.
Well, you have a delta there, so it's giving you some idea of the benefit that they're likely to get.
That delta is terribly poor for us to accept, is the point I'm trying to make.
That's right, but that's the way it is going to be practiced.
That's exactly the point I'm trying to ask. The point I'm trying to ask is, with that kind of a small difference, is it worthwhile using that intervention? We will come to that point a little
One
later.
last point, because it's quite important clinically. I think we need to, when something like this comes up, you have to spend time with the patient. And the question then comes up, are you willing to spend the time in explaining the outcome? Then the patient can make the decision.
Point well taken. But before you confuse the patient, we have to have some clarity within ourselves, which we don't have at this point.
Once you have a delta, you have clarity.
And then I will give you some more confusion to add to that. Now, CDK4/6 inhibitor is part of this confusion, right? And there is data to say that CDK4/6 inhibitors have some negative interaction with immune checkpoint inhibitors. The incidence of pneumonitis, the incidence of hepatitis is higher when you combine these two. Should not be further developed, does not warrant further evaluation, and does not support further evaluation. So you added one more problem to the variable. Our problems in ER-positive patients are at what ER level you want to use it, what PD-L1 level you want to use it, how long you want to use it, what's the end point, and when it comes to CDK4/6 incorporation, there is some data to say that it might be toxic, and so then the question comes, when do you start the CDK4/6 inhibitor after completion of the PD-L1 inhibitor, and so on and so forth. So I leave you with those thoughts. These are the ones that you have to look for when ultimately the approval will come, which I think will come in the next 6 months to a year. So these are the points to ponder about before incorporating that into practice. So that's about the role in ER-positive breast cancer. So we move from breast to endometrium. Endometrium was such a simple disease to manage. There was no treatment except paclitaxel and liposomal doxorubicin. Now it's become the most complicated gynec malignancy to manage. 45-year-old grade 3 endometrioid carcinoma of the uterus. Adequate staging is done. Pathological stage 3C. P53 is wild type, MMR is deficient, POL is wild type, ER/PR is positive, germline testing was negative. So it's a MMR deficient endometrial cancer. Treatment choices. Sandeep, these are the choices for you. 6 paclitaxel, 4 paclitaxel plus pelvic radiation therapy. Number 1 or number 2 with 1 year of pembro. What would you choose? Oh, Saurabh, I'm sorry, I said Sandeep. Yeah. Or Sandeep, whichever, whoever is there. Oh, I'm sorry. I'm so sorry. Okay. Saurabh and then Sudeep.
Sir, either 1 or 2 with 1 year of pembrolizumab.
1 or 2 with 1 year of pembro.
There will be DFS benefit.
DFS benefit. Saurabh?
Yeah, agreed.
Agreed.
Sir, 4 cycles of paclitaxel and radiation. Well, I'm itching to use pembrolizumab in MMR deficient adjuvant setting.
Okay.
We need OS data in the adjuvant to really add value.
But there are so many interventions we use only with PFS or EFS data. Why are you partial to this?
Yes, sir, because there is some surrogate marker, like we're chasing a PAT-CR. Before the Keynote 522 data came in, the OS benefit, we were chasing a PAT-CR, believing that in triple negative PAT-CR will at some point of time translate into better survival. Pembro, MSI high, yes, enough evidence in metastatic setting. I, in my personal opinion, still feel we are not there yet in the adjuvant setting. Maybe soon, once the data becomes more robust, with the newer trials setting in, it may become standard of care. But today,
so you're not convinced with whatever is there in your screen. Doesn't matter. Dr. Richa, would you push your medical oncology colleague to say hazard ratio is 0.31, superb numbers? That's as much as you get with olaparib in patients with BRCA positive high-grade serous ovarian cancer. No overall survival benefit yet, but we use it for 3 years. Vashisht has said that there's the same hazard ratio here, though this is a subset analysis, but Vashisht does not want to use it. It's okay. What would you say?
So I think I'll leave it
closer?
I'll leave it to them to decide.
Wow, lovely answer. The most diplomatic answer.
Once the surgery is done, of course,
your job ends there, you're saying.
So I think, yes, there is upcoming data.
Okay.
And
no, you're not going to get a study of patients with MMR deficient only. So this is the kind of exploratory data based on which you will have to end up informing.
Subgroup analysis in MMR deficient have shown some benefit in pembro.
Okay.
And I think they are all very comfortable using pembro in metastatic and advanced cases.
Fine. So you will not push
probably
Vashisht to do it.
if they want to extend the indication towards adjuvant.
But it's okay if you don't. Sunu?
Yeah.
I think I would go ahead to go with Vashisht because the data is still too mature, and I think the overall study also, all comers, I think it should not show any major benefit also.
Or could it, if I just make another point to support both of your arguments, that these patients do well in the metastatic setting if we treat them with pembro, and then you can salvage them. Would that be one of the reasons to say
no,
it's okay?
no.
Oh,
That's
no, not that
not.
reason? Okay, go
Salvaging after a relapse might not be always possible.
Okay.
So
that means you would want to use it right away.
Grade 3, like what was said, my hands will each might be in another 1 or 2 years, it might change the practice. But as of now, grade 3, we will go ahead with the standard.
You're waiting for some more data to change
Yes.
practice. Okay, never mind.
Grade 1 and 2, certainly no.
Okay.
So I'm just thinking a little bit one step ahead. If the OS comes the same for both the things, whether it is metastatic or in adjuvant setting, where will we use it? Should we use it in adjuvant or should we use it in
So
metastatic?
I'll just make a small point because we'll run short of time. When you use it in the metastatic setting, with whatever immune checkpoint inhibitors data that is available as of today, the first thing that you see is that 30% of patients don't benefit from intervention in the metastatic setting. I'm not saying that they will benefit here. We just don't know who are those 30% patients who don't benefit when you use this in the metastatic setting. And that's across all MSI indications. Colorectal cancer, single agent pembro, 30% will drop. Endometrial cancer, 30% will drop. So as Sunu rightly pointed out, 1/3 of patients who relapse cannot be salvaged with immune checkpoint inhibitor in the metastatic setting. So when you're reading this data and trying to look at applying it in day-to-day practice, though we know who is the one who will benefit, which MSI benefits, again, there's data to say that irrespective of the mechanism of MSI, all of them equally benefit or don't benefit. Okay, so we don't have something to say that if this antigen is lost and that's MMRD, they benefit more or less. If it's Lynch syndrome, they benefit more or less. There was a time when we thought Lynch syndrome patients benefit better compared to not. But there's more data now from 4 studies to say that that's probably not the case. Madam, you wanted to make a point.
That's the point I wanted to make about the mechanism of MSI, that is Lynch versus hypermethylation. So there's this publication in Cancer as well, where they have shown that the Lynch syndrome, almost 100% would benefit, but the non-Lynch, it would be much less. So I think it still holds true.
Correct, madam, but I think there's now data in urothelial cancer, there's now data in some other cancers that though Lynch syndrome may have a tendency to benefit better, I have a couple of patients with Lynch syndrome where I've used single agent pembro. First evaluation, they just progressed. I've used Nivo and EP after a period of time again in these patients and they seem to benefit. So again, the question of single immune checkpoint inhibitor versus dual immune checkpoint inhibitor, I think there are a lot of intricacies in that. But the general point that I'm trying to make is that at least in endometrial cancer, there doesn't seem to be a big difference. 30% of patients will drop down. I think that's the point. That's the broader point.
The
Yes,
forest
doctor.
plot showed that higher stage do benefit in terms of the hazard ratio. So this kind of patient would be a candidate to add the immunotherapy.
Correct. So that's exactly why we are discussing in this panel, because some have a difference of opinion. That's fine to have because this is purely based on a subset analysis. But the point is that you're not going to get a big data set on patients with MMRD only. You will get, subset analysis from multiple studies showing that you will benefit. You don't even see a p-value there. So that clearly shows it's exploratory. But that hazard ratio is too good to really ignore in your patients. At least for me, I've started using immune checkpoint inhibitor in the adjuvant setting in most situations, not necessarily in endometrial. I have a patient with gallbladder cancer whom I'm treating now. I have a tendency to use it early, but I'm not saying that everybody sitting here and there should be doing that, but that's been my tendency because I fear that salvaging these patients in the metastatic setting may be a little bit of a challenge. So that's where we are. So here is something for us to again ponder about. Third case, 45-year-old stage 4 high-grade serous endometrial cancer, inoperable peritoneal disease and non-regional lymph nodes. So we sent it to Dr. Richa and she sent it back saying no surgery at any point in time for this patient. P53 mutant, MMR is proficient, the pole is wild type, ERPR are positive, HER2 is negative, the PD-L1 is positive. Okay, so it's a high-grade serous endometrial carcinoma. These are your treatment choices: paclitaxel, followed by, immune checkpoint inhibitor, followed by maintenance IO. The same with olaparib. Lenvatinib pembro, I don't think immunotherapy has a role. So, Bhavesh, let me start with you.
So I think we can, all the options are correct up to 3.
All the options are correct up to 3. Okay.
Maybe if we want to go by practice and maximum experience, lenvatinib pembro.
Lenvatinib pembro, first line.
This is first line. Sorry. So, the first option 1 would be better.
Okay, so I think Dr. Jogama, Nikhil showed this leap. He didn't talk about leap in the first line, he talked about leap in the second line. So you want to... Sudeep.
Pembro was second line.
Second line.
After
so
progression with taxane and platinum.
Is there data for Lenva pembro first line?
I don't know.
You don't know, doesn't matter. Okay. Sunu? Lenva pembro first line because looks easy, non-chemo combinations, patients will love it.
MMR proficient first line, I would go with chemotherapy, one of the options with the chemotherapy.
Okay, so paclitaxel versus lenvatinib pembro first line study is a negative study. There is no improvement in AFS or OS. So lenvatinib pembro is post chemotherapy only for patients with advanced endometrial cancer. So the first line data is negative. So LEAP 001 is negative, published mid last year. So between choices 1 and 2, Sunu, you want to take it? Choices 1 and, okay. Yeah, go ahead.
I think the DOE, I'll go more with that.
DOE, you want to go with DOE. Why do you want to go with DOE? DOE is on your screen.
The PDL1 is, I think, 10%.
PDL1 is positive, but this is not PDL1 tap. Okay, so PDL1, for people who are not familiar with PDL1, I'm sure there's nobody sitting in this room who's not familiar. Bharat, you want to sing a song?
I would like to add one question.
That might be better than this drab.
I'm more of a conservative precision oncologist. This patient is ERPR positive. Say it is highly expressing ERPR. That one more information I would like to add. And I do
so what's
use
the role of ERPR in patients with high-grade serous? So what is the role of using hormone therapy in this patient?
Only after might be second line or so.
Okay, only after the nth line of treatment you will use hormone therapy because these patients, though may express ER and PR, they generally don't respond well to hormone therapies. It's the endometrioid low grade that typically respond well to hormone therapies. Even the high grades don't have such great response. Okay, thanks for making that point. Yes, so here is the DOE in front of you. So for people who, all of you know PDL1, there's CPS, there's TPS, now there is a TAP, TAP. Okay, don't ask me what TAP is. I try to keep, memorizing what TAP is, but I forget it. TAP is another complicated way of measuring the PDL1. It's used in biliary tract cancer, and the other place they've used it. Only with durvalumab they will use it. They want to be unique, it looks like. It's not easy to do. So the PDL1 that was used in this was TAP. So I'm just telling you CPS. Okay, so there's a problem there. Anybody else who wants to do DOE? Or if you don't want to do DOE, please tell me why is that you don't want to do DOE? Okay, so DOE, just to summarize, is a trial that randomized patients to paclitaxel, durvalumab, durvalumab, and olaparib. Okay, the quadruple. Yeah, go ahead.
So I think, sir,
I will come to that in a moment. We'll end with the BRCA probably.
Sir, I think in DOE subset, the population which seemed to benefit the most was the HRD positive on the tissue.
So we didn't have HRD results in DOE at all.
So there's a subset analysis of DOE?
HRD was not done, HRD was not done in DOE at all. That's the ovary.
DOO?
Yeah, DOO. OHO types. Sunu?
I think with olaparib, Durva plus olaparib would be my choice.
Durva plus olaparib. Okay. So,
small point to make. Sir, if you look at the Durva plus olaparib arm and the Durva, and I feel the benefit seems to be more coming from olaparib than with durvalumab.
How do we know that?
Arm 2 and the arm 3, sir,
okay, so let's ask another basic question. So here is the trial design. The primary endpoint here is CP plus Durva versus CP. CP plus Durva plus olaparib versus CP. CP is carboplatin and paclitaxel. What all of you are talking about is an exploratory endpoint which is not powered to answer the questions that all of us would like to know, which is, what is the additional benefit of olaparib over durvalumab? Is it durvalumab that's doing most of the trick, or olaparib is adding to whatever is being done by durvalumab? Is a question that this trial is not designed to answer. At least the statistical power is not there for you to get the answer to that particular question. And that's why I'm asking you this all over again. So Sunu, go ahead.
So my thought would be more related to the serous histology, where sometimes we tend to treat the serous uterine similar to the serous ovarian also. Explorating from there, I think that might be the reason why I'm a little bit inclined more towards adding olaparib also to it.
Very nice. So I think 2 points were made. One is, so based on the statistical considerations here, this is not a trial that will answer the question that we are trying to answer here. So that is a given. So there is something that is driving a subset of patients to benefit from olaparib, whether it's the point that Sunu made, which is the fact that serous carcinomas tend to have a higher likelihood of benefiting from the addition of a PARP inhibitor, or the point that Vasisht made, because serous carcinomas have a higher likelihood of having HRD positive. Both of these are things that we don't know based on the study that we are actually discussing, right? Though numerically there seemed to be a benefit for the addition of olaparib or for the quadruple therapy that we are actually discussing here. So again, the point is there seems to be some data that is trending towards the fact that olaparib might actually add, but we don't have a conclusive answer to that question, at least based on the DuoE study. Yes, Dr. Richard.
I just want to ask, would you like to do HRD testing to triage your patients?
Would you like to do HRD testing, Bhavesh?
So even if we do it, currently we don't know how to use it in endometrium.
No, he said that if the HRD is high, he will be tempted to use it. Okay. Yeah, good.
So very quickly, I think, sir, now HRD is, sooner I feel it will become a tumor agnostic marker of response.
It's a tumor agnostic marker?
I feel it would become sooner or later.
You feel it would become. Unfortunately, that's not the case, Vasisht. So the HRD is one of the most complicated things. The median HRD scores for, if you take a 25 tumors, are totally different, one tumor from the other. And the cutoff at which you're likely to get a response to a PARP inhibitor is absolutely different for each one of these tumors. So you can never say Myriad my test 42 for endometrial cancer is the same as ovarian cancer, is the same as lung cancer. All of us think HRD is likely to be a tissue agnostic marker, but at least based on the evidence that we have today, it is not a tissue agnostic marker. So you may ask for a HRD score, but Bhavesh is in a way right. Is this score likely to predict the benefit to a PARP inhibitor is something that we just don't know at this point in time. So don't do that HRD score that is being offered free of cost and then say, I want to use olaparib. You're not totally wrong, but you've got a high likelihood of being on the wrong side. Okay? So we'll stop there. These are my conclusions. In case you're confused, in breast cancer, you may benefit from an immune checkpoint inhibitor in ER that's low, and in my opinion, a very high PD-L1, that be a percentage of patients, antibody cutoffs, all of these things will matter. We don't have any event-free survival data yet. There is a lot of toxicity with CDK4/6 and immune checkpoint inhibitor. How you will sequence and incorporate this will be a challenge. Endometrial cancer, addition of pembro to pacli-carbo improves PFS. This is exploratory data, but I think you won't get a bigger data set to incorporate it in practice. You'll have to work through this. Improved overall survival in advanced disease with addition of immune checkpoint inhibitor, but this is not Lenva pembro, this is chemo plus an immune checkpoint inhibitor. Exploratory analysis shows better activity for immune checkpoint inhibitor plus a PARP inhibitor along with chemo. Again, not powered to statistically answer that question, but there seems to be some biological reasons for that happening, especially in high-grade serous. We didn't talk about ovarian cancer for what of time, but there's some positive data for dostarlimab plus niraparib. We will wait for the readout, but the GSK website says that the trial is positive. So with that, I will stop. I hope you had some points to carry back home today after this panel discussion. Thank you so much.
Thank you. Thank you, Dr. Santhil. I think that last your slide, otherwise we all are confused. But thanks for your last slide.
I was so sure of
In
that.
that last slide also, there will be may benefit and there will be a wait also.
So
we will definitely wait for your next 7th
Panel discussion.
I-OSICON plenary session. Thank you. Thank you all the panelists, thank you moderators, and thank you speakers.
Thank you, sir. Thank you, ma'am. Now we proceed to our session 2 with combinatorial therapy in the IO era. I would request our chairpersons, Dr. Sameer Kaul, sir, he's a surgical oncologist from Delhi. Dr. Saroj Das Majumdar from Bhubaneswar, he's a radiation oncologist. And Dr. J.K. Singh, he's a radiation oncologist from Patna, to kindly come and chair the next session. I would also request everyone to please take the questions at the end of the session so that we can be on time.
Good morning, everybody. Thank you, organizer. I am Dr. Saroj Das Majumdar. The next speaker is none other than Dr. Rakesh Jalali, radiation oncologist, who is well known in India. He is respected. He has worked more than 30 years and has more than 300 publications to his credit. He will be talking about emerging role of immune checkpoint inhibitors in replication repair deficiency driven CNS tumors, including his institute experience. Thank you, Dr. Rakesh. Please go ahead.
Thank you. Thank you, Dr. Malhotra, for making me feel taller. I'd like to begin by expressing gratitude to the organizing committee, but more importantly, I just feel so thrilled and enthusiastic to being part of this beautiful journey of the Immuno-Oncology Society of India, being right there from the inception and how it has evolved over a period of time. Every single new conference brings some more energy and enthusiasm and participation. So today I'm going to speak on slightly different topic on CNS tumors. We have a fair amount of data in other tumors, but CNS tumors are always very difficult because we have realized with great trepidation, with great disappointment, so much effort, so much resources, investment in high-grade gliomas, and you see a series of negative trials, unfortunately, over the last 10 to 15 years in this group. And there's a bottom slide which is very, very sobering and very disappointing and humbling that so many thousands and thousands of patients, hardly any positive trial. Like everyone else, we had also a great enthusiasm on using checkpoint inhibitors, and 2 studies in particular, both one in the recurrent setting was a negative study, Checkmate 143, and using different combinations, PD-1, anti-inhibitors, the CTLA-4 blockade. But also then we thought newly diagnosed glioblastoma, particularly unmethylated, assuming that they will have a slightly unstable genome with high MSI, but unfortunately that was negative too. And one of the reasons is CNS tumors are traditionally thought to be immunologically cold, have relatively low tumor mutation burden. The MSI is not very much well understood. But the neoadjuvant anti-PD-1 immunotherapy, there's a completely changing strategy now. That instead of doing resection and then using an adjuvant, can we just take a biopsy, use the neoadjuvant immunotherapy, and then use the conventional adjuvant strategy? And there is some very interesting data on it, and this has to be borne. These are exploratory proof of the principal studies, but it has to be borne in the clinic. And also different strategies, for example, intratumoral, because of the blood-brain barrier, the microenvironment, how to overcome it is to use the intratumoral viral therapy. And IDH, which is a mutant glycogenesis gene in many tumors, there has been a lot of effort to identify a vaccine against it. So we were, in general, in neuro-oncology throughout the world, including in our practice, we were not so much kind of cognizant about this phenomena until about 2 or 3 years ago. We saw a case, 40-year-old male in our clinic. Surgery was done. It was actually called outside as a metastatic from something very weird tumor. But when we looked at it, Ki-67 was very high, but it was a classic glioblastoma. You couldn't argue. It was all the bells and whistles of histopathology. The MRI findings were classic glioblastoma, IDH wild type, ATRX retained. But MGMT promoter was methylated, assuming that's a better survival. But then we do now routinely the MSI panel and found out there was a loss of MSH2. We have a dedicated genetic program now in the Proton Cancer Center, so we did the somatic NGS, but also did the germline whole exome sequencing and found out this was actually a Lynch syndrome. And obviously they did the genetic counseling and so on and so forth, and this patient is doing very, very well now. And we gave a conventional proton therapy, but then we put them on Mempro and CCNU. Mind you, we didn't use the temozolomide in spite of being MGMT promoter methylated, and I'll just come to it in a minute. And then so far, we just saw him last week actually, he was doing pretty well. And then this was the beginning of the, in our setup as well, that there is the RRD is also there in gliomas. We know the Lynch syndrome, of course, when the replication enzymes are proficient, but then of course you have the RRD, both the constitutional but also the polymerase proofreading deficiency. And this was a very good thing. We know in other cancers, we know the TMBs, we know the hypermutation, we know the hypermethylation, the hypermutation, and we also know that they are resistant to conventional chemotherapy drugs, including temozolomide in gliomas. And there is, therefore, we are looking at other alkali-aging agents like the lomustine, but also looking very, very, very meticulously about the PARP inhibitors to combine as a strategy to overcome this mechanism, which traditionally they don't respond to chemotherapy. Now, that also gave us the idea that to use immune checkpoint inhibitors for this because of the unstable genome, and that has been seen in many other sites. In non-neurological advanced cancers, in rectum, colon, and many other sites, it's very well known, but there was not much known in terms of gliomas. Until this was the first seminal publication in JCO a few years ago. It was done from sick kids from Toronto, Dr. Buffet's group, where only 2 patients with CMMRD, they showed exquisite response to immune checkpoint inhibitors, and that sensitized the neuro-oncology community that there might be something to gain in spite of being all the negative studies that we had seen so far. The million-dollar question, of course, is how common is it? And there is wide range of data sets that are available that as low as nothing, 0% in peds. I've just highlighted a few of them, and to as high as 35 to 40%. So there's such a wide range as to, it depends upon which population that you, and also it depends upon the sample size that you take, whether you take peds only, the AYA population, the adults, and the very old. So all these factors matter in this cohort. But there was some interesting insights, at least in pediatric gliomas, who are actually leading the front. And again, Anirban Das and Eric Buffet and Uri Tabori from Sick Kids as a collaborative effort. Only in 10 patients, 9 patients had a relatively high TMB, 7 were malignant gliomas, 5 being GBM. 4 of these children with refractory malignant gliomas were complete remission more than 3 years, which has never ever happened in this set of patients. So this was again a proof of principle study as to there might be something about RRD-driven pediatric gliomas and how we can incorporate it judiciously in our own practice. That also led to a global effort of, as many of you know, the IRRDC consortium, the International Replication Repair Deficiency Consortium, which is looking at the CNS tumors. And I'm happy to tell you that at least 3 centers in India, the Tata Memorial Center, our Apollo Proton Cancer Center, as well as the center in Kolkata, the Tata Memorial Center, are part of this effort. And this also sensitized to us, it's not only the pediatric high-grade gliomas, not the DMGs, the diffuse midline gliomas driven by the histone or the G34 hemispheric gliomas, but also the H3 wild types and IDH wild type gliomas, but also could be seen in medulloblastoma. As a matter of fact, this week only we saw, I think, our first case of sonic hedgehog-driven medulloblastoma, P53 mutant, had a small little tumor in the supratentorial medulloblastoma being posterior fossa. We thought it was a MET, but it turned out to be a high-grade glioma, which was driven by the CMMRD, and we are confirming it with germline mutation testing. So at least there is a sensitization is coming up slowly in our clinic, because it can change the adjuvant therapies completely as compared to the conventional chemotherapy, and there could be a small cohort of patients which might benefit from otherwise what we have been doing for all these years. So we know that there could be the TMB, the MMR, IHC, but we look at the quantitative MSI burden, and as we know, there are different areas, the Lynch and the CMMRD, and also some area about the germline pole mutation. This is actually one of the finest pieces of work. We just came this month in the Lancet Oncology. It's a collaborative international effort of about 1,400 gliomas. And for the first time now, we have realized that there indeed is something to it, because now it is a slightly tightly packed, tightly controlled environment of the clinical data sets. And now it has been seen that as about 3.7 to 12.4% of our high-grade gliomas could have primary MMRD. And there are some interesting differences between if you treat with ICI versus no ICI in the pediatric and adolescent and AYA population as compared to the adult populations with the Lynch syndrome. And you heard some discussion about the responses in the Lynch as compared to CMMRD, and that has been our relatively modest experience in gliomas globally, but also a little bit in our own center. So in overall, the immune checkpoint blockade was associated with improved survival for patients with primary MMRD as compared to conventional chemoradiotherapy, with very, very encouraging hazard ratios and p-values. Now, essentially, there are 3 subsets identified in gliomas, and this is the IRRDC report, which was only in an abstract form in the ISPNO a few months ago. And the RRD1 are the MMRD plus the PPDs. The RRD2 is exclusively MMRD. But we have identified now the RRD, which can be driven by IDH. Now, IDH is exclusively seen. So far, we had thought that it was only in the adults, pediatric gliomas. In fact, some of them we even don't do IDH, because we don't think pediatric gliomas ever would have IDH mutation, until we got a child of 9-year-old female child, born to a co-sanguineous couple, which is an important finding, and was actually from Kerala, but was settled in Dubai. They came to us about a year ago, presented with multiple episodes of focal seizures, had this multiple kind of a gliomatosis picture. And what was stunning was that IDH mutation came positive. And I couldn't believe it that a child of 9 years would ever have IDH mutation. But we reconfirmed it. We did the Sanger sequencing also to prove it. And then it told us, man, maybe we should have the hereditary cancer gene panel, and turned out to be a CMMRD. So it completely changed our practice. We didn't give temozolomide to this child. This was the preoperative picture. The postoperative was only a biopsy. We gave the radiation with proton. She did very well. Post 6 cycles of ICA, it was responding beautifully to pembro only until about a year ago, when there is again one of the tumors has increased. And now we are thinking of re-resecting, although the other tumors are well controlled. So the question is, this is an IDH mutant tumor with a CMMRD, responded very well to the first line of immune checkpoint inhibitors, what to do. And the story started with the seminal paper again in the NEGM in August, where first time ever we found a targeted therapy, vorasidenib, in IDH mutant gliomas. And clearly, quickly, again, the group from Sick Kids in an abstract last year have tried to show that maybe we could use the IDH inhibitor now. And gratifyingly, there is some funding available, and we are already putting this case in the international funding that where she will get vorasidenib free of cost, because it's a very, very expensive molecule. And because the preliminary data set, although it is not a full publication as yet, it seems that if you use the IDH inhibitor, it did prolong the survival as compared to with not. So maybe in future, There could be a combinatorial therapy in this regard. Although, mind you, we have to be very careful that if you do too many things together, targeted, and we have realized not in so great encouraging things, that it can be counterproductive. But so far, it seems that even if you have a subset of patients with IDH mutant gliomas, that could be done. This also highlighted the effort in our other low-middle income countries. There are data sets available in different forms, both in publications as well as in abstracts from other centers, Tata Medical Center in Kolkata, All Institute of Medical Sciences, our own group, and also very nice publications in the Journal of Global Oncology last month, or maybe this month, from our colleague Noreen Mushtaq from Pakistan, where she put an effort for the 7 years and has also been participated in the IRDC group. But every case doesn't do very well. This is another patient I wanted to highlight, 26-year-old, few episodes of GTC, diffuse again picture, especially in young people less than 40 years of age. MSH loss was there, confirmed on both the germline and somatic mutation. He was put on immune checkpoint inhibitors, withdrawing temozolomide, but did not do well at all. We put him on CCNU. Within the next 6 months, there was a massive recurrence, and in spite of our best efforts, the patient is not doing well. So therefore, it also highlights that everything may not be dual, so it's a lot of work and effort needed. How to combine Nivo and EP, what is the sequence of events? Should we still do the local therapies like radiation, or should we give in the new adjuvant setting for these patients? And the CNS being a kind of a different organ as compared to others, these are the questions that are being asked in different parts of the world. It is also important perhaps to recognize the microenvironment, as we discussed in the morning, and several groups are trying to identify, for example, lymphopenia, and we know the data on the lymphopenia because lymphopenia is an independent negative prognostic marker in such situations. And charged particles, for example, can minimize the treatment-induced lymphopenia and can also be very beneficial because many of these patients are going to use immune checkpoint inhibitors. We were lucky to get this publication in a major journal, the Immuno-Oncology Advance, which is our main journal. And we found out the proton therapy in particular, because the volume of the normal brain receiving the radiation is significantly lower in these gliomas, and protection of the lymphocytes has an impact of early signals of improving progression-free survival. And we are putting now in a prospective manner to study it better because this was a retrospective effort. So in summary, right on time, historically the data on immunotherapy was not very promising, but at least a small subset cohort of replication repair deficiency gliomas is a separate entity with distinct clinical profile. Actually, may I also say, it has also a different imaging characteristics. On imaging only you can tell on MRI, this is likely to be having an RRT deficiency, and we are working on it as an imaging biomarker because sometimes very difficult to biopsy all these lesions. They could have a high mutation burden. They may respond to immunotherapy. We should routinely now, Dr. Jins, who is sitting in the audience, has a poster tomorrow. We are putting up a prospective trial in the Apollo Proton Cancer Center, but also is going to be discussed in the ISNO meeting in April, the Indian Society of Neuro-Oncology meeting in Dehradun, where there will be a separate 2-hour session on it, and we have Dr. Anirban Das coming from Toronto. Routine screening should be done for repair deficiency. Recent evidence shows that if carefully selected patients with RRD could benefit from immuno. Local therapy, fortunately, is also evolving to adapt to the immunotherapy with charged particles showing maximal promise. But the most important factor is from the science and the data, needs awareness. Neuro-oncology, immuno-oncology communities have to come together, both clinical basic translation on a global collaborative platform. As compared to breast cancer, endometrial, there are millions of patients out there. Glioma is a very small subset of patients, and only with global collaborative effort, this will lead to some fruition. And we are hoping with societies and forums like this, we try to bring at least a small set of patients better outcomes, as has been historically our experience with. With that, I thank you very much for your attention.
Thank you very much. Thank you, Dr. Rakesh Jalali, for this really your experience and new thing in RRD and CNS tumors. I am told the questions will be taken at the end. So may I request our next speaker, Dr. Ranjit Bajpai, radiation oncologist from Mumbai. He is involved in research and patient care for last 20 years. He will be presenting on advances in radiation oncology in the era of immunotherapy. Future is here. Thank you, sir. Please go ahead.
Thank you so much. I'm really happy to be here. First, I would like to thank Dr.
Ghanshyam, the local organizing, to invite us to this temple city of Bhubaneswar. I see a lot of teachers, Dr. Rath, and so many of you. I'm here to basically give the perspective from the radiation oncology, that how immunotherapy has evolved and the synergy, whether it has reached the pinnacle or still we are some point away from it. So I would like to start with this story. We all know about this, that how the blind men were fooled, or probably they've had their own perception about the concept. So when we talk of synergy between radiation and immunotherapy, we should know that not everyone has not the whole truth unless we see and combine and collaborate. So how it evolved? We know that roughly around about the time when the first experiment, successful experiment of immunotherapy was done with Kohli's experiment on sarcoma patients in 1893. Subsequently, Röntgen discovered X-ray, and the next 30 years we have developed radioactivity and then the fractionation experiments. It took another 50 years to reach to the point where we first understood the abscopal effect, as we understand the remote effect of radiation, and another 50 years to first translate into a clinical benefit in a trial, when in around 2012 we've got the first paper. Subsequently, we've had this first trial with GCSF support in metastatic solid tumors, the abscopal effect, which is nothing but the remote functioning of the radiation apart from the loco-regional benefit. And as we know that in the last 5 years or 6 years, we have significant progress in terms of usage of radiation along with immunotherapy. So there has been a lot of promise as been explained with both immunotherapy and radiotherapy, but and where we know that the radiation can act as a vaccine, as a module to release the tumor-associated antigens and stimulating the immune system against the tumor, thereby potentiating the effect of the immune checkpoint inhibitors. But recently we have seen some conflicting clinical results on the benefits of combined radio and immunotherapy, which could be related to the difference in the treatment sequencing. So after the successful results of Pacific trial, we've had number of trials, particularly in head neck cancer, where it was expected they will have some really good results, where they failed to meet their primary endpoints and probably was sort of a setback. So what is the need of talking about this radiation along with immunotherapy? We understand that immunotherapy may have some immunoresistance developing when in course we go, and naturally we want to have durability of response with immunotherapy. So here, this important paper talks about the intrinsic and the extrinsic mechanism and the pathways wherein we can have this immunoresistance, which could sort of inhibit the sort of responses where it will not sort of get the durability of the responses. So how radiation works? There can be non-immune effects, which is dose volume effect, of course, are less of a tumor burden for the immune system to work upon. We can have a direct DNA damage, the microvascular alterations, which can cause changes in the microenvironment and can again affect the impact of the immunotherapy. And the immune effects, as we know that, of course, by secretions of tumor-associated antigens, chemokines, the immunomodulation, wherein it can actually influence the immunoinhibitory effect of the tumor stroma, and the abscopal and the recently understood concept of radscopal effect. So here this important article which was published in 2022, which talks about all the details about how radiation works in the ecosystem of the cell and how it can influence both in terms of immunostimulation as well as immunoresistance, and understanding these pathways helps us big time in sort of going forward utilize radiation synergistically with immunotherapy. There has been immense interest in the understanding and sort of review of the abscopal effect, the synergism between radiation immunotherapy, and particularly we can see in last few years there's been a significant number of articles published in this area. What about the radscopal effect? So apart from, as we know, as we understand that a lot of trials highlighted on the high dose radiation, which can create this tumor cell kill and the elicitation of the immune response, it's the low dose also which helps us in altering the tumor microenvironment and can create, which can boost the effect
of radiation with immunotherapy. So sequencing, I think probably that's where probably the answer lies, that we have had many trials in the recent past which failed to achieve their endpoints, is to do something to do with the concurrent regimes. So where possibly there are few of the effects of the radiation along with immunotherapy, it is far more effective when used either as in a neoadjuvant setting or as an adjuvant setting. These are the few trials, in the different phases. And what I would like to highlight in this is the different endpoints which are used in these trials, including the maximum tolerance dose or the dose-limiting toxicity, the survival rates, and other toxicity parameters, including PFS. So they've all had in different stages, and naturally in the coming years, we'll have much clearer answers going forward. Like for CTLA-4 inhibitors, we have a lot of data from PD-1 and PD-L1 inhibitors. These are the important trials which are going on or have completed. So what is the randomized evidence we do have as of today, which tells us that where we are standing in this regarding? So we have two positive trials, the Pacific one, where the durvalumab was used in adjuvant setting for non-small cell lung cancer, which was a positive trial, along with Checkmate 577, wherein again nivolumab was used in an adjuvant setting, which has given us benefit. But there are negative trials, including the Javelin, the Pembrolizumab, and the Checkmate 546, where we know that the radiation, mostly when used in concurrent setting, has not given us the advantage which we are looking for. I would like to highlight these two important trials. So in head neck is probably one of the key areas where we would like to utilize the impact of the immunotherapy. So while IMVOKE 010 trial turned out to be a negative one, but very recently this Keynote 689 trial was shared and probably will be waiting for the full publication, where we'll see that pembrolizumab has achieved at least benefit in terms of PFS. So this one positive trial gives us a lot of hope that immunotherapy used either in neoadjuvant or adjuvant setting gives us that advantage which we are looking for. These are the FDA approved drugs as of now, bladder, lung cancer, and a host of other tumors. So, of course, we've had setbacks when we are looking to utilize impact of radiation along with immunotherapy. Pacific 2, which came after the sort of success of durvalumab in adjuvant setting, which failed to create the same advantage when it came to the concurrent setting. And there are a few other trials, as mentioned, which could not. So, was it a setback, and do we have the complete picture? So I would like to just try to come back to my initial story that yes, the blind man with the elephant, and what happened with the blind elephant. So yeah, one blind elephant thought, yes, man is flat. And of course, there was a concurrence with other blind elephant also. They felt that yes, the man is flat. But we need to remember that what we observe in nature is sort of reflection on what we are trying to observe or question, rather than what actually is our inference. So technology, in terms of technology, radiation, as we know, it's a lot about technology and how we are influencing it. So I would like to highlight a few of the key aspects, what sort of coming up in a big way, and possibly in the next few years, we'll have some breakthrough when it comes to utilizing radiation along with immunotherapy. So MR-guided radiation, which is already here, it utilizes a concept where we can have magnetic field modulated RT, where we can deliver the dose in sort of, and there are efforts where we can have heterogeneous dose deposition in the tissue, which could utilize the rat scopal effect to a good effect actually. Radiomics, it has been there for some time now, and we are having these imaging biomarkers to guide us how to sort of deliver radiation in a better way. Specially fractionated RT, these are the things which we keep on hearing more and more, where we are utilizing be it lattice therapy or the grid therapy, which was developed a long time ago. And now we have this immune-sparing partial ablative radiation, which again utilizes the same principle that we don't have to necessarily go on to develop mechanism of radio resistance while utilizing with immunotherapy. Particle beam, as we all know, it has different biological properties when it comes to linear energy transfer or RB, wherein the presence of oxygen sort of doesn't become a limiting factor. And since the damage is more, we can utilize these properties of particle beam to again have much better impact when utilized with immunotherapy. Flash RT is going to take it to the whole next level, wherein we know that there is comparison to say 0.5 to 5 gray per minute dose rate. We are going to have a 40 gray per second dose rate, which is going to have a whole lot impact, and it has been studied a lot. Along with that, these are the other highlighting features like multi-site RT or pulsed RT, where we know that it is not just one metastatic site which we need to treat. If we try to treat multiple metastatic sites with radiation, naturally it is going to cause much more stimulation of the immune system, which could be sort of then utilized in a synergistic way with immunotherapy. So just a quick word about Flash RT. So what Flash RT is going to, how it is going to change the way we practice radiation is not only the effect of a very high dose rate, which would not sort of have an impact on the circulating blood. And we've heard about the impact of lymphopenia or the circulating lymphocytes, which gets affected with radiation. So if the duration of the radiation, since it's going to be very short, it is not going to cause problem when it comes to the lymphopenia and the immunoresistance following that. So this is one of the important articles, and it has highlighted the technical areas, how it is developing. So one, of course, is the radiotherapy, where we try to use by reducing substantially the treatment time and the cost, but also it amplifies the damage in low dose region. Another technical area is to fuse it with immunotherapy and try to deliver substantially smaller amount of immunotherapy, which can naturally again impact lower toxicity. And these smart radiotherapy biomaterials, so conventionally we are used to use these fiducials, maybe titanium or gold. Now it can be replaceable with a solid or liquid SRB and then subsequently nano drones, wherein our capability to deliver these molecules inside the body, and there are experiments done on animals and preclinical studies, and now the trials are coming up, wherein they release these immunotherapy drugs in smaller amounts to have the best of the effect. Now about the toxicity. So this is one of the most important factor, and it has been highlighted in this one of the larger pooled analysis of over 25,000 patients, which was published from US FDA database 2 years ago. It basically highlights that, of course, there are a lot of variables in terms of what is the sequencing of RT with immunotherapy, but at least what they have highlighted is they could not find anything significant when it came to side effects in sequencing RT, and what they have looked for when RT was sequenced within 90 days or RT was sequenced in more than 90 days with immunotherapy. They have not found any difference, significant difference in terms of side effects. So what is the circle of progress? When we look at the ImmunoRad proceedings in 2023, this was one of the important point which was highlighted, that when we are going ahead, I think probably one of the key factors would be not only to play with dose and fractionation and trying to reduce the doses to the lymph nodes, along with the blood sparing, which will help us sort of reduce not only the side effects, but also reduce the chances of developing immunoresistance, different predictive biomarkers, and of course charged particles will change probably that significantly. So way ahead is, as I said earlier, with dose and fractionation, field design, the sequencing, how we do it, the healthy tissue exposure, and the charged particles. So in concluding, I would mention that to exploit the potential of what could be a very powerful combination therapy, we need to determine the right or optimum treatment sequence. And in addition to determining the most effective treatment sequence, it is necessary to identify which patients are most likely to respond to the combination of radiation and immunotherapy. And possibly the most effective, most difficult task was to find a strategy of treating these regional lymph nodes, because ordinarily we are the basic principle of radiation is to treat both primary and the lymph node with the same dosage. But if we can some way find a way to reduce the dose to the lymph nodes, it probably make a lot of difference to have a proper synergy. And of course, the trial design is crucial with clear inclusion criteria. Thank you so much for your attention, and this probably slide highlights the collaborative power and Konark Temple, of course, and looking forward to the trip to the Orissa in the day forward. Thank you so much for your attention.
Thank you, sir. I would like to now invite all the speakers and the chairpersons to kindly come on the stage, and please request any questions.
Thank you, Dr. Bajpai. That was a wonderful lecture. I must tell you that it's been fascinating. I'm a surgical oncologist, and I work out of the Apollo Cancer Institute in Delhi. It's been fascinating to live in a time when all this is happening. It's in fact scripted, and to be amongst scripting this history. It's nice. We weren't around when the chemotherapy happened, and that took such a long time. And now I appreciate it. Things happening, and immunotherapy linking up with sorry, I won't take a lot of time. So immunotherapy expanding on its own, its horizons, research, data, biomarkers at each step, and linking up with the other arms like surgery, combinatorial therapies that you're talking about, radiation, chemotherapy was already done. But the rate at which it is happening is fascinating. And one wouldn't have wanted to live in better times, because at the end of the day, it's delivering what we all owe to the stakeholder, which is longer survivals, better biomarkers, surrogate markers, and it's clearing up cobwebs. But any questions for Dr. Bhajpai?
I have a
who
question.
talked about radiation and whatever news happening in radiation. And of course, Rakesh's original seminal work out of India, very proud of that happening in our own country, where gliomas traditionally into the skull have been always excess inhibitory in terms of the hard skull around it and ways of getting at them and being sensitive areas. But a lot of work with RRD happening there. So very, very hopeful of one.
Can I ask a question, sir? Here.
Any questions?
Here. Can I ask a question? My question is to Dr. Jalali. Sir, can you get over there, please? So, what is your gut feel? As of just now, immunotherapy hasn't made big inroads in glioma. If it does, when would be the right time to give it? Before the surgery, radiation, during, or after? Whatever data we have for other solid tumors is that radiation expose the new antigen, then during and after is the time where it will work best. So what is your gut feel?
So that is a very difficult question, and people, traditionally we tried like other sites in the adjuvant setting, like the traditional, but it doesn't, all the trials are negative. I showed you one data set where in recurrent setting, if you have a relatively small tumor burden, you just take a biopsy, do all the markers, and if there is a good expression, you could use it in the neoadjuvant setting, and this was the work done from the UCLA group, which was very fascinating to us, changing the strategy. In gliomas, the trouble is that the large mass effect is there. Traditionally, we come with large tumors, many times they need corticosteroids, and that could be one of the factors also, and we also know the CNS being immunoprivileged, so as to speak, and how to overcome this is the difficult strategy. But I showed you some data sets that either the neoadjuvant setting, even the intratumoral, which was never ever thought of, that whether we could use the inhibitor there directly to incite the reaction. Preservation of the microenvironment is also very important, how to recruit the T cells out there, that's also very important. And I think I also showed you at least about 5 to 15 to 20%, and this will likely grow, at least the RRD-driven gliomas, both in the pediatric and AYA population less than 40 to 45. Although there also we are now facing the challenge, it's not that all cases would respond to ICIs. So what is the optimal way to do it? But there is a great deal of enthusiasm in neuro-oncology. And finally, the CAR also. You cannot disregard the cellular therapy. There is a fascinating data set in diffuse midline gliomas for children, which has been the ultimate barrier in pediatric neuro-oncology. So there, the CAR T cells are gaining a traction, and including we are trying to think to do something here also. So just wait out for the space, and I think even the traditional difficult gliomas, finally we might have something in the next 5-7 years.
I have a question for Dr. Sharma, if I may. In the context of enhancing immune outcomes with whatever we are doing, we haven't spoken about the microbiome, and could you enlighten us a little bit on that?
So thank you so much for the question. I think the microbiome has been shown in many publications, including from groups that the Anderson Genwargo's lab, and other groups, that they play a very important role in educating the immune response. And it's certain microbiomes, specific species of microbiome, contribute to the immune checkpoint therapy responses. And so that in certain settings, you can even select patients based on their microbiome, or maybe change the microbiome with FMT, fecal microbiota transplants, to improve the immune checkpoint therapy responses. Microbiome has also been shown to play a role in adverse events, so that in patients who are having severe colitis and these kinds of things, you can give the FMT to also help with the adverse events in that setting.
Now with this, we come to the end of this session, and thanks to both the speakers for the excellent deliberation, Dr. Rakesh Dalali and Dr. Bajpai. Thank you so much.
Thank you, sir. I would please invite our speakers and esteemed chairpersons to please come on the dais for a group photo. Thank you, sir. So with this, we come to the most important session of today, that is the I-OSI oration, that is by none other than our Dr. James P. Allison, sir. For this, I would like to please invite our President I-OSI, Dr. Hemant Malhotra, sir. He is medical oncologist from Jaipur, and the General Secretary of I-OSI and Chief Organizing Secretary, Dr. Jyoti Bajpai, madam. She is also medical oncologist, to kindly come and chair this session. Please, madam. Please, sir.
Cancer. The diagnosis of cancer sends a shiver down the spine of even the strongest of human beings. But hope is the only thing stronger than fear. The Nobel Prize should give patients hope. The 2018 Nobel Prize in Physiology/Medicine has been awarded jointly to James P. Allison and Tasuku Honjo for the discovery of cancer therapy by inhibition of negative immune regulation. Our focus today is James P. Allison, and cancer is not new to him. His mother died of lymphoma when he was 11, and his brother of prostate cancer in 2005. And that ignited a passion in him to cancel cancer. And that's been his personal crusade to combat cancer, a battle to beat cancer, and a fight to defeat cancer. Padmani Sharma, his beautiful wife, and both of them work at the MD Anderson Cancer Center in Houston, Texas. And these two people have shown us how, from the bench to the bedside, from the lab to the podium, you can be together throughout as a cancer-fighting power couple. This cancer-fighting power couple has been successful in unlocking some of the deepest mysteries of the immune system. Interest in immunology made them interested in each other. Covalent bonding continued, and this chemistry cracked the age barrier. and physical proximity permanently in 2014 when they finally got married. And 4 years later, you see walking them hand in hand. And that was when the Nobel Prize in Physiology/Medicine got announced in 2018. Inhibitory receptors on the cytotoxic T lymphocytes. Cytotoxic T lymphocyte antigen 4 or CTLA4 is also known as CD152, and this is an immune checkpoint. It downregulates immune responses. Checkpoints. CTLA4 and inducible T cell co-stimulator. This cancer couple has been responsible for the checkpoint blockade approach to cancer immunotherapy. As a pioneer in this field, Jim Allison has spent decades tackling major scientific challenges. It's interesting to note that Allison would consider one of the top 5 moments in his life jamming on stage with country star Willie Nelson. Yes, in addition to being a top flight scientist at the University of Texas, MD, SCC Houston, James P. Allison heads, owns, and is part of a musical band. You see here, he and his team is performing as part of this musical band. And you know what's the name of this musical band? It's called as the Checkpoints. What would you call that? Passion towards your profession should not change the position towards your passionate hobby. The Checkpoints, James P. Allison heads, owns, and is part of this musical band. In chess, you move silently and only speak when it's time to say checkmate. There are still a few tickets remaining to see Jim Allison and the Checkmates at the Firehouse Saloon Saturday night. So these are the kind of captions you see across various conferences, especially as part of ASCO. And that's where Jim Allison performs as part of the Checkmates, along with he and his entire team. The Jim Allison plays as part of the Checkpoints or Checkmates. You can see him perform on the stage to the extreme right in this pic. Let's have a closer look to see what Jim Allison does as part of the Checkmates or the Checkpoints. An even more closer look, or maybe a side look. James P. Allison rides a Tesla, and you know what's the number plate? ICOS. James P. Allison drives a Tesla, and the number plate is ICOS, in testimony to the fact that his wife Padmani Sharma identified the role of ICOS in immunology. And Padmani Sharma rides a Porsche, and the number plate is CTLA4. And that's what this cancer-fighting power couple teaches us. Passion towards your profession can reciprocate, can translate to possessive position for your better half. Thank you so much, and it's an honor to be able to introduce you to all my colleagues who have come to attend this prestigious conference. Thank you so much, and welcome all.
So thank you, Satya, for preparing. For unfortunately, who could not attend, so he made this because for last 6 months he has been preparing, he has been collecting. It's almost a research on that. So thank you, Satya, from I-OSICON 6th from Bhubaneswar. Thank you. Over to you.
So good morning, ladies and gentlemen. On behalf of myself, the current president of the IOC, and our secretary, Dr. Jyoti, we welcome you to this oration of the Immuno-Oncology Society of India, the 6th oration. And I'm sure that all of you liked the specially prepared video for you, and I can see very clearly that both Pam and Jim, they liked it. And thanks to whoever made it for the effort involved. We are very, very honored to have Dr. James Allison here in India, in Bhubaneswar, to deliver this oration. And I'd like to request Dr. Jyoti to very briefly introduce formally Dr. Allison. Informally, he's already been introduced to you.
So thank you very much. And ladies and gentlemen, it is extremely thrilling for me because, you know, we have been preparing for this day since really a while. And thank you very informally to Dr. Jim and Dr. Pam for really fulfilling this promise which they made with me, a while ago, really. And as Dr. Hemant said that, now this is time for formal introductions. The informal is already done, and I'm seeing that everybody is having a glitter and a smile, so they all enjoyed this. So very formally and briefly, I'm going to introduce Dr. Allison. So Dr. James P. Allison, the 2018 Nobel Laureate for Physiology or Medicine, has spent a distinguished career studying the regulation of T-cell responses and pioneering new strategies for cancer immunotherapy. Among his most notable discoveries are the determination of T-cell receptor structure, and that CD28 is the major co-stimulatory molecule that allows full activation of the naive T-cells and prevents energy in T-cell clones. His lab resolved a major controversy by demonstrating that CTLA-4 inhibits T-cell activation by opposing CD28-mediated co-stimulation, and that blockade of CTLA-4 could enhance T-cell responses. This leads to tumor rejection in animal models. He proposed that blockade of immune checkpoints such as CTLA-4 might be a powerful strategy for therapy of many, many cancer types, and conducted preclinical experiments showing its potential. These seminal findings actually established the field of immune checkpoint blockade therapy for cancer. Work in his lab led to the development of ipilimumab, that is an antibody to human CTLA-4, and the first immune checkpoint blockade therapy approved by FDA. Since that time, the ipilimumab has been approved as part of the therapeutic regimen for metastatic melanoma, renal cell carcinoma, lung cancer, etc. His current work seeks to improve immune checkpoint blockade therapies currently used by our clinicians and identify new targets to unleash the immune system to enhance and eradicate cancers. He is regental professor and chair of the MD Anderson Immunology Department, executive director of the Immunotherapy Platform, and director of the James P. Allison Institute. Among many honors, he is a member of National Academics of the Science and Medicine. His other recent awards include the Breakthrough Prize in Life Sciences in 2014, Lasker DeBakey Clinical Medical Research Award in 2015, the Belzin Prize in 2017, and the Kovalenko Medal from the National Academy of Sciences, the King Faisal Prize in Medicine, and the BBVA Foundations of Knowledge Prize in 2018. So there can be, hours of introductions, but in the interest of time, and since we all are gathered here to listen to him, I'm really inviting, with great pleasure and delight, Professor Jim Allison on the dais. Thank you very much.
Movie that was shown. I can't believe anybody got all those archival tapes and everything. It's pretty accurate, though. Pretty a lot of fun. One of the things that I've always tried to tell my students, I hope I don't fall off this thing. One of the things that I've always tried to tell my students that was captured in that is, we work hard, but we party hard. And people talk about work-life balance. There's no difference. You just do it all and have fun at both of them. That's the way, at least I've always tried to do. So if I can get this damn thing on again. First try. So as was mentioned, I'm going to talk today about checkpoint blockade, but what I'm going to spend is most of the time talking about the differences, the similarities and the differences between CTLA-4 and PD-1, how they work. Because I think the differences between them is not fully appreciated. And so they're just called checkpoints and checkpoints, except they're very different. For example, with radiation, I think that we heard about the fine talk earlier, which is something we showed early on, was something that could work with checkpoint blockade. Can really work probably better with the ipilimumab antibody that works during priming rather than with PD-1, which works only on preformed effector T cells, as I'll show you. So this is one of the lessons that we will be. going on. I was given a new computer for this trip, and it does all kinds of interesting things that I'd never seen before, like this. So I apologize. This is strictly, come on. It's going to go through that again. Last night, we had the same problem, but it eventually came on. Is it on the right? Is it on the right? The internet. Magic. Thank you. Somebody who knows the magic of the system. So these are my disclosures. First, I'm going to start and just give the acknowledgments so they won't be distracting at the end. This work really stemmed out of earlier work that I'd done in the late 70s and early 80s showing the structure of the T-cell antigen receptor, and then work when I first got to Berkeley showing that CD28 was an obligatory second signal. And then I was lucky enough to have a really outstanding graduate student, Max Krummel, who tackled the question of what does CTLA-4, this recently cloned, very close homologue of CD28, what its function was. It was first thought to be a positive co-stimulator, but Max, through some very clever experiments, ruled that out and proved that it was actually an inhibitory receptor, which in the vitro assays you really couldn't tell the difference. Sorry, in the vitro assays you really couldn't tell the difference, but in vivo assays it made the greatest difference in the world. And when I first started proposing in 1993 or 4 that this could be used for the reason I'll show you in a moment, to be used to treat cancer, nobody believed it. I got nobody that would listen to it. I presented it at a plenary session at the International Congress of Immunology in 2015, and nobody paid any attention. It received absolutely no coverage at the meeting. I went to biotech companies, I went to pharma companies for 4 years afterwards. They all said this will never work, and nobody would do it. And finally I teamed up with an old friend, Alan Corman, who had another friend who had a mouse that had the immunoglobulin genes replaced with human. And so we could make a human antibody to CTLA-4. So we made that, a little company called Metarex, put it into production, and that became history. BMS came in and licensed it, and it became ipilimumab. The work, and the rest is history. A lot of the work I'm going to show you today was done by a very good postdoc in the lab, more recently Spencer Way, who used high-dimensional fluidics to show the nature of the cellular mechanisms of this. And I'll show you some more recent work on myeloid cells that we're beginning to get into, because they, I think, are going to play a really critical role in our success as we move forward in this. And of course, all of this is done since the very start with Pam Sharma. So just to clue you in, so you probably all know this. If you don't, it's not worth knowing all of it except a little bit. One is that a T-cell receptor that gets just an antigen receptor signal doesn't do much. It may have some changes in metabolism, but it won't do much. You have to have the CD28 signal, contemporaneously, to turn all this stuff on and tell it to divide. I mean, the whole way T-cells work is you've got probably 10 to the 10th different clones of different receptors in your body, consequently only a small number of those of any given receptor, and you need hundreds of thousands to millions of them to go out and swarm a virus infection or a tumor cell. And so they have to proliferate very rapidly in the first week or 10 days after whatever the insult is detected. And that's what this is all about. So the CTLA-4 is really the ignition switch, and dendritic cells provide the B7 molecules then that interact with CD28 on the T cell, and that gets the process going. And what we know now is that also induces another program, which is the OFF program. It turns on the CTLA-4 gene. That then begins to accumulate in the cytoplasm, comes up, and then turns off that first priming from CD28 and the T cell receptor. It's really cool how it works too. We made a GFP fusion of each of these molecules and watched them in the cell. So this is CD28. That green cell up at the right is a T cell that's heading in towards an antigen presenting cell. Let's see if I can get this right. Why isn't this working? This worked last night just fine. It should just... Maybe I ought to have you give the slides and I'll just... Yeah, never mind. Anyway, what you would see if this movie worked is that the T cell would come into contact with the antigen presenting cell, and then CD28 would flow in the plane of the T cell receptor and then accumulate in the synapse right surrounding the antigen receptor, right there at the synapse. CTLA-4, as you can sort of see here from the start, is very different. It's up at the back of the cell in that structure that's at the back of the T cell. The T cell's going this way. The CTLA-4, after it's made, is all back there. When the T cell comes in contact with the APC, those little vesicles move, and it's sprayed into the synapse right where CD28 was, and we think pushes it out of the synapse and shuts off co-stimulation, and that's how everything comes to an end. And that's critical for stopping the immune response, because you have to stop it or the T cells will kill you. That proliferative phase is lethal if it's not checked, and so that was shown by Takmak and Cynthia Chambers in my lab and Eileen Sharp, who all made knockouts. They all showed the same thing. In about 3 weeks, T cells, mice fill up with T cells and die, probably of a cytokine storm or just tissue destruction. It's a pretty quick event in any event. So what does that have to do with tumors? Well, one of the things that we noticed when we first started doing this work, when we learned that B7 was the ligand for CD28, there was a question as to whether tumors didn't provoke immune responses because they didn't have antigens or they didn't have that second signal. And so we took a whole variety of mouse tumors and transduced them to express B7, and that was sufficient with every tumor we looked at to get it rejected. They wouldn't even grow in mice. So that showed they had antigens, but they were invisible to the immune system because they didn't have B7, which caused me after a while to put this sort of scenario together. The tumors arise, they're invisible to the immune system, despite the fact, again, they may have all kinds of antigens due to the mutagenic processes that are involved in oncogenesis, until they get too big or die for some reason. That causes the innate immune system to come in, the dendritic cells pick them up, redisplay the antigens in the context of B7, and then that turns on the T cell now for the first time, and it can go out and look for tumor, except that as soon as you start that, you also turn on, as soon as that happens, you also turn on CTLA-4, and it'll come up and stop the tumor. So it's a race at that point, was the reasoning, that the tumor is growing. It's had a head start, so if it's delayed, if this process is delayed so much that you can't generate enough T cells to take out all the tumor, then the tumor wins. So we had the idea, let's just disable the brakes for a while, let the T cells keep going, do it with an antibody so it'll go away, everything will come back to normal, and maybe the tumors will go away. And sure enough, it's shown on the right slide. The left slide shows some of the photos of what I was going to show you in the movies. But anyway, the right side just shows the typical sort of result we got got from mouse experiments. This is a transplantable syngeneic tumor growing. If you block CD28, the tumors grow even faster, showing that the immune system is trying to catch up, but just can't get there. But if we take the brakes off with CTLA-4, the tumors grow for a while and then get rejected. And those mice are permanently immune for up to 1.5 years later, until they get quite old. We can give them 100 times as much of the normal inoculation of tumors, and they'll just reject it right off. And so this was the thing that led us to be so excited about getting this in the clinic. Anyway, we did get ipilimumab. It went in the clinic. I moved to Sloan Kettering to watch the trials because I was afraid of one thing. I knew nothing about trials except that in the mouse, the tumors always grew before they went away. And one of the things I learned very early on was that progression-free survival was the endpoint that was going to be used to evaluate this drug, which is obviously not the right endpoint because growth of the tumor before restruction is inherent in the biology of the process. And so the oncologists were calling this a cancer drug. It kills tumor cells, therefore the tumor cells can't grow. Well, that's not how it works, and that would have killed it. Pfizer made an antibody, a similar antibody, used progression-free survival, and it failed at phase 3 for that reason. BMS had used the same endpoint, changed it to overall survival at the end when they realized that a lot of patients that had called non-responders went home to their, from New York, went to their communities and responded there. And so it was late response. So they saw that, realized that it was consistent with the biology, and then changed the endpoint to overall survival, which meant that the trial lasted 5 years. Anyway, I had the luck when I was there. It was bad luck for her, but to meet a patient of Jed Walchuk's called Sharon Bellman. She was 22 years old, just finished college, just gotten engaged to be married. Was an athlete, had a lot of trouble running and doing her normal things. Went to her family doctor. He quickly diagnosed her with metastatic melanoma, sent her to Sloan Kettering. Jed diagnosed her, started treating her with the conventional chemotherapy. She failed them. I should point out she had 31 lung mets. She had her liver was so peppered with metastases, there were too many to count. She also had a 1.5 centimeter tumor in her brain. And all of that failed. 2 rounds of the standards, well, there weren't any standards of care, but the normally used drugs at the time, and also failed radiation to the brain tumor. Was finally given a month to live or so, and Jed said, we got one more thing, ipilimumab, you want to try it? She did, and went away, came back a few months later for a checkup, and all her tumors were gone. It was quite an excitement at Sloan Kettering, because when the reports came up from the screens that she'd gotten, they said there was no tumor detectable anywhere in her body that time. And they went to double check. They thought they'd gotten the wrong field, all this stuff, and finally we realized that they were just gone, as shown on the right. They were all gone. Anyway, as I said, that was about 2006. On the slide on the right is 2005, rather. On the right is her 2 children that she had in 2016. And I just show this for fun. We became good friends after that, and so she went with Pam and I to Stockholm for the Nobel Prize, and enjoyed that with us. And so the trial then, the phase 3 trial, a randomized trial, was presented at ASCO in 2010. It's shown here. The line at the bottom is the control, the placebo controls. You can see here about a 7-month median survival with essentially everybody dead by 3 or 4 years. This is the IPI line only here, this one. You can see it moved the median survival over about 4 months, which would have been sufficient. But the cool thing was that the survival curve flattened out at about 2 years. And so it was stopped. The trial was successful. It was approved by the FDA in 2011. And so very soon after that, BMS had done so many trials. They had almost 4,000 patients for whom they had 10 years follow-up by 2015. And those numbers showed, again, about a 22% survival rate at 10 years after a treatment with monotherapy. And so quite a big success, but why just, in melanoma? Because there's no drug that ever prolongs survival. But of course, the question was, why only 20%? Well, I could give you a mechanistic reason, there's some arguments, but of course the one obvious problem was that maybe there were other checkpoints that we just weren't getting out of the way. And so as our early clinical data were coming out, Tasuku Hanjo who had a molecule called PD-1 that had some interesting properties, teamed up with Arlene Sharp and Gordon Freeman. They made an antibody to it and showed that it was a similar molecule, another checkpoint, except it's a little bit different because it has a ligand that's actually on tumor cells. So that it's shown in the cartoon. PD-L1 is actually on tumor cells. It's induced by gamma interferon. So it works on late-stage cells that are already terminally differentiated. They know their specificity, know their function. They're making gamma interferon. They come up, make gamma interferon. The tumor responds by upregulating PD-L1, engages PD-1 on the activated T cell and turns it off. And so very different sort of process. Works in many different kinds of cancers, as CTLA-4 did. And caused a lot of excitement on its own. We put them together in mice and showed that they're at least additive. And this shows a recent update, a 10-year follow-up of I think, 1,100 patient randomized trial, 11 countries, who knows how many investigators, but just the absolute gold standard of a trial. And you can see here the combination of anti-CTLA-4 and anti-PD-1, the 10-year survival is 52%. And that's a solid number as you can get. So we've gone from a situation where we had an incurable disease that was genuinely, mostly completely fatal by 7 months or so, at least half people, nobody lived past 5, to we could cure over half the people with that and actually use the word cure. And so I think that, has opened a lot of doors and a lot of interest, understandable excitement. This shows a partial list by type of, by antibody in different kinds of cancer. I'm not going to go through it all. This actually I stopped in 2021. There have been lots of approvals since then, but many approvals in bladder cancer led by PAM, head and neck cancer, lung cancer, many kinds of cancer, particularly those with high levels of mutation. I'm sure everybody knows all of that. All these approvals are either PD-1 or CTLA-4 antibodies, or increasingly the combination of the two. We're beginning to see in the last several years neoadjuvant trials, which are working even better in non-small cell lung cancer. There's recently a trial by Tina Cascoyne at Sloan Kettering at MD Anderson in non-small cell lung cancer that has 77 3-year survival. Finding combined with chemotherapy, and another trial in melanoma combined with surgery, where the combination was given both before and after, where the response was, the 3-year survival was over 70%. So we're headed up there. Those aren't approved yet, but those are the initial findings. So as it moves earlier and earlier in treatment and combined with other things, I'm really looking forward to seeing radiation taking its place in that scenario. We're, I think, getting to the point where we can think about really moving intelligently and curing more patients with it. It became evident early on that there is a relationship between mutational burden and response rate, as shown in this trial here with melanoma and caused by sunburn, and lung cancer caused by smoking and things like that respond quite well. Other tumors that have other causes respond less well, but they still respond at some rates. When you calculate it in terms of the frequency of different kinds of tumors, at least in the United States, we're reaching about 25% or so of all cancer patients now. And I think that number is going to go up as we keep going. And that's what we need to do, I think, is really learn all we can about how to combine all the modalities of cancer therapy that we know about in ways that make sense to cure cancers better. And to do that, we really need to understand how they work. So this shows some of the differences between the two antibodies. I already told you that CTLA-4 is hardwired. It terminates every T cell response that you get, regardless of whether it comes from viruses or anything else. PD-1 is an induced resistance, where the tumor cells, the cells respond to gamma interferon produced by the immune system to put up its inhibitor. This has been shown to play a role in protecting the developing embryo from destruction by the maternal T cells attacking paternally encoded antigens on them. So it may be that tumors just somehow co-opted that, which is the real biological role of PD-1, to protect themselves. In any event, CTLA-4 targets the CD28 pathway, PD-1 the TCR pathway. CTLA-4, as I told you, works during priming. I don't have time to show you, but it actually skews the types of CD4 cells that you get, because CD4 cells don't have their function determined until they're primed. And so by having CTLA-4 there and unlimited co-stimulation, you get a new type of cell that I will talk to you about, that Pam discovered. I'll talk to you about later. But the fact that it works during priming raised the possibility that it may also set the threshold for activation. I don't have time to go through those data either. We published extensively on this in the early 90s, showing that when you have CTLA-4 around during priming, you can get T cells to respond to peptides whose avidity is otherwise too low to trigger a T cell. You can drop the level that you need to engage the T cell satisfactorily enough to activate a T cell. So you expand the clonal diversity. So you'll bring more clones to more antigens when you give CTLA-4 than with PD-1. PD-1, as I showed you, works on the terminally differentiated cells that are already functionally mature and doing what they're going to do. It can increase the number of those clones, but it doesn't. It's been shown in mice, not only theoretically, but in mice and in patients, that PD-1 doesn't bring new clones in. CTLA-4, it just expands old ones. CTLA-4 does. As I'll show you, CTLA-4 as a monotherapy primarily affects CD4s, although some CD8s as well. PD-1 as a monotherapy only affects CD8 T cells. CTLA-4, Dr. Sharma showed, can move T cells into cold tumors, at least prostate and some bladder cancers where PD-1 does not do that. T cells aren't in a tumor. PD-1 is not going to get them there. CTLA-4 blockade can. Perhaps because of its working during priming, adverse events associated with CTLA-4 are relatively frequent, with PD-1 much less frequent. But disease recurrence after response is very rare with CTLA-4, but it's quite common, 25 to 30% with PD-1 monotherapy within 2 to 3 years. One of the reasons for that we just published, I don't have time to talk about it, but the inherent memory that you get in a T cell that's been developed in the presence of CTLA-4 blockade, because they retain more of the TCF transcription factor that gives stimulus. They have much more durable memory than PD-1, which mostly retains tox transcription factor, which makes them functionally better, makes them less durable. So all these differences. So anyway, we want to see the cells that were involved. So this is just the annotated version. I'll spare you all the raw data. The stuff on the left here is showing Tregs. I don't want to pay much attention to. Our mouse antibody depletes Tregs. The ipilimumab does not in humans, so it doesn't have that part of the mechanism. But if you look at CD4s, CD4 effector cells, you can see that PD-1, which is green, does nothing over the control, which is in blue. But you see the red line, those cells are hugely increased when you give anti-CTLA-4. We call them Th1-like because they have ICOS on them. And you know the consequences of that by our license plates, as you saw in the movie. But I'll come back to that later. But PD-1 doesn't do anything to those cells at all. There is a naive population of T cells in there that neither does much for us. If you look at CD8s, these two are the populations of interest. Now, when you hear about PD-1, everybody talks about exhausted T cells. These are the ones that have PD-1 high, TIM3 high, and LAG3 high. Those expand, as you can see here in green, when you give PD-1, but not with CD4. CTLA-4 doesn't do anything with them. But the point I want to make here, in addition to saying that PD-1 expands those, and those are the main, among the CD8s that are associated with smaller tumors, they still have that phenotype. So when the antibody goes away, those cells are going to stop again. And that's why you have to keep giving PD-1 for as long as 2 years or until patients progress, because it only works as long as it's there. CTLA-4, on the other hand, is generating new T cells all the time, so you don't have that limitation. There's another population of CD8s, which are effector cells. They're the ones that's the common everyday CD8, KLRG1, mature cytokine-producing killing T cells, and those are expanded equally well by both CTLA-4 and PD-1. So the story then is that these mechanisms differ. CTLA-4 hits these these ICOS positive TBET Th1 effectors and the EOMIS positive CD8 effectors. PD-1 expands these exhausted cells and also the effector cells, but does nothing to CD4s. So how do they interact, though? We're now putting the two together in most patients, so the monotherapies don't really matter. But what happens when you combine them? Is it just the combination? So we just added one more group. I'll go through this rapidly. This shows the effect, again, on these exhausted cells. So you can see here's the control. Here CTLA-4 does nothing. PD-1 increases that. You add CTLA-4 to the combination, and the numbers actually go down of those exhausted cells. They go down. We've seen this again and again and again. They go down even below the control levels. And if you look at the Spearman coefficient, where we kept track of the tumor size in each mouse so we could show the number of cells versus tumor size, the blue dots show you that with no treatment, it's the frequency of those exhausted cells that correlates with smaller tumors. With PD-1, the more of those exhausted cells, the smaller the tumors. But in the red, if you just add CTLA-4 to that combination, they don't matter anymore. Not only are the numbers smaller, but they become irrelevant to the whole process. So you collapse but you do expand, shown here, you expand the terminally differentiated cells, not the exhausted ones, but the terminally differentiated cells up above more than just the CTLA-4. So you simplify the reaction then to where it's just the two, just the CD8 cells and just the CD4 cells. So what happened to those exhausted cells? Well, we don't really know. Did they revert back to effector cells? I don't think so. John Huary and others have worked out the epigenetic evolution of those cells quite nicely, and it appears that they are stuck in that exhausted population. But we're trying to look now to see if there are any fingerprints of epigenetic changes that we could find that they once were effector cells. But I think more interesting is that the fact it might be that when you have CTLA-4 there, one of the things that happens is that CD28 becomes available all the time in an unrestricted way for both CD4s and CD8s. And it might just be that the T cells, when you give the combination, the CD8s could go back, the effector ones, and keep getting rejuvenated by a new co-stimulation event, and they never become exhausted. This has considerable implications towards how you dose patients in combination, but it'll take a lot more work before we could decide what to do about that. In any event, because activated CD4s also have PD-1, when you add CTLA-4 and PD-1 together, you get even more of those CD4 effector cells too. So a very much more potent combination of cells, more CD8s and more CD4s than you would get either monotherapy by itself. But what about these ICOS cells? Well, ICOS is inducible co-stimulators, a member of the CD28 CTLA-4 family. As I said, Dr. Sharma discovered this in her very first neoadjuvant trial. She talked about yesterday, so I'm going to repeat just a little bit of that, where she looked and showed that of the tumor-specific cells seen in bladder cancer patients treated with anti-CTLA-4, all of the CD4s that reacted with the antigen EDNY-SO1 in this case that was on the tumors expressed ICOS. There were no conventional CD4s there that had tumor specificity. So they played a role in cancer. ICOS, again, is a member of that family. And this is the other work that Pam did. She collaborated with Jed Walchuk when he was doing the phase 3 and actually showed that the appearance of those ICOS-positive cells was absolutely essential if a patient was to respond. In those days, if a patient didn't have the elevation of those cells that were stable throughout the period of therapy, they did not respond to anti-CTLA-4, probably maybe because they had been so beat up in those days by chemotherapy, so we don't see that much anymore. It doesn't necessarily guarantee they are going to respond, but if you don't have them, they're not going to respond. So it's a marker, pharmacodynamic marker of activity. Pam showed you yesterday that it's essential in mice. I'll repeat that quickly so you know this. This is our mouse model treating normally, but if you do the therapy in mice that lack either ICOS or its ligand, you lose half of the specificity, half of the potency. So it's not just on there as a marker, it's playing a functional role in the response. And Dr. Sharma showed that's because of site that binds PI3 kinase and signals through that pathway that makes it absolutely required. Forget the full function of CTLA-4. So we collaborated and gave an agonistic signal or not. This is a fairly resistant tumor line where CTLA-4, even with a radiated tumor cell vaccine, doesn't do anything. These are all the controls on the left. But if that tumor cell vaccine has ICOS ligand, you go from 20% response rate to about a 90% response rate, just by adding that one little signal through ICOS. And if you do that in ICOS knockout mice, in other words, the receptors, the ICOS receptor isn't there to work in the mice, it doesn't work. So it's a critical molecule in the biological signaling, the pathways that give you the response. And it's something that could be done therapeutically, and something that we are working on is trying to make a more clinically relevant way of giving that agonistic signal than a transduced tumor cell vaccine. And more recently, we've looked in more detail. I'm not going to go through this because of time in much detail, but use single-cell RNA analysis to look at what goes on, and this shows all the different panels. But if you just compare the monotherapies with the combination here, what you can see here is that these are the CD4, those CD4 ICOS positive cells here. And you can see at the bottom, these are those exhausted cells which almost go away again completely. And these are the effector CD8. So again, it recapitulates in the single cell, unbiased way of looking at the data that we saw when we did the original antibody-based proteomic study. But what's really interesting is what happens to the myeloid cell population. Again, these are single cell data here, and it's complicated, but just to point out the relevant areas. Here, look at this index map here. Up here are the so-called M2 macrophages. They have arginase, they have all these different things that they can make that'll inhibit T cells, whereas the more inflammatory or helpful, or whatever you're going to call them, cells are down here in this area. And you get them both with NSCLC by itself or in the control, but when you add the IVAX, get the ICOS signal, you almost lose all of those inhibitory myeloid cells, and you're left only with those that are the ones that help the T cells kill tumor cells. And so we've had this phenotypic remodeling of the entire myeloid population to help kill tumor cells. And this is something we could just do better. I think we could greatly improve the response. So that's all the data I'm going to show you. I think all this shows that we're on, if we could just continue to learn these mechanisms, know the targets, know when different checkpoints come up, put things in the right order, we could do a lot better. This slide here shows all the T cell checkpoints repeated from the movie a little bit. But you know, the disappointing thing is that, you know, IPI was approved 2011, PD-1 antibodies in 2014, the combination in 2015. It's 2025 now, and the only new molecule that's been approved is LAG-3 over here. What about all these other guys? And I submit to you, it's because we as a field are not really paying enough attention towards doing the experiments in the right way. Certain old shibboleths of oncology, like, oh, if a drug doesn't have single agent activity, don't use it because it won't work, makes no sense in this, because very often things like VISTA, for example, has been shown it's not there unless you give IPI, and then it appears. And so to give it without IPI and it fails, and you say that's a bad target, you've just killed something that's good. You just need to give it after you give IPI. And I could give you other examples of that we're just not doing. The pharma companies are not paying attention sufficiently to the science and the cell types that are involved. We need to really understand how these things interact with each other. We're going to do better. Plus, there's a whole new family of molecules, the LILR2, the LILRB series, at least B2 and B4 in mice and humans, that are greatly inhibitory and can be targeted with antibodies to actually do some of this remodeling. So the thing that a lot of companies are trying to do, which is to get rid of myeloid cells, is really a bad idea, because you get rid of cells that can help the responses I showed you. That response, if you look at the response, when you get rid of myeloid cells, it's worse. when you do the combination than if you just leave them there. They actually help. And if we can help by just getting the bad ones out by targeting these molecules, I think we can greatly improve that interaction between myeloid cell component and the T cell component and do much better. So I'll just close here and say that, in oncology, those of you who've been in the field know that for years, the approach has been to just take a whole bunch of patients, look for a p-value, treat them, a whole bunch of patients with something and see if you move the median survival over a little bit. Quality of life's okay, that's sufficient for approval as it should be. But with IPI, we showed that you can do that, but you can also get this durable effect of about 20% of patients as monotherapy with a 10-year survival, 20-year survival in Sharon Belvin's case. The combination, 52% or 70% or more as we're seeing now in the neoadjuvant trials. But what we need to do is look at all these things, these combinations, not only these, but combinations with chemotherapies and TKIs and radiation, and bring all the tricks that we can to bear to optimize these T-cell responses, remove the inhibitory influences, and increase the helpful influences of myeloid cells. And I think that we can get to curing. Maybe we can get close to 100% in melanoma. I don't know. Maybe we can get close to 80% or so and 100% in non-small cell lung cancer. We're nowhere now really in pancreatic cancer or glioblastoma. We need to learn the tricks there. But in both those cancers, there's a huge myeloid population involved. Maybe that's the secret. A lot of people are beginning to look at that. But the thing I want to leave you with is that we know we can cure cancer now. That we've done it. We've done it in a lot of patients, 20 to 25% overall in the States. We need to be able to do it better and get it up closer to 100%. I don't think we'll ever eliminate cancer. If we can prevent it and do this, though, we can minimize the suffering and death from this collection of diseases that's plagued humans for so long, and I think that if we know it's possible, it's just a matter of working smartly, and we can get that done. And so I'll stop with that, and I apologize for all the confusion if I went over anything. Thank you for your patience.
So, ladies and gentlemen, can I request you to please stand up and give Jim a standing ovation? So, Professor Allison, that is a tribute from all of us to the incredible work which you've done and to the innumerable lives which you've saved. Thank you very much. And may I ask you to please come in the center of the stage so that we can honor you. So, ladies and gentlemen, no questions during the oration, but we are following this up with the Cancer Moonshot, the American-Indian joint program, and Professor Allison and Dr. Sharma and some of the Indian experts will be available for the panel discussion, and you can shoot your questions at that time. So over to the organizers to call the panelists, please. So will the organizers call the panelists, or should I do that?
So Master of Ceremony for the
I would like to now call all the panelists. We'll now proceed to the next session, that is the Moonshot Indo-American program, the challenges and opportunities. For this, I would like to invite Jyoti Bajpai Madam, Dr. Jyoti Bajpai Madam, for chairing this session.
So I would like to call upon the chairpersons for this session first, and the chairpersons are Dr. Sudeep Gupta, who's the Director TMH Mumbai, Dr. G.K. Rath from Delhi, Dr. Shripad Banawali from Mumbai, and Dr. Sarangi from Bhubaneswar. So chairpersons can please take the seats, and Dr. Sudeep Gupta is joining online. So
yes, good afternoon, Jyoti. I'm already here. Thank you very much. Thank you for inviting me to this conference, and apologies for not being there in person. I very much enjoyed the talk by Dr. Allison, and I look forward to the deliberations on Indo-US collaboration in the domain of cancer research as well as immunological treatments. Thank you.
So thank you very much, and now I would like to call upon the other panelists, Dr. Pam Sharma, Dr. Sangeeta Goswami, Dr. Betty Kim, Dr. Hemant Malhotra, Dr. Rakesh Jalali, Dr. T. Raja, Dr. Ranjit Bajpai, Dr. Vijay Haribhakti, Dr. Vinay Deshmane, Dr. Birendra Nath, Dr. Deepak, and Mr. Dinesh Madhavan. Again, Dinesh is joining online. Yeah. Sit down. So while the status staging and panelists are coming on the dais, let me tell you that this will be a truly a brainstorming sessions with all the stalwarts in the field, and this is a Cancer Moonshot panel, and with the stars and moons in the panel, you can really see that how interesting it would be. And in the interest of time, I really request each one of you to please be, really brief on the comments so that we can have more discussions.
We need one more mic over here. Yes.
Right. So I'll begin from here, and so in this panel tour, we should be discussing about the Cancer Moonshot, what is the meaning, institutional, because there is an MD Anderson Moonshot panel, there is a countrywide, what is happening in US, what is happening in India, international collaboration, quiet moment, collaboration movement in cancer space, opportunities at various disciplines, focus on which cancer and why some cancers are taken as the initial focus areas, in Quad Moment, in MD Anderson, any other thing. Role of international and national societies like SIDSI, I-OSICON, ESMO, etc., and way forward. So I would begin here about the Cancer Moonshot program. So what it is and how this is associated with cancer. And I would like to take from Dr. Padmani Sharma, if you want to take this.
It's a very broad question, but okay. I think the Cancer Moonshot program at MD Anderson was started really to foster collaboration between different investigators in different fields of biology, to try and come up with innovative treatment strategies or innovative research studies that can really advance our knowledge. So to try and take the medical oncologists and the basic scientists and the surgeons, and then even the basic scientists from immunology or people who have expertise in microbiome or computational modeling, to make sure that these teams are formed in a cross-discipline way to really expand the innovation and expand the sort of thoughts that we were having for new treatments in cancer.
Thank you. I think computer is having its own brain. It's moving the slides a little bit on its own. So I will, start here with the famous cancer moonshot speech of Kennedy, which is, kind of an inspiration for many of us in various times. So can we play this first? And can we have little dim lights here?
We meet in an hour of change and challenge, in a decade of hope and fear, in an age of both knowledge and ignorance. The greater our knowledge increases, the greater our ignorance unfolds. Despite the striking fact that most of the scientists that the world has ever known are alive, and the unfinished still far outstrip our collective comprehension. There is no strife, no prejudice, no national conflict in outer space as yet. Its hazards are hostile to us all. Its conquest deserves the best of all mankind, and its opportunity for peaceful cooperation may never come again. But why, some say, the moon? Why choose this as our goal? And they may well ask, why climb the highest mountain? Why 35 years ago go lie in the Atlantic? And they may well ask, why climb the highest mountain? Why 35 years ago lie the Atlantic? We choose to go to the moon. We choose to go to the moon in this decade and do the other things, not because they are easy, but because they are hard. Because that goal will serve to organize and measure the best of our energies and skills. Because that challenge is one that we're willing to accept, one we are unwilling to postpone, and one we intend to win. Why choose this as our goal? And they may well ask, why climb the highest mountain? Why 35 years ago?
So that was the, the actually setting the stage thing, that what was Cancer Moonshot initially and how is inspired nation and rather, beyond the nations. It was, they choose to go to the moon because it was hard. It was not easy and those were pretty challenging. Similarly, to control cancer, to set those boundaries is pretty challenging. And we will be discussing how we are moving in this space nationally and internationally. So I heard Dr. Sharma talking about, what it means by the Cancer Moonshot program in MD Anderson. I would like to ask Sangeeta further. There are a couple of, pointers like innovation, scale, collaboration. You can take anything and you can speak on that, how these things are being, done in MD Anderson.
So in MD Anderson, like as Pam mentioned, that one thing we have realized that we cannot cure cancer in silo, right? We, as I mentioned in the previous panel as well, that all the teams need to come together to actually make the next breakthrough or next innovation, the true innovation, not only the incremental changes. So for that innovation, MD Anderson, not only through Moonshot, but other institutes like James P. Allison Institute, the Data Science Institute, and other institutes that we are forming. So we are trying to bring the talent from across different fields to kind of bring about those innovations. And as I mentioned before, that innovations, it's has to come like not only from the clinicians, but the basic scientists, people from the computational field, the AI, like all the newer technologies that is kind of really helping us to understand the microenvironment better. So how can we develop a patient-specific response? Like initially we used to think from the tumor-specific, but now we know that in every tumor, patients behave differently, right? There is heterogeneity. How do we go about in a patient-specific manner? So that is the drive of that program in terms of innovation. It's not only the Moonshot program, I would say. This is more of a philosophical, thing that, that the aspirational goal that we always thought about it, but practically that there's different other institutes also forging together to truly make cancer history.
Absolutely. I think, yes, very truly said that there's a philosophical and that there is a scientific, and there are other aspects which are very, very important for this cancer moonshot. When we say cancer moonshot, it itself gives an inspiration to reach to and to aim high. So Dr. Allison, I would like to ask you, there's a very important component what I could see, that there's a research past and then past. And who else than you would be the best person to tell that how this is being done? And there are several things which are part of it, especially in immunology. I would like to know that what are the recent research which is being done to reach and to change the fate of the cancer?
Well, I think that probably the best person to talk about that in the clinic would be Pam, but I think it's by studying what happens when we perturb the tumor microenvironment with whatever we're doing, radiation or the checkpoints or chemotherapy or ablating this receptor or that, really seeing what the consequences are, because the immune system always responds. It's so elegantly controlled. There are many more ways of turning it off than there are of turning it on. And that's one of the things we've learned. That's why there's so many of those checkpoints. They each affect a minimal, I shouldn't say minimal, affect a different aspect, a different biology of the T cell. And by understanding in a very complicated way, and we're only beginning to understand partially that goes. And I think if we're going to really use the combinatorial properties that the immune therapy offers that are not there to quite the extent. Anything that kills tumor cells, virtually, as I showed in the cartoon, will initiate an immune response. The question is how long will it last, what direction it'll go in. So my own prejudice is that we need to pay more attention on just looking at mechanisms and finding, it may take a half a dozen different agents combined well to take out the more difficult tumors, but so be it. The scientists have to do it. I think the pharma companies don't work quite that way. We need to hand them the combinations and say test it in a lot of patients, but we need to be able to get it up to phase 1, and that's what Dr. Sharma has started at our institute at MD Anderson. So.
Absolutely. Yeah, I think make a lot of sense, and combinatorial therapies, we have to really choose wisely and precisely again as the theme of this Congress. So Dr. Kim, your take on this, and there are other major research platforms also. You are part of several of these avenues, so you can talk about any drug development, immunology, whatever is your experience and you think one of the most important part of this cancer moonshot.
Sure, I think with the cancer moonshot, and just, we're trying to do research that will be transformative, and that requires a lot of collaboration. But I think what's really critical about the MD Anderson program is the people. And an example would be the James P. Allison Institute, where we're, people in it are what makes and drives the innovation. And there's collaboration through it, as Dr. Goswami mentioned, multidisciplinary sort of effect. And so I think when we bring in people of different sort of backgrounds, And especially the young, the new generations, where they're thinking maybe outside the box, maybe they're not as rigid and are sort of thinking, of the pathways that have been done traditionally, but they're bringing in new technologies. I think that's what really excites me about these platforms, because the institution as a whole is providing us sort of the platform to utilize, to innovate. And so that allows us to sort of do better research. And actually, that also brings about funness. I think if you're really passionate about this, it also has to be fun. And so I've really enjoyed that about joining the MD Anderson team as an institution, where they really foster that and the innovation behind it too.
Sure. So about the drug development, I think, the newer drugs, the most important thing which has happened in, a couple of decades and which has actually changed the fate of the cancer. Immunotherapeutics are one of those kind. I really feel not only the last decade, but it's last century, which is the biggest revolution happened with your pioneer work. And, we are talking about, indefinite survivals in our clinics with the deadly cancers. So I want to now ask Dr. Malhotra and Dr. Raja, one by one, that what is your take on these newer drug development and how we are facing a challenge? How can we collaborate with what is being done in the other part of the world from this end?
So I think my take on this is that we have excellent clinicians in our country. We have excellent laboratory researchers in our country, but the clinicians don't go to the lab and the researchers don't get to the bedside. So the first thing is to get them together, get them on the same page, and that is one of the rationales why this society was formed. And we have our own cancer moonshot in our country. We have managed to design a humanized CAR T cell in our country, and the architects of this moonshot are sitting there in the audience. We have Dr. Gaurav Narula sitting there. We have only one example, but we need several more examples, several more molecules, organizations to get it from the bed to the bedside. Our neighboring country has so many checkpoint inhibitors in development, in advanced phase 3 studies, in approvals. I really do not know why we are lacking behind, and that is one of the things which we all need to think of, and we need to expand our Moonshot initiative in our country.
Thank you, Dr. Jyoti, and it's an amazing feeling to sit in the same podium with Professor Allison. Thank you so much for putting us all together. The Cancer Moonshot program, as it was originally, I think it has got both literary meaning and technological meaning. In literature we always say sky is the limit, reaching for the moon, and then the technological prowess of our President Kennedy's ambition to reach for the moon, to show the technology. And the MD Anderson started the Cancer Moonshot program. Then it was formalized by the White House. I think it was Mr. President Bush, and then later on the subsequent presidents. But I think India joined we can also look at some the Moonshot is a very, very broader goal, putting so many things together. That's what we know. But there can be some tangible goals also. For example, India is part of the Quad Moonshot program, and that came from a very simple idea from the Australians. Australians had a target that in 2035 we will eradicate cancer cervix. From that, the Quad Moonshot program was formalized. I think now it's part of, India is part of the Quad Moonshot program. The Indian Moonshot program, I think the goals are to, if possible, to improve the papilloma virus testing, and also to look at the vaccine and to see how to eradicate cancer of the cervix, which is one of the most common cancers in our country. The second part of the Indian endeavor is that to improve access to the clinical trials. That's known as the ASHA program, access to the clinical trials. I think like what Dr. Malhotra said, if we have large number of clinicians, and a very big population, and if only the access to the clinical trial and the very culture of getting into clinical trials can be enhanced in our country, I mean, we can also be pioneers and innovators, and we can also teach a few things to the world. That's what I would take.
Sure.
Thank you.
So, very well said. And I think since you talked about Quad Summit, so I have a slide for Quad Summit as well. And I also feel that this is extremely, extremely important, united effort. And, this brought many nations together to work for a single cause. And definitely we should aim high. We should try to reach the moon together. Perhaps together we can make more difference. So I would just like to play this short, very short, again, inspirational voice. Voice is not coming, I believe.
Good evening, everyone. Prime Minister Albanese, Prime Minister Modi, Prime Minister Kishida, and Governor John Cornyn, Senator Chris Coons, and Representative Governor John Cornyn. All the scientists and doctors and advocates here tonight, what a fitting way to end the Quad Summit by launching another historic endeavor. When I was Vice President, Jill and I launched here in the States what we call the Cancer Moonshot. We committed to end cancer as we know it and reach 50% cure for cancers in a time frame that we've announced. We had lost our son to glioblastoma in 2015, Bo, a graduate of this great institution. And like many mothers and fathers, quite frankly, we were ready to give up. But I wasn't going to run again. My son, Bo, knowing he was going to die shortly, pulled me aside, not a joke, I wrote about it, made me promise that I wouldn't walk away, that I'd stay involved, because he knew the impact if we stayed.
So, I mean, this was another very inspirational speech and, a moment of togetherness, 4 countries coming together. There was some personal reasons, some, other reasons, but, everybody was looking very motivated to take this mission forward. So now my question, maybe I'll start from Dr. Jalali. How can we strengthen this bond? It was, it was started in a very big manner. What should be the way forward?
Thank you, Jyoti. I think it's a very pertinent topic, and it's a delight to be, and a real honor to be a part of this group. And much has been said since 2 days and this morning also. I just want to highlight 2 aspects. One is pure scientific aspect, and second is the practical aspect. The scientific aspect was truly inspirational by actually Dr. Allison. The 2 take-home messages to me were so much impact, and I've heard Dr. Allison now several times, and he always says that don't look at the silo only at the immune checkpoint. It's not only the cancer cell, it is the immune system, it's the microbiome, and the impact of combinatorial therapy. And I think that's the way forward. And fortunately, the Immuno-Oncology Society and societies like these, where there's a multidisciplinary approach from the clinicians, from the basic scientists, the translational aspect, that's very important. And also he showed the graph, that how you can push the graph with combination therapy to about 70 to 80% of all the cancer cures, which is about 40 to 50% at the moment. And I'm quite hopeful and enthusiastic that this is perhaps, as Dr. Cole also mentioned, we are at the cusp of something truly exciting in our lifetimes, and if we come together, so that's very, very important. So that was one part. The other scientific part, which is also a little bit close to my heart, here we also have to identify a priori the moonshots. For example, the neuro-oncology is my field, so glioblastoma, pancreatic cancer you mentioned. And if we can overcome these 2 really, and the diffuse midline gliomas in children, it can open vistas and avenues to many other cancers, and that will teach us. But it needs a truly global effort, transcending not only the political, the geographies, but also the industry. I strongly also would say the patient advocates, the governments, everything has to come like an orchestra in unison. And what better time than this? And we have to overcome our own personal prejudices, egos, looking at silos in our own field. And that is very, very important in my opinion. The practical aspect is I strongly suggest the society with the leaders And we have several leaders both joining online and here in front of us. Dr. Rath is here, Dr. Gupta and others, to identify very quickly a task force for the country who would identify and make a recommendation to the government, take it on board with Professor Allison's and their team's help, make a very workable, with very a priori, well-defined short-term goals and intermediate and long-term goals to come to fruition, and have summits in society and meetings like this to really make the difference to the world, because the science is there, it's just only the matter of implementation. Thank you.
Absolutely. So I think very well said again. And we will move to now the two eminent surgeons in the panel. So definitely it's you very rightly said, Immuno-Oncology Society of India is truly multidisciplinary, and that's where we take this pride. And we have very progressive surgeons, who are associated with us, and they are very, positive about the new avenues and events. So I'll take Dr. Deshmane and Dr. Haribhakti's opinion on that. What are the opportunities and various specialties to collaborate on these fronts?
I think looking at everything, I think the science is great. Its applicability has not been so great as we would have wanted it to. The strength lies in our diversity as well as the fault lies in our diversity. So we don't actually, our problem is we don't have quality control in many of the things we do, but we have sheer numbers. So we do require to form collaborative programs with quality control, especially when we're talking about tissue, microbiome. We require pathology to be given its due place. Unfortunately, in our oncological society, we are not seeing pathologists of a proper a level, or at least a standardized level across the country. So you will actually have to form small groups which will maintain quality and then combine. I think neoadjuvant, the neoadjuvant area is a great area where we could actually provide a large number of patients. And also if you look at our registry programs, every registry program shows that we have large number of advanced tumors at presentation. So that also forms a great group for doing extremely well-focused trials. But we need to maintain quality. And the other thing is pathology. We've got multiple now genomic labs which are coming up. But there has never been a proper drive in our country for doing research at the basic level. When I learned translational research back in England, I did methylation in 97, 98, which is very, very, very new, and I came back to the country. There was just absolutely zero opportunity. I'm at least now seeing some green shoots where people are interested in basic research and trying to translate things. And I really hope that this takes off in a big way.
Thank you. Dr. Haribhakti, please.
Yeah, I agree with all the statements made by Dr. Deshmane, and I think I'm going to add a few very basic ones. Firstly, it's really a great honor to be here in this meeting and with such a distinguished panel. And I must start by saying that the most important takeaway from Professor Allison's lecture was your last slide, which spoke about optimal combinations, because I think that is really where we are heading and we should be heading. But for a moment, I'm going to step back a bit when I see this list. What are the low-hanging fruits for collaborative efforts? And I feel in our country, we have some really huge problems. We have tobacco, which is the biggest bane and the biggest cause of the most frequent cancer in males. And we haven't been able to do much about it. So I think if there's a collaboration, I would want to understand deeply how smoking was tackled in the US to bring down the incidence of lung cancer. Because we urgently need to bring down incidence first. We get to treatment, of course, like everybody is saying, but we need to bring down incidence, I feel, very, very critically. So we need to have collaborative efforts for that, for breast. Today in the presentations we saw, we have so much more of TNBC in our country, and we have so much more of cancer in younger patients. Yes. And I still feel, I mean, in our hospital we started a one-stop breast clinic, but it has not been taken well by the community. People don't come up. So I think there is something we need in terms of public education for prevention, for early diagnosis, for limiting incidence. And then, of course, as we move on to
actual patients, as Dr. Deshmukh said, we definitely need to embrace trials, and we need to understand that it's only well constructed and well structured trials that are going to give us any meaningful outcomes. So that's what I was saying. Yeah.
So thank you very much. Yes, our problems, our solutions, and so our Mr. Modi, I will just take 10 seconds to play this also. The
भारत
Quad
का
Summit.
विजन है वन अर्थ वन हेल्थ। इसी भावना से मैं क्वाड मूनशॉट इनिशिएटिव के तहत $7.5 million.
So in the interest of time, I will not play that full. So the Moonshot program, Quad Moment, lot of emphasis, and our people discussing that, you know, our problems, our solutions. We have eminent people sitting here who did a lot of work, and towards the end, I'll take chairperson's opinions on all these things who are pioneering in these kind of work here. So Quad focus on cervical cancer as a poster child. So I would like to ask Dr. Ranjit, you can talk about this. Then why cervical cancer? What is special about this, especially in Indo-Pacific region? Why this was chosen as first?
Thank you. It's a real honor to be in this panel. I would like to highlight 2 important points over here, and which has been included in the Quad program as well. The low-lying fruit. Cervical cancer, as Dr. Haribhakti said about the oral cavity and trying to prevent tobacco-related cancers. According to that document, in Indo-Pacific region, there are 10% vaccine coverage for HPV and 10% screen detection effort. So I think that's a huge opportunity we have to cover for those and bring down the cervical cancer related death. So I think that's probably one of the most low-lying fruit. The second aspect I would like to highlight is the public-private association. So as highlighted by everyone, that none of us in individual capacity can gain so much ground in comparison to if we collaborate. So if we collaborate, naturally we are going to have a lot of ground covered, and I'm glad that, as Prime Minister highlighted, and there's quite a bit of emphasis to give first, India can contribute in terms of tech, what we are developing the database across, and also in the vaccine. So already government has assured that we'll be providing vaccine not only for covering the Indian population, but the global. So I think that's the way forward. The collaborate treatment, of course, yes, it's important, but I think policy and connecting those dots would be crucial. Thanks.
Thank you for this. I think very important. I'll move to Dr. Deepak. Dr. Deepak Rotre, your take on these aspects.
Okay, at the outset, it's a matter of pride and privilege to be part of such an eminent panel, so I thank the organizers. I would think cervical cancer is of immense concern to any cancer program in India, because number one, it's not as much a concern in the West as it is in India in terms of prevalence. And number two is cervical cancer lends itself very well to both primary and secondary prevention. So we had the Western vaccines for quite some years, and now we've got our own vaccine, and at possibly at 1/10 the cost of the Western vaccine. And with a little more push, we should be incorporating it in our vaccination program soon. And secondly, we've got a very robust program for early cancer detection for cervical cancers, be it the PAPS, be it the VIA, the colposcopy, or whatever. So I think given the situation of cervical cancer in India as against the West, we definitely need to address it more aggressively and try and get it early and treat it to the best of its outcomes.
Sure. So we have with us Mr. Dinesh Madhavan online. Dinesh, can you hear me? We have online presence of Mr. Madhavan, I saw him. Okay, so meanwhile, I'll ask Biren. So Dr. Birendranath, you are a molecular geneticist. What is your take on all these collaborative aspects? And then we'll go to Mr. Dinesh. Oh, so he is there. So maybe Dinesh, you can take from, because I want a different flavor. So from the administrator's perspective, what do you think, how can we move forward in this space?
Am I audible?
Yeah, you are audible now.
Thanks, Jyoti, and the organizers for putting this together. And it's a pleasure to be on this forum with distinguished luminaries, including Dr. Allison. My apologies for not being there in person, travel pre-commitments. It's a historic day for 2 things. We're looking at sharing, and there's nothing better than success which is shared. It's also historic because today's budget speech changes the paradigm from what it was earlier. If those who have been following the budget speech will know that cancer drugs are now exempted from custom duty. One. Second, the government has announced over 200 daycare cancer centers in the next 12 months across India. And in the next 3 years, the government is set out to establish cancer centers in every district. What does that mean is to actually increase awareness, early diagnosis, collaboration, more precision. But I would also urge through this forum, if we could learn from some of the best practices which MD Anderson has brought into the US and get a collaborative approach, because to me, I think the best way in this space is to collaborate between public and private in India, create a universal cancer care policy. Unfortunately, we have a divided house when it comes to notifying cancer, and I hope we will overcome that. And I also hope to see a few more decisions taken by the government, which includes importing equipments, which are huge customs duty, and there'll be some relief to that. Because to me, for a country which is about 1.5 billion, the largest population in the world, with close to 1.6 million being diagnosed, you will have to make it accessible, and that can only happen if private and public get together. Thank you.
Thank you very much. It is extremely useful. So we'll move to Dr. Birendranath. Your comment, please.
Well, thank you, Dr. Jyoti. First of all, it is a privilege to be allied to Allison. And as an organizing community, as a city, Bhubaneswar is proud to host one of the geniuses of the planet today. So my take here is very simple and practical. In this part of the world, I would like to give you real life, real world 30-second head start. Dr. Sarangi is sitting here. Dr. Rautrai is heading the largest cancer institute of the state. So what we have done here is we have spoken to the government post-COVID, and we have told them that the newer drugs are on the platter, and we have to make it available. How do we do that? We have to test the patients to make it available. So as one of my panelists was mentioning, pathology is the key. So we have moved from tissue to the receptor to the DNA. So we live in a world where DNA is real and it is no more fancy. So we do the DNA testing as well as the screening. And in the November month, we have screened over 10,000 papilloma patients for cervical cancer here in this part of the world. And we offer free NGS testing for whoever is eligible through the government, absolutely zero cost. This is the first effort in the country by our cancer care program. So if we can dream big, we can do it. Moon is not the benchmark. India has proved that we can go to Mars at the cheapest. We offer genetics at the cheapest cost in the planet.
Well said, and this will be the topic of my panel, the next I-OSICON. To reach to Mars. Yeah, please.
Since Professor Allison is here, bringing to from a clinician's perspective, sir, you taught us that immunotherapy is one of the pillars of treating oncology and probably one of the curative pillars of treating oncology. And so immune checkpoint inhibitors have really created a revolution after your pioneering work. But still, there is the elusive problem of how do we identify which patient is going to respond and which patient is not going to respond. And we have been following your work and Dr. Sharma's work, and we do understand that it's not enough to know about some of the basic biomarkers like TMBs or PD-L1. You have moved on to show that we need to know about the Tregs and also look at the markers for the T-cell exhaustion like LAG3. And the trouble is, how do we measure all these things? Is there a tangible platform or something? Because these drugs are expensive, and if only we can clearly identify who's going to benefit and who's not going to benefit, and we know that individually these markers can be measured by IHC's flow cytometry, and some of the labs are trying to put a panel of what they call as immune profile scores and all. Where are we, sir? You can tell us in clearly identify who will respond, who will not respond. That will be a big resource saving and patient benefit.
obviously, if we could get a baseline specimen from a patient and predict what he would respond to, that would be ideal. I don't think, with our knowledge base now, we can do that. I think that what we can do a better job of, due to the work as Dr. Shorma does, is get on-treatment biopsies and decide very early on. It's not as good, perhaps, but I think we're within reach of doing a pretty good job of early on-treatment within 3 weeks, let's say, or a month, be able to have a pretty good idea who's going to respond at that point. And maybe we could work backwards then as we get more omics and with the magical word AI these days, and work backwards and filter it out there. But I think we've got a long way to go. I don't think there's any magic thing now. And you're right, PD-L1, those things, they're not all that useful, really. You need to know what's happening later after you change those.
Sure. So we have one question on the microphone. Gaurav, you want to ask something? Yes.
Yes, thanks a lot. I really was taken by Professor Allison's lecture, and especially when he was talking about things that we are looking at which may never have single agent activity but can actually improve the outcomes by modifying the T cell or lymphocyte behavior. So both in the field of checkpoint inhibition and cellular therapy, which our groups are looking at, we are looking at a lot of these agents which might improve the metabolic fitness or change the exhaustion phenotype of the lymphocytes back again, and they may never have single agent activity. Whereas that's the way the testing goes. What's going to be, how are we going to bring these things into the therapy pipeline? And I was, I was just taken by that 3 decades ago, you said that CTLA-4 inhibition is going to work, and no one was listening to you. You told us about that story. And now it's 3 decades later, you have a Nobel Prize, and they're still not listening to you? Where are we going to go from here?
So the basic question was, how do you think we're going to move it forward? I think by focusing now on getting specimens from patients that are on treatment, looking at the changes that have occurred, identifying commonalities. They may be different. The checkpoints that come up after initial treatment may differ from cancer type to cancer type. Hopefully they won't be too individually specific. We don't want to go down that road, although we could by sequencing, making vaccines these days. I mean, that technology is within reach. But I think what we've got to do, unfortunately, these days is in the basic and translational labs, come up with suggestions for the new drugs, show that they're safe, and try to convince the pharma companies to change a little bit about the way they do it, because we can't go the next step. We can't do the large trials, obviously, but come up with a way of getting better interactions with the companies where we get to a certain point and say, we think this looks pretty good. It's not got a 90% chance of failure like most drugs. It's got a 30% chance of failure. And we can de-risk it, we can predict it for certain patients who respond a certain way early. That sort of thing. It's going to take a teamwork between pharma and the laboratories to do that.
So I think one of the things to think about is what are the small projects that you can really prove the concepts of how this country can move the field forward. And if you take some lessons, for example, if we look at MSI status or tumor mutational burden, and it's exactly as you said, every patient in India who's coming to see an oncologist should be getting sequencing data, without a doubt. I mean, this is the first step. And then after that, you can say, we will create our own biosimilars. Stop worrying about the expense of the drug from Merck or BMS or whichever company. India has the capacity to make an antibody. These are not complicated things to make. An anti-CTLA-4 and anti-PD-1 are very easy to make. You make one that the country now has without needing to pay the price of other pharma companies. And then you conduct a trial with your antibody in your patients that you've sequenced for MSI or TMB, and you show that you get 80–90% response rates in those patients. Then you become the hub of being able to show that you can take a drug that you created all the way through to a clinical trial and really benefit a subset of patients, and you build on that. So I think that's the pieces that you need to put in place, and it can be done here.
Absolutely. I think this is the most important thing, to be self-sufficient, and also with these kind of collaborative efforts and support from you all. Perhaps this is the way forward, and we should certainly brainstorm on these lines. So Dr. Sangeeta, your take on this, and also the role of international societies and, further collaborative moments.
Yeah, before I get to that, one thing I would like to say, population density is a weakness of this country and a strength of this country, right? And we should always think, how do we utilize this strength? And I was looking at the list of all the cancer types that, you guys, we were all focusing. But one thing that is close to my heart, and I want to advocate, is the rare disease population. We often kind of try to ignore that population. There are not enough trials available. And issue is this, like many times those rare cancer happens in younger population. And it's a really difficult situation, right? So because of the density, I feel that you will have more N in terms of statistics, in terms of understanding the disease process. So that is, I feel, not really a low-hanging fruit, but because of that you have the numbers, something to kind of have more insightful information on those rare disease setting that could also be evaluated here.
I think very, very important point you made, and certainly when millions or billions of population, even 0.1% is substantial.
Exactly.
So for instance, I'm very passionate about rare cancers, and in Tata Memorial, which was my prior institution, I was seeing the maximum number of sarcoma cases anywhere in the world that way. So definitely we can contribute in certain areas much more. A couple of panelists mentioned our problems, squamous cell, cervical cancer, many other, and rare cancers, of course. So even in breast cancer, triple negative variety, aggressive one, younger. So these all things are perhaps a low or at least a middle hanging fruit, I would say.
Yeah, exactly.
And we should certainly target with the collaborative efforts. So now, because we are moving towards the end, and I have to hear from our eminent chairpersons, their take on, all these aspects, what we have discussed. So Dr. Rath, your.
So far as the cancer is concerned, India is in a unique position. We had a meeting 2 months back of the Indo-US Moonshot program. The officers of the American ambassador to India, our ministry personnel were there in our National Cancer Institute. We have a big National Cancer Institute near Delhi. India can be considered United States of India so far as cancer is concerned. Why do I say that? The incidence of cancer is absolutely non-uniform so far as India is concerned, and this is our 43 years of our own registry. The lowest incidence of cancer in India, for our friends from West, is 40 in a place called Barsi in Maharashtra, western part of the country. The highest is in a place called Aizawl, which is northeastern part of the country. 40 to 280 is found nowhere in the world. 7 times different in the same country. What are our peculiarities? So we can be called United States of India so far as the cancer incidence is concerned. It's like a mesothelioma. So to study cancer, this is the place. The lowest incidence of cervical cancer is a place called Kerala, down south. Highest is in a place in northeast, is 25 per 100,000, 25 per 100,000. Breast, lowest is 9, highest is 40, in this country only, which is absolutely very unique for this position. The second, what the government is working on, as Dr. Jalali also told, on 3 things. Prevention. India is a place where prevention is seen every day, and we are working on it from the government side. We have a state called Punjab. People don't smoke there. People don't chew pan there because of several reasons. One is that they have some religious beliefs that they can't, chew, tobacco. Second, if they smoke, their long beard of 10 centimeters will be burnt. So they can't smoke. Physically, they can't smoke because the beards are so long and 6. So proof is in India. There's another peculiar cancer which is called gallbladder. We are the second important place in gallbladder, 17 per 1,000, 17 per 100,000, next to Chile only. And that's where 3 things we are working on. And we have establishing a lot of regional cancer centers, giving a lot of money. I'll say, I don't know how much in dollars, 120 crores for a regional cancer center. Thank you very much.
Thank you, very inciting. And Dr. Sudeep Gupta is with us online, so I would like to hear from him your comments. Sir. Dr. Sudeep is with us online, Siddhant. Till the time he is joining.
He was also present in that Indo-US meeting.
Sorry?
Dr. Sudeep was also there in that meeting.
Sure.
in our cancer.
Okay, so Dr. Sudeep, would you like to comment upon the aspects we have discussed today? So meanwhile, I'll want to hear from Dr. Banavli, and one can reach me.
Yeah, thank you, and really great to hear so many people on the subject. You know, definitely India, I think one of the most important thing, again, has been repeated again and again, is we have to concentrate on cancer prevention. We have low incidence, but you have to make sure that how we do not allow to increase it like the West, and how we can prevent it. That's one part of it. The other, you know, I think this is a 3-day meeting, but again, it's something close to my heart. We are talking about immunotherapies, but only therapies that we are talking is the stimulatory immunotherapies, you know, the inhibitory immunotherapies, you know, the metronomic therapies that I work on, how we can use that, not one lecture or one session on that, because that's something which is cost effective for our country, and we have to look at it. It may not be the real science, it may not be as much, you don't have that much hard data, but we have to create that. If we don't create, who will do that? And the other part which I really feel is that, you know, the toxic therapies cytotoxic therapies is different, but the MTD base or the drugs that we test as per our regulatory thing has to be used in the patients who are multiply relapsed, you know, large tumors and all, but whether the biological therapies, the doses that we use in that type of thing are the really ones that are good enough for early cancers, you know, I really feel the drug like, you know, bevacizumab, which is used as an anti-angiogenic drug, always started being used in multiply relapsed large tumors. But whether if you want to prevent the angiogenic switch, whether that is the dose of 1/100th of that dose or 1/10th of dose, nobody has tried. You know, all the immune therapies, whether, you know, the doses that we use in the relapse setting, we use the same one in the early setting and then say it doesn't work, or, you know, it may be different. So we have to, maybe we have the infrastructure, we have the patients, whether something different has to be done, that's the other thing. And the last thing, which is, again, we are in India, you know, we have other pathies also, like, you know, we have Ayush, the Ayurvedic and yoga and all those. How can we integrate that? Also has to be looked. If we don't do, who will do it? And these are Ayurvedic therapies, for example, they are very immunomodulatory therapies. How we can use that, I think we have to explore that. So there are multiple things that we have to look into being in India here, I think, and that will help us to bring it, do it cost effectively. Sure. The biosimilars and all are there. It will bring down the cost, but other things also may bring down the cost.
Absolutely, very well taken these comments, sir. So Dr. Sarangi, your quick comment, and then Dr. Sudeep Gupta towards the end.
I'm a surgeon, but for last 10 years, I've been working on cancer public health in the state. Creating a standard treatment for cure of cancer is different. How to implement it at the grassroots level. That is how it's going to bring down your 50% death. Unless you achieve that, no amount of vertical science is going to have any meaningful impact. And while sitting in this symposium, I think 2 of my questions have been answered, which I've been pondering for last 8 to 10 years. Number one, when you do an extensive screening, Government of India has got an extensive screening program. We are doing a grassroots screening, but we are not able to mobilize those people who have been identified as some abnormality to the center where they can be addressed. That's a big challenge. And today the budget speech has made it a little easier. Now they were going to have 300 district cancer care programs, which will address this issue at a district level. And Odisha has started in 2016, 30 districts nodal cancer care program. Now that's going to be strengthened. That's a big achievement. Number 2 is how to bring down the cost of all these expensive drugs which have been manufactured. Unless these are being used by a patient with a curatable intent, whatever may be available, it's not going to bring down your mortality. I think Dr. Sharma has given that answer.
Sure.
It's a difficult task. It's a very, very cost-intensive and technically intensive task, but it's still doable. We have to have our own drug to make it cost-effectively available.
Sure.
I think these are the implementation area which we should work for. Thank you.
Sure. So Dr. Sudeep Gupta, your comments. And we actually missed your presence.
Yeah, so thank you very much. I also miss being there in person, but I listened to your panel discussion and the previous talk very intently. Whatever is required to be said has already been said by others. Let me just say that we need both cutting-edge innovations, including of the kind that Dr. Allison and Dr. Sharma have pioneered. We also need to better implement what we already know. And some colleagues and others have coined the term ground shot for that endeavor. So for example, we need to implement routine surgery, radiotherapy and chemotherapy much better than we have, at least in countries like India, as well as having these cutting edge innovations. And I'm sure that we will bring down the mortality due to cancer. I must add that, I was looking at the data. The case fatality ratio for cancer in India is about 60%. The case fatality ratio for cancer in many countries of Europe is about 35 to 40%. So we have a higher fractional mortality due to all kinds of cancers. That of course is because of late stage presentation and several other factors. And I'm sure that everybody together, including in collaboration with colleagues from the US, we can all learn from each other, and we will move forward. Thank you very much.
So thank you very much. And we are towards the end. So I begin with the JF Kennedy's speech of why we go to the moon, and I'm ending with that because we go to the moon not because it is easy, but because it is hard, and we wish to win these challenges. And in any panel, if Dr. Allison is there, I believe the last word should be from him. So your last word, and we will end the panel here.
This has been a fascinating meeting to come to. I consider it as sort of a continuation of that Moonshot meeting that we ran in Delhi earlier in this last year. Anyway, but I look forward to. I think you're on the right track. I think there's a lot we could do together. We're going to help you. I think the idea of getting your own antibodies and getting in the fray in a big way is an important step. And let's get with it.
Thank you very much. Thank you very much. And we will proceed for our inauguration ceremony from here. So thank you very much, the panelists. And I'll request Dr. Allison, Dr. Sharma to be here for the inauguration also.
Recording stopped.
I'll further invite Dr. Hemant Malhotra, Dr. Jalali, Dr. Biswas also to be here for inauguration. I'll call the Master of Ceremony for today for the further proceedings of inauguration.
So with this, we come to the inauguration ceremony of 6th I-OSICON. I would request all the dignitaries to kindly come for the inauguration ceremony. I would like to invite our guest of honor and Nobel laureate, Professor Dr. James P. Allison, Professor and Chair of the MD Anderson Cancer Institute and Director of the James P. Allison Institute. Chief guest Dr. Padmini Sharma ma'am, renowned physician scientist at MD Anderson Cancer Center. I would also like to invite Dr. Hemant Malhotra sir, President IOSI, Dr. Jyoti Bajpai madam, General Secretary I-OSICON, and Dr. Ghanshyam Biswas sir, the Organizing Secretary of I-OSICON 2025. We would now like to head for the lighting of the lamp. We'll now proceed for the Utkal Vandana also.
वन्दे उत्कल जननी वन्दे उत्कल जननी
वन्दे उत्कल जननी
वन्दे उत्कल जननी
वन्दे उत्कल जननी
चारुहासमयी जननी जननी जननी
वन्दे उत्कल जननी
वन्दे उत्कल जननी पूतपयोधि विधौत शरीरा
तालतमाल सुशोभित तीरा
शुभ्रतटी निकुल शिखर समीरा
जननी जननी जननी
I would request Dr. Jyoti Bajpai madam to please proceed and give bouquet to James P. Allison sir. I would also request Dr. Hemant Malhotra sir to please give the bouquet to Dr. Padmini Sharma madam, please. Thank you. Dr. Jyoti Bajpai madam to speak for 2 minutes.
So thank you everyone. It is extremely delightful, and I'm feeling truly honored that what we were dreaming since a while is actually happening today, and everybody witnessed the great work what Professor Allison, Professor Sharma, and other colleagues, Dr. Goswami and Dr. Betty Kim is doing in MD Anderson, and how can we collaborate on many fronts and really at least try to go to the moon. That's where I am, and I will not take much of the time, and I will hand over to Dr. Malhotra for to say a few words further. Only one additional thing which I want to make here is that I'm super proud that Immuno-Oncology Society of India, which is kind of a brainchild to me and my colleagues, we really tried hard to conceptualize this society, and we tried that this society should provide a platform for both clinicians and scientists together to come on one stage and work towards progress of immuno-oncology. With the help of many colleagues like Dr. Sharma, Dr. Allison, and several others from Europe and US, we are initially making infantile steps. I'm proud to say that now these infantile steps are turning into children's steps at least. And we are certainly going to collaborate further. We are part of World Immuno Council, the 20 partners by Indian Immuno-Oncology Society is one of those partners. And every year we are having, alongside SIDSI, that is Society of Immunotherapy of Cancer, our own presentation also in these forums. We are collaborating with the European Society of Medical Oncology, Japanese societies, and several others. So we will definitely keep on progressing with all of your help, and we'll keep, doing good work. And I hope with these all things, we can certainly reach to our goal, what is being, really established. Thank you very much.
Thank you, ma'am. Now I would request Dr. Hemant Malhotra sir to please speak 2 words.
Sure. Thank you very much. Pleasure and privilege to be here and share the dais with luminaries like Professor Allison and Professor Sharma. I remember that afternoon at Tata Memorial Cancer Center 6 years back, where we had the first meeting in which we conceived and formed this organization, this society, the Immuno-Oncology Society of India. And our basic aim at that time was that we wanted the bench and the bedside to get together. We wanted more collaboration between our laboratory experts and our clinicians. And our first founder president, Dr. Shubhda Chiplunkar, she's sitting there in the hall. She represented the bench, and the second president, which is me, and I was the founder vice president at that time, I represent the clinicians. So we are really truly trying to, bridge this gap together, and I think that is fundamental in developing our own immunotherapy protocols and our own immunotherapy drugs. Our founder treasurer and our present treasurer also, Dr. Gaurav Narula, is a clinician. He has associated along with the team from AdTrack with the IIT and Dr. Rahul Purwar, who is again a laboratory worker, a bench expert, and between them they have developed the first Indian CD19 CAR. They are well on the way to developing the BCMA CAR, which trials will start. Happy to tell you that the CD19 CAR trials have been done. It's approved by the regulator of our country, and commercial production has started, and more than 200 patients of lymphoma and acute lymphoblastic leukemia in relapse have been treated with this product. And I'm also very proud of the fact that the present data indicates that this product is as good, if not better, than the international products. And this is at 1/10 the cost of the international products. So this is like a really good start in the right direction. Individual in this country, every single patient in this country who needs it. There's some data from Tata Hospital that as of just now, 1 out of 10 patients in whom the drug is indicated can afford it, gets it. We have some data from my institution, which I will show during the oration tomorrow, the presidential oration, that it is even less in smaller cities. So we really truly need to change that. Immunotherapy has now become the 4th pillar in addition to chemotherapy, radiation therapy and surgery in the treatment of malignancy. But we have to make it accessible to more and more patients of ours. And as Dr. Sharma said, that unless we do develop our own small molecules, our own antibody drug conjugates, and our own immunotherapy molecules, we will never be able to bring the cost down. So I think I urge each one of you, representatives from the bench, representatives from the bedside, laboratory experts, clinicians, to come together and take this field forwards so that we can provide equitable cancer care to all our patients. So I hope you have a wonderful conference, enjoy the scientific content, interact with Professor Allison and his colleagues on a one-to-one basis, and also enjoy the excellent social program which our organizers have laid down for us. Special thanks to Dr. Ghanshyam Biswas and his team for having worked very, very hard and not only collected these galaxies of experts for us to meet and interact with and hear and listen and learn, but also this excellent hospitality, this beautiful hall, this near perfect audiovisual, and really thankful to you, Dr. Ghanshyam, and the team. Also like to acknowledge the leadership and the guidance of the incoming president, Dr. Rakesh Jalali, one of the leading neuro radiation oncologists of the world. This gentleman is instrumental in developing guidelines which guide treatment for radiation oncology, especially brain tumors world over. We're very proud of you, Rakesh, and I'm sure that with you leading this organization and this society, we will progress by leaps and bounds, and whatever I could not do, you will be able to do. Thank you very much.
Thank you so much, Hemant sir. I would like to request Dr. Rakesh Jalali sir to come and share his few thoughts on this occasion.
Thank you very much, Dr. Malhotra, for those kind words. No pressure, very big shoes to fill in, but may I just begin by, again, congratulating Jyoti, Ghanshyam, everyone to do a stupendous effort for organizing this meeting. Some of you may know or may not know that it was in the corridors of Tata Memorial, I think 7-8 years ago, because on the 11th floor, and there are fair number of Tata Memorial people here, fortunately the radiation oncology rooms for the faculty are just in parallel to the medical oncology. So this fair bit of discussions were happening in the corridor rather than, and in addition to the tumor boards. And therefore, I kind of incited the idea to Jyoti and others that we must have an Immuno-Oncology Society. I had some experience to start the Indian study of neuro-oncology about 20 years ago. So we gave the constitution. We were not sure how it is going to be. Very baby steps, and what a proud moment for all of us to see to some amount of fruition and only better things to come. I truly believe in my heart, truly believe without exaggeration, that this is a milestone and momentous meeting. Not only for Dr. Allison's and Dr. Sharma and many other the very illuminating names to grace the occasion, but also having the humility to accept that what are the challenges. And also, I also believe that the previous discussion could be the perfect example, not only just to discuss, because we have done this many a times, but to come out with concrete steps. And I can assure you, we are not going to leave it. There's a great deal of enthusiasm, both from the bench side industry, the clinicians, now perfect example from the government, and also the patient advocates. There's a fair number of patient advocacy also now in India. And we will write a white paper on it. We will do a priori, very small projects with the collaboration both internally to the rare cancers, for example, our own innovation, whether it's drug development and optimal combinatorial therapy, the pathology and the testing part of it. Very smartly and judiciously, we have to devote some resource and time for the international collaboration, but also devote a lot of time for our own problems, whether it is TNBC, oral cancer, and rare cancers like glioma, I can't not mention glioma, and also sarcomas and so on and so forth. So these are truly exciting times, and I would request all of you to kindly help us to get this dream in fruition. And it is appropriate actually, because any major monument and building has to have 4 pillars. No monument will ever get on the 3 pillars. So we truly are there for the 4th pillar, and all of you, your students, your fellows, your trainees in the next decade or so will be truly exciting and memorable times. With these, I thank you very much for your continuous participation and look forward for your scope in the next few years as well. Thank you.
Thank you so much, Rakesh sir. Now, I would like to request Dr. James Patrick Anderson sir to please share a few words.
I must say I really enjoyed being here at this meeting, seeing the interest, the excitement about teaming up with us in the States, if we can, under this new administration, if they continue with the commitment that President Biden had. I think it'll bode well for success along the lines of the things that we've been discussing this morning. And I view this as not the first, but the second meeting that I've been in to discuss, that Pam and I have been able to discuss these things, and perhaps the more important one, because we've got more people here, and I can see momentum coming out of this meeting. So I look forward to great progress and bringing all the modern cancer therapies in an affordable way to the people of India.
Thank you, sir. I would like to request Dr. Padmini Sharma ma'am to say a few words as well.
So thank you all again for the opportunity to be here, to share our ideas and to listen to your ideas. I do think that this is a new society that is making great steps, so congratulations to all of you who've really put this together and brought all of the different teams together. I do think that in terms of moving forward, it's going to take real discipline in how you want to put your working groups together. So who are in charge of the working groups to make the first project that you're going to move forward with, which is the company, who's funding the collection of all the samples, and who's going to be doing the scientific parts in the lab, and who's going to be writing the clinical trial. These are all the really detailed parts to have successful outcomes. And I think that those are the things that hopefully after this meeting, some of you will get together in those working groups and say, we will be the working group to move the clinical trial. We will be the working group to get the pathology together. We will be the working group to really put the pieces together to get all of the sequencing done. And then that is how you can have the real outcomes for the people of India and for cancer care here. So thank you all.
Thank you, ma'am. Now, I would like to request Dr.
So 1 minute. Both Dr. Jalali and myself, we omitted a significant thing which we should not have omitted. But you know, when you do a function in the family, the nearest and dearest in the family are not thanked and not appreciated. So I want to fix that before Dr. Ghanshyam comes for his vote of thanks. We want to jointly thank Dr. Jyoti Bajpai, who, we did not mention by name, but would like to very much mention by name now, who's been the founder secretary, the brain behind formation of this organization, and she is still the present secretary, and she is the moving force behind this organization. Big round of applause for Jyoti.
Thank you, Hemant sir. I would like to now request Dr. Ghanshyam Biswas sir, Organizing Secretary, I-OSICON 2025, to share a few words. A huge round of applause for him, please.
There is always a woman behind every success. So behind I-OSICON is Jyoti. behind Dr. Allison is Dr. Padmini. So, respected Dr. Allison, Dr. Padmini, Dr. Sangeeta, Dr. Betty, my teachers from whom I learned oncology, so Dr. Tapan Saikia, Dr. Banawali sir, Dr. G.K. Rath. My seniors in oncology were all there, my classmates, batchmates. So last few months and especially last 4 months has been a horrendous. So post tomorrow, I want to have some sleep. So the circadian rhythm has absolutely gone wrong. So managing both ends, the practice and the conference. And you must admit that you are in a vibrant city, a city which has seen a lot changes in the recent past. And Odisha is said to be the incredible part of India. The many secrets have been still hidden. This is a land not only of Jagannath, so lot of kings, rivers, and there are natural beauties. So you may take months if you go around every corner of the state. So I completed 20 years after my oncology journey at TMH. So I complete 2 decades here, serving my own land where I am born, with blessings of my late parents, with blessings and handholding of my teachers from medical school to oncology school. And we have seen a vast change in oncology. I particularly, in last 2 decades, in 2005 and 2025, the sea changes. We have moved into a precision oncology, and we cannot forget the contribution of Professor James. We are talking about immunology, immuno-oncology, and India is proud to have their generics soon, and definitely so we'll go into the masses. So thank you, friends. Thank you, colleagues. And I especially thank my Sparsh family who has been with me in my journey for last 20 years. My family, my parents' blessings, all good wishes of the colleagues. I also thank Rajesh, Mice Idea teams who have been phenomenal working in unison. And I also thank Mayfair Group, the convention Lagoon, for their hospitality. So if I miss somebody, so that is not intentional. Lastly, the most important point, any conference cannot be done, and especially in last 7 months, we have done 3 international conferences. So that was probably a task-taking, tedious. So all the pharmaceutical companies who have come forwarded for their academic endeavor, supporting the cause, and only one man, so Dr. Allison's stature was enough to motivate people. So thank you, ladies and gentlemen. And before we go for the lunch, so everybody wish to have a photograph with Professor Allison. So sir can be on the dais. So the front row too can come, and then we have a group photograph. Thank you, friends. Thanks so much.
Ghanshyam sir, I would like to request you to present mementos to Jyoti ma'am and.
So also thank the past president, Diploma Madam, so the present president Hemant sir, and the future president Jalali sir. So we'll also felicitate from Dr. Allison to Dr. Jyoti, Dr. Jalali sir, and Dr. Hemant. So Hemant sir. Konark. So all of you can come forward for photograph, please.
While everybody is coming, I also wanted to put on records about Dr. Padmini Sharma, who herself is a very big leader in immuno-oncology, and on a very lighter way in what Biswas said, that behind the success of every man and Dr. Allison, there is a Dr. Padmini. And I would also say, behind the success of Dr. Padmini, there is Dr. Allison. So, she is of the equal stature, and, I truly believe, and I say her also, that with her pioneer work, we are calling one Nobel laureate at present. In future, we will be calling the second Nobel laureate in her shape.
Dr. James Allison did not begin his career trying to cure cancer, but his foundational discoveries have transformed cancer care and saved countless lives. Dr. Allison started with a desire to better understand the immune system.
It was amazing. I've never seen so many people so happy. It made me feel sort of embarrassed in a way, but on the other hand, happy because everybody there was so happy with so many people. It was the whole teams out there.
It was absolutely incredible. Just the enthusiasm, the energy, the signs, the cheers, the selfies. It's something I will never forget.
Just so proud to be a part of MD Anderson at this point. Just wow.
We're proud of you, Dr. Allison. Good job.
I can't think of any better place to work and better people to be around. We just saw it in the hallways with MD Anderson. I heard the news this morning. I was stunned just because I wanted to know how T cells work. Ended up helping people with cancer. I'm a basic scientist. In fact, I got it for physiology and medicine. It's so gratifying to me. I think my prize will impact everybody to come up. Helping work there. It's making a big difference. The teamwork there and the spirit that people have and the desire to help cancer patients is impressive. I've been a cancer patient myself. It's really special. As far as I know, first Nobel Prize has ever been given for cancer therapy, and I hope that it will create optimism. There is hope, and we're still working and trying to make it better. There are already many types of cancer that respond, but some that don't. And that's the big challenge that we face now, is how do we get at those? The cancer field has begun to accept immunotherapy now as the fourth pillar, along with radiation, surgery, and chemotherapy.
So thank you all.
It's not going to replace all those.
So you have seen one video. So this is another video created for Dr. Allison and Dr. Padmini with all music background. So while we move for the lunch, so there are posters downstairs, and I request every faculty to be in the. There are stalls, so you can move around. Thank you so much.
pathway will be activated, allowing us to
We're about to begin the post-lunch session, and it's always challenging to keep people awake post-lunch. I request everyone to be a little awake. Grab some coffee if you need to be awake. Our first speaker is Dr. Prasant Narayan, medical oncologist, Bangalore. He is going to talk about immunotherapy combinations in early stage NSCLC.
Hi, good afternoon. I hope that I can keep people awake. I'm 100% sure that by the time Ullas comes for his panel, he will make them very awake actually. So we have heard about immunotherapy, the evolution, and excellent sessions. So I thank Dr. Jyoti and Dr. Bishwas for this opportunity. So when we talk about immunotherapy in early stage NSCLC, I can't see the presentation here actually. Yeah. Yeah. So I was told to discuss about immunotherapy in resectable non-small cell lung cancer. And when we talk about this, I think the initial data was in advanced stage lung cancer, and now we have more and more data in resectable lung cancer. This, why the interest in bringing immunotherapy in early stage? Because patients have more intact immune system, the draining lymph nodes are in situ, potential for long-lasting immune priming is there, and it's an ideal opportunity for translational science. So this is the study which was the landmark paper which brought in immunotherapy in early stage lung cancer, the Pacific-1 study, which looked at consolidating with durvalumab after concurrent CTRT. And we all know that this, now it is almost 6 years old since the approval came. And the long-term data also says that there is significant improvement in overall survival. So with this in background, we should also look at what happened after this. So there was a Pacific-2 study, which actually looked at including durvalumab along with CTRT, then followed by durvalumab. So this is more durvalumab as compared to the Pacific-1 study, but this is interestingly a negative study. So when durvalumab was given along with CTRT followed by durvalumab, just like the Pacific study, in the Pacific-2, there was no significant difference in overall survival, which is interesting. And probably the reason why we are now looking at different options of neoadjuvant, perioperative, and adjuvant ways of adding immunotherapy into resectable lung cancer. So we all know what is the attraction towards neoadjuvant, being shorter treatment time, better treatment compliance, perioperative for micrometastasis, and the classic adjuvant therapy. So today I will be discussing these trials. The neoadjuvant, there is the approved data of Checkmate 816. Then in perioperative, the maximum number of trials have been done in the perioperative setting here. We have similar design trials from Pembro, Nivo, Atiso, and Durva. And also 2 trials which are important in the Indian context now, because this is from toripalimab and tislelizumab. Both are now available in India from Indian companies. So then the adjuvant trial, the IM Power, and the Keynote trial. So these are the ways in which the immunotherapy has been done in early stage lung cancer. Let us go to the Checkmate trial, the neoadjuvant trial. I think among all the trials, this is the most attractive because this has got very less immunotherapy and very good outcome. So this is only 3 cycles of immunotherapy plus chemo versus chemo alone in the neoadjuvant setting. The primary endpoint here is pathological CR and EFS. So did the trial meet the primary endpoint? Yes, it met. There was 24% pathological CR, which is incredible in lung cancer. And the 4-year EFS update also shows significant difference. So this got approval based on this data for nivolumab in the neoadjuvant setting. When you see the overall survival, this line that the PAT CR if a patient gets with neoadjuvant nivo chemo, the 4-year overall survival was 95%, which I think in lung cancer is extremely good. Even if there is no PAT-CR, we can see that there is a significant difference in overall survival there. Most benefit being seen in stage 3 and PD-L1 more than 1%. What about the adjuvant data? We have 2 trials. One is the IMpower trial, the atezolizumab, straightforward treatment of adjuvant cisplatin-based chemotherapy for 4 cycles followed by 1 year of atezolizumab. And what about the results? The stage 2 to stage 3A, if you take all comers as well as if you take the patients who had PD-L1 more than 1%, this was the stratification factor, there was improvement in disease-free survival, which is the primary endpoint. If you take the intent to treat population, the impact is not as much as you see with the stage 2 to 3A patients actually. So 1B, if you take, it slightly is less impactful as compared to stage 2 to 3A. The adjuvant Pembro study, very interesting because chemotherapy was optional in this study. So there were patients who did not get any chemotherapy, they just got pembrolizumab versus placebo. And most interesting outcome, in the overall population, the DFS is better. But if you take the patients who had a TPS score of more than 50, it was inferior. So patients who had more than 50 PD-L1 score did worse as compared to patients who had less than 50. So when you compare both these studies, one study, chemotherapy is not mandatory. The primary endpoint is DFS in both the studies, and the outcomes are similar. The Keynote 091, if you take the overall population, the DFS difference is 53 versus 42. But if you take the PD-L1 more than 50%, it is not significantly different. So these are the 2 trials from the adjuvant setting. Now we will go to the perioperative setting where there is maximum data. There is data. All these trials are similar design. The Pembro study or the Nivo study or the Atezo, Durva, toripalimab and tislelizumab all gave chemo plus immunotherapy followed by immunotherapy. And the neoadjuvant adjuvant group, the Keynote study, gave almost 1 year of pembrolizumab if you start from beginning, 17 doses. And the PAT-CR was 18 versus 4. This was the primary objective, was PAT-CR and event-free survival. And this is the only trial in the perioperative setting which has got overall survival data as well, which is statistically significant. Similar design for the Checkmate study. Again, nivolumab with chemo for 4 cycles, followed by surgery, and then 1 year of nivolumab once a month for 480 milligram. And again, the PAT-CR and EFS, similar results to the previous study, similar design for the durvalumab study as well, and similar outcomes. So the takeaways from the perioperative immunotherapy trials, the 6 trials, all these address stage 1B to 3B, all show improvement in PAT-CR and EFS. If that is good enough for you as endpoints, I think this is a standard of care now. The Keynote study has got mature data. Maximum follow-up in this group is with the Keynote study, and the maximum benefit was seen in PD-L1 more than 1%. Also note that the PD-L1 more than 50% did not improve when you gave pembrolizumab in the adjuvant setting. The other studies, the Checkmate, AGN study, Neo-Torch, Rationale, the overall survival data is still pending. So what are the unanswered questions which Ullas will be asking in the panel after this? What is the role of adjuvant therapy in the perioperative setting? Whether we are giving the neoadjuvant followed by why should we give them perioperative, the post-operative treatment, which is pretty expensive when you consider immunotherapy and toxic in many patients. How to manage PD-L1 negative tumors, what is resectable NSCLC in the new era, because we have Pacific 8 data, and when to go for the non-surgical treatments. What about driver mutation positive? So I'll try to put in few slides on this. So the role of broadly, if you see the neoadjuvant, Nivo, EFS and the perioperative data is similar. So whether there is any role of adjuvant nivolumab is something which is which should be discussed in a new clinical trial, which is unlikely to happen. And PAT-CR, negative ctDNA, these are the things like whether we should escalate if a patient doesn't get PAT-CR after neoadjuvant therapy. There were studies, mermaid studies were planned for this, but by the time the IMpower data got approval and the company's, the trial was withheld, unfortunately. So we will not have that data. So this is a meta-analysis which has taken not the Chinese trials, the other trials, the perioperative versus and the neoadjuvant trial, and there is no added benefit from this meta-analysis of giving the adjuvant immunotherapy, the EFS benefit which was seen with neoadjuvant only was similar to the one which was seen with neoadjuvant plus adjuvant. How to manage PD-L1 negative tumors? Positivity is significant in most except the Keynote 091. But all the trials have used different antibody clones, different staining platforms, different PD-L1 expression is heterogeneous here. So it is not a decision-making tool. And the definition of resectability, there is no agreed criteria. MDT is the solution. And to note that none of these trials, the neoadjuvant or the perioperative trials, were designed in borderline resectable or for conversion therapy. So we should not think that we will now give immunotherapy along with chemotherapy and convert some patients who were initially deemed unresectable to resectable. That was not the objective of any of these trials. When to go for non-surgical treatment, very interesting, because the Pacific trial, the one which was approved 6 years back, has the longest follow-up data among all immuno-oncology trials in early stage. But now when you have neoadjuvant therapy data, probably more patients are getting into surgical treatments. There is a gemstone trial, which was again the Chinese. So we should note that China is having trials in all these settings, and all the drugs are ready to come and be used in our market as well. So when to go for non-surgical treatment is also an MDT decision based on the center's capabilities. What about driver mutation positive tumors? Taking all these trials together, very few patients, maybe total number of 100 patients, there were patients who were mutation positive. And so in mutation positive, we have very strong data for the ADAURA and ALINA trials. So as of now, there is no role of immunotherapy in mutation positive tumors in the early stage in lung cancer. So this is my last slide. So there is role of immunotherapy in the standard of care for the curative intent in multiple tumor types, including lung cancer. So novel systemic therapies, whether to give it neoadjuvant, adjuvant, or perioperative, should be individualized, and multiple randomized trials have demonstrated superiority of this approach. And as medical oncologists, we should definitely look at overall survival being the gold standard for demonstrating benefit. There are trials which have shown overall survival benefit in this, but we should wait for more data to see what is the best approach. Also, considering the logistics of just giving 3 cycles of neoadjuvant nivolumab as neoadjuvant therapy, getting the almost similar EFS as compared to 1 year of perioperative approach. Thank you.
Thank you, Dr. Prasad. Have you started using the neoadjuvant immunotherapy in
Sir, I don't get many patients who are resectable lung cancers, actually. So I think this should be answered by maybe Ullas, who has got more patients in this setting. But if I am, after reading this entire data for preparing this talk, I think I am more convinced in terms of logistics that if at all we should try in the neoadjuvant setting.
I think, yes, sir, we have been using it. I mean, not to that thing in which we use in the metastatic setting, but it's really good to done. The only thing is the surgeons feel that while doing surgery, the lymph nodes get a lot of fibrosed. So doing a lymph node dissection is slightly difficult at that time, but it is doable. It should not be.
Unless there is when I was preparing for this, I went through this point actually. So there is a large data which says that this is not true actually.
Correct.
And there is no negative inferior outcome regarding lymph node dissection also after immunotherapy. So I think that is a perception basically.
They say it is doable. That's what I said. It becomes hard, but it's doable.
Right.
That's what they say.
If it is going to be just giving neoadjuvant alone, it would be the best which we can look into it.
Between adjuvant and neoadjuvant, sir, I think neoadjuvant scores far more cross-trial comparisons, but neoadjuvant is definitely better than giving adjuvant. And whether you want to give perioperative, that's a session for debate all throughout, sir.
And there were recommendations that the approval should not be given for the perioperative trials actually. Strong objections raised saying that we don't have the comparison, but the approval came.
Okay, thank you, Prasad. So we'll now next move on to the panel discussion by Dr. Ullas Batra, Senior Medical Oncologist from New Delhi. So he will be moderating the panel discussion on this immunotherapy in lung cancer. So it is over to you, Dr. Ullas, for your calling on to your panelist.
Thank you, sir. And can I please call upon my panelists, Dr. Bharat Bhosle, Dr. Nikhil, Prabhat Malik, Dr. Venkateshwara Rao from Vizag, Dr. Lucy, radiation oncologist from Cuttack, Ankit Batra from Dehradun, Mubina Turns from Mumbai, Gautam Panda from Bhubaneswar, and Lal Mohan Swai from Cuttack. So I think Bharat has just introduced a new term called as the Allison effect. Post-lunch, everybody has disappeared with Dr. Allison, so you know, and that is what is... so we will try to make up for that, and we'll probably try to, you know, get some, let people not sleep on this. So those are the true medical oncologists, sir. Okay. So panel discussion on lung cancer. So there is no immunotherapy, target therapy, anything. We will discuss whatever comes to our mind. And Dr. Sahu has already stood up over there. You're asking me a question on this also, Dr. Sahu? Okay. So my first reactions when I was asked to speak about, panel discussion on lung cancer and I-OSICON was like, listening to James Allison, it all looks like everything is going to be a smooth ride, You will just, when immunotherapy, target therapy comes, it's almost like this is the way Sahu behaves in Goa. So, aram se go to a beach and go around throughout over there. But my subsequent reactions actually are to welcome to reality. I mean, I was just listening to Prasad saying how many neoadjuvant immunotherapies we give. We don't give actually much. And there's always a reality check. What you think you are is like this, but what you end up actually is one on your right side. So, we will start with a real world case discussion. We have a 60-year-old female who is an ex-smoker. She came with a history of cough with expectoration and breathlessness. PET scan was done, which showed a right upper lobe mass with lung nodules and right pleural effusion. MRI brain said there was no evidence of metastatic disease. Biopsy was done, which came as adenocarcinoma, TTF1 positive. PDL1 was 0. NGS was sent, and the NGS report revealed this. Good celerity, 40% tumor celerity. KRAS was there, non-G12C. STK11 was also there with a good VAF of 63.21%. Now, this patient has a California syndrome. Patient sitting over, attendance over here, attendance in California also. So, they were very disappointed when they saw this report because they felt that, PDL1 be 0 hai and KRAS hai, STK hai. So, subsequently, a liquid biopsy also was sent, maybe because probably they have listened to Prabhat or somebody saying we should do both tissue and liquid biopsies. And this is where the liquid biopsy came as. So, liquid biopsy, in addition to STK and KRAS, also showed NF1 mutation. Prabhat is looking at this, ye kaun si dawai aa gayi hai, selumetinib. Maine to kabhi nahi suni. And with that, this was the patient's daughter's, kind of movement, Eureka, we have got something over there. So, let me start with Prabhat only. So, Prabhat, this patient comes to you. What would be your choice of treatment? Would you want to give the standard immunochemo? Okay, it's whether you want to give for, they don't have, can you give some, Bharat can speak and sing, everybody will join in the chorus, Bharat. Okay. Yeah, sir. Or you want to go for a check IO or chemo alone, or there was a debate I think between you and Dr. Sahu last year in ICON about the lack of immunotherapy agent in PDL1 negative. So do you want to go for this, or there are a lot of precision oncologists who will want to combine IO and selumetinib, IO and selumetinib, selumetinib alone, or maybe chemo and selumetinib. So where do you belong to?
So, as you rightly said that I was looking with a lot of stress that what this drug is and what this mutation is. So, obviously, I would not comment on that. But what I know, apart from PDL1 being 0, there is another mutation in STK11 which confers a resistance to checkpoint inhibitors. So, obviously, IO alone is out of question in this scenario. Either a combination or, there are some subgroup analysis done with Keynote 189 also where they say that the combination is still okay. But the data for dual IO combination, either IO or IO with some chemotherapy is something.
In the last 50 patients of immunotherapies that you have given,
0.
How many have you given IO?
0.
Why is it that you have not given IO? Ankit, can I ask this question? How many IO combinations have you given in PDL1 negative? That's the strongest one we have. BMS people are listening to this for your next ticket to the next conference.
The last 3 years I've given one only.
Last 3 years we have given one. So let me go to the high-five flying people, Bharat. Only one. Fantastic.
Keyboard.
How many?
I haven't used IO.
So Nikhil, let me come to you. Why not a combination of the, what the people typically say as the precision oncology? Why not combine selumetinib and immunotherapy or IO plus chemotherapy? Let's get the entire gamut of this together.
So technically we are asking for fusing the clinical trials and results and applying.
Yes.
I think I'm not as courageous as what you are.
Okay. Okay, I think we all will agree that we will either give a combination of IO chemo or we'll give a combination of IO chemo. I think the common sense oncology should prevail over precision oncology. A lot of time on the WhatsApp groups we keep on saying, people combining immunotherapy plus PIK3 inhibitors plus KRAS inhibitors plus this. I think we should hold our horses on all of those things and really common sense oncology should prevail over precision oncology. Otherwise, this is what exactly we will end up like. So, this patient was started on KN-189 regimen. PET scan showed a partial response to treatment. She was continued on maintenance pemetrexed and pembro. She got 24 cycles of treatment. PET scan showed further response to treatment. Now at this time, MRI brain had, we always do MRI brain in combination with the PET scan that we do, because we do feel that around 30 to 40% of people will have asymptomatic brain mets which can get picked up by the MRI. So this is to the radiation oncologist. MRI brain has been done right now, which says 2 small lesions, frontal lobe, one in frontal lobe, one in parietal lobe, 0.66 into 0.8 mm, and 1 lesion was there in the intramedullary portion of C2. In spite of repeated questioning to the patient says, नहीं मुझे चक्कर नहीं आ रहे हैं, नहीं मुझे nausea नहीं है, नहीं मुझे vomiting नहीं है. We even threatened him on gunpoint, her on gunpoint, and she said, नहीं मुझे कोई चक्कर नहीं आ रहे हैं. So ma'am, but the patient has definitely got these new lesions which were not there before.
Yeah, this particular case, this can be, discussed in a tumor board sort of.
We are discussing in a tumor board, ma'am.
0.6 and 0.8 mm, 2 small lesions, patient is asymptomatic. We can offer stereotactic body radiotherapy, SBRT fractionated. So 5 fractions, we can offer SBRT.
Fantastic. Anybody else who will want to differ? Prabhat is looking at me with disdain. ये कैसे क्वेश्चन लेके आ जाता है? Okay, yes, Nikhil.
Just a question. 0.6 millimeter is not.
0.6 centimeter, sorry. Yeah,
sure.
6 millimeter, 6 into 8 millimeter, sorry.
Okay.
Very alert, Nikhil, at post-lunch. You didn't have a good lunch, I guess.
now that I'm alert, now I can sleep.
Alert now. Okay. Everybody would want to give radiation to this asymptomatic person?
So 2 things. One, what one can think about, maybe it's early progression, but with the C2 lesion, which can become symptomatic in no time. So I would probably discuss with the patient about this one. Same time when the patient is progressing, let's say oligoprogression, would be a good time to do one more liquid biopsy for the patient.
One more liquid biopsy. I am coming to the medical oncology part of that. Okay.
Here we have to remember we are treating a lung cancer patient. So lung cancer patient with 0.6 mm lesion in the brain, it has to be treated.
It has to be, even if it's an asymptomatic. So let me just put this question across to the panelists. Let's just go to the beginning of this patient's journey. Let us say, ma'am, at the same time, she had lung mass, lung nodules, effusion, and she also had the similar 2 8 mm by 6 mm lesion in the brain. Will you start with, this is a trick question, ma'am, just to wake everybody up. So let me come to Ankit right now. Ankit, so this patient, after 24 cycles, everybody is saying that we will give radiation to the asymptomatic oligoprogressive lesion. This patient, if the same lesions were there at the diagnosis, what would you do?
So, sir, since there is no targetable
there is no targetable mutation. If you believe selumetinib can be targetable, otherwise there is nothing.
That would have been the case, no radiotherapy upfront. But in these kind of scenario, I would like to start with the systemic and have a close follow-up for the brain mets that they are stable, progressing.
So just to ask you, after 4 cycles of pembro and pemetrexed, the lesions remain stable. Patient is asymptomatic. When will you intervene?
So just a slight progression at any point of time.
Stable.
So stable, I won't.
You won't. Prabhat, so why can't we do it right now that the patient is asymptomatic? we keep the patient under observation and then we will see.
So one thing you initially mentioned that common sense oncology should prevail.
I think it's
and
going to come
you have done MRI brain. I mean, why the hell you would do MRI brain if you don't want to give radiation to this? So this is an isolated lesion.
If we have done an investigation, we would want to act on this. Yeah.
So otherwise...
and also because the wife is radiation oncologist, so Prabhat will never say no to radiation oncology, you know. I mean, he also has to go home. So he will never say, radiation pehle de do, chemo baad mein dete rahenge. Is that the right thing? And I had the same COI for Nikhil also today. I guess Nikhil will always say. Okay. So this patient, actually in tumor board, we had this discussion and I actually told my radiation oncologist, let sleeping dogs lie, patient ko symptom nahi hai. Why do you want to? For a moment he agreed when they had only 2 lesions in the brain. But while on doing an MRI, we found out the C2 lesion also was there. So the C2 lesion was the one which clinched things. He said, sir, when we are giving to the C2, let me give to the brain also. The patient got FSR to do all brain lesions. This is a question, I think I'll go with, yeah, I'll go with you. So if you have to really give immunotherapy and radiotherapy, what's the break? It's a very practical question. We have given the last immunotherapy on January 1. And let's say it's going to, radiation is going to start on January 15th or something. Is there a time limit gap that you will do, or you will just give it anything?
Yeah, we'll give the time limit, nearly 2 weeks.
2 weeks is good enough for you. Anybody else, Nikhil or, yeah?
So I'm not 100% sure about these numbers, but what probably I would do is around maybe 4 weeks is what I would do.
4 weeks or something, fantastic. Anybody else? Prabhat will answer this question for me.
So break here would not make a good sense because anyway these drugs have long half-life. And if you're giving SRS, you don't you give few fractions.
Yeah.
And
so,
if you're radiating brain and bone, you really don't have to worry much about it.
So I think that's the point why I kept it. If it's a TKI, we normally stop at 3 to 4 drugs depending on the half-life, but immunotherapy anyway has a half-life of around 90 days. So there is no real point. And I mean, the first patient that we gave radiotherapy to our oligoprogressive, we were very scared. But now we routinely give it 2 weeks, 3 weeks, doesn't make a difference. Anyway, it has been there in the body for a long time. But if it's a TKI, we will obviously want to stop it for some time. Now, this is for you, Ankit. I'll start from here. Will you change the... So, technically, it's a progression. There's a new C2 lesion. There are new 2 lesions in the brain. Will you change the systemic therapy also right now?
No, sir. It's an oligoprogression.
It's an oligoprogression.
Give the local treatment and continue the system.
Everybody agrees? Bharat, you agree? Yeah, okay, no need to change. So this patient was continued on Pembro and Pemetrexate. She had a tolerability was good except for she got pedal edema, fatigue. The creatinine was 1.8 at that time. No, we are changing a different thing right now. So Pemetrexate was stopped at present in this. Now after this, after 4 weeks, she came to the OPD with history of deteriorating breathlessness. She was slightly cough. The problem with Delhi is, you know, sometimes patients have cough and if you don't want to do investigation, you can say it's an allergic cough or pollution cough. You just said AQI of 300, itna to hamare yahan rehta hi rehta hai. And right, you know, probably a pollution-related cough, give some Duolin and Buteyko nebulization, which actually happened. Everybody ascribed this cough. She was coming for last 2 cycles and different people were saying, nahi, sir, occasional ronchi the, and we just kept on giving Duolin and Buteyko nebulization. But then, you know, X-ray now showed a right-sided moderate pleural effusion. Now, this also is an issue because the creat is 1.8 and Pemetrexate was given. People have pedal edema. So we also felt it was, you know, because she was doing so well, we thought that, you know, maybe this is also because of the pedal edema only. Now, an echo also was done, which had a moderate pericardial effusion with impending cardiac tamponade. This was an X-ray and an echo finding. Patient was reasonably PS2, I will not say this. She underwent pericardial tapping, which was positive for malignant cells. And the PET scan was done concurrently at that time, which basically said metabolic active left lung mass, lung nodules, lymph nodes with bilateral pleural effusion and pericardial effusion with other findings and interval changes seen. This is how bland the report actually was. So if you look at only the report you can have actually, you know, with immunotherapy you can actually miss this thing. But the pericardial effusion was positive for malignant cells. And pleural effusion was also positive. This lady actually was in ICU for a couple of days. So, how will you proceed now? Bharat was, no, I think Nikhil was there. Somebody said liquid biopsy right now. He said liquid biopsy.
Okay,
so
I would like to do sequencing for the blocks. No, there are blocks of peripheral fluid and pleural fluids. So, and liquid biopsy was also done. And when there was a good response and only intracranial progression, when you do a liquid biopsy, it is better to sequence it at different time points to see, because
So you
sometimes
will
there are different
want to-
mutations.
You will want to do a liquid and tissue biopsy.
Together.
One, fantastic. Anybody? No. No, you have not answered. I have not been able to ask you anything.
So I would
You would
say
want to change over to chemo. You would want to change over to chemo and anti-angiogenic. Or you
chemo
will,
and,
yes,
chemo and anti-angiogenics I would choose.
chemo and anti-angiogenics you will choose. Fantastic. Nikhil,
So I will wait for the biopsy, NGS first.
the biopsy is adenocarcinoma and the,
NGS.
okay. I'll come to liquid biopsy right now. What are we looking for? We have done so we don't expect an EGFR mutation to commit. It's a truncal mutation. We are not looking for a resistance pathway in immunotherapy. I don't know how many Prabhat might have a big number on that, but whatever small 30-40 people we have done, we have really not found out. The only one patient I found out was an EGFR of 5%, but then we went back and looked at the initial one. It was also in a subclonal way. So it's very nice to say histopathology I will definitely do, because there can be tissue plasticity and something change. Liquid biopsy, if she was a non-smoker and you don't trust the lab, I would probably do it, that they might have missed it. But I think the incremental advantage of that, at least in my practice, has not really been very great till now.
So agreed. Having said that, we'll still would like to do the histopathology as well as
Correct.
water NGS. I mean, the possibility would be, as you rightly
very
mentioned,
low.
is minuscule. But once that is
It
established,
is nice to send actually, because if you don't send, somebody else will send.
somebody else will.
Okay.
Yeah, in this particular case,
Sahu
initially,
is waiting for my, you guys to. Okay.
so KRAS was positive.
Yes.
And
KRAS non-12C.
T53. So when you have sent a liquid biopsy in the beginning, the fantastically chemo and IO combination has worked. Creatinine has gone up. You stopped chemotherapy. Why I said I would like to repeat, with the chemotherapy or IO, whatever, the clones have disappeared at least. In the subsequent, if you see clearing, I know that chemotherapy is working well. And then to take a decision about chemotherapy adding with anything anti-angiogenics will give me confidence. That is one thing, because it was done at the baseline, not to look at the mutation.
So I have a, yes, Dr. Sahu. So do
We
you still
have
support
now a
IDs in this
tissue
setting?
which is in the pleural fluid as well as the pericardial fluid. No, it's not about business. You have a patient lived for 2 years with chemoimmunotherapy. You have a tissue now. Patient has lived beyond 2 years. Why not to do NGS? What is the logic behind not doing NGS right now?
So it is unlikely that you will find a resistance mechanism. But I mean, that's what, but the problem here is that if it was sent in a lab that you don't really trust, that's okay. But I mean,
don't need to tap, look at the fluid is hemorrhagic and start the chemotherapy and angiogenesis. Why to send to the histopathology?
Prabhat, will you do it on an academic setup also, apart from research setting?
No, the only reason for doing an NGS here would be if you have done a hotspot panel in the beginning, or if you have done a limited panel, you want that. I mean, I agree with Ullas in that situation. I mean, if it's a comprehensive profiling done at the beginning, you will not find anything.
But that is not why I put this thing. This was just the last one actually. What will you do? You will all change it over to chemo and anti-angiogenics?
Chemotherapy.
Okay, so my point over here is, and I mean, this is where I think, there is no right answer to this. My point here is, look at this. Now, a progression on immunotherapy, somebody who progresses within 3 months, somebody who progresses within 10 months, somebody who progresses after almost 2 years. Are you going to club all of them as the same thing? And you looked at, the PET scan report. It said towards progression. We have taken out the fluid and all. Anybody here wants to continue with immunotherapy and reintroduce chemotherapy on that? So like HER2 new, I mean, you continue on this and you get the chemo onto that, or you were saying that's the end of chemotherapy. Does everybody agree with that? Bharat?
Again, to this case, your progression has happened after stopping the chemotherapy. I don't know whether it's rapid progression. Like,
Correct.
It's not targeted
correct.
thing.
The
You
progression
stopped and
has
it
happened.
progressed.
Yes, so
right?
the progression has happened after 6 months of stopping Pemetrix, right? But Pembro was being continued.
Yeah, but 24 cycles, then
And
the
so
creat went
she
up.
was almost at 33 cycles when the progression actually
Yeah, I
happened.
agree. So chemo-free interval of 6 months. So
Yes.
definitely I feel
No,
chemotherapy.
chemo is there. But will you continue immuno? That's what I'm saying, between an anti-angiogenic, so chemo will have to be given. That is there.
So I think changing the chemotherapy combination and continuing immunotherapy, that again, we are looking at only palliation for this patient.
Okay. Dr. Sahu doesn't agree? You will not. you will say give it over to docetaxel and ramucirumab.
Point is, it's such a frank progression on immune checkpoint for 2 years and beyond, continuing immune checkpoint on progression with this amount.
So do we see hyperprogression after 3 years?
So this is not a hyperprogression.
This is not a hyperprogression.
This is not a hyperprogression.
This is not.
So my only point here is that, if you, because I'll tell you what I did. So we did actually give the patient pembrolizumab and we got paclitaxel. The lady is still absolutely okay and she's going on to pembro maintenance, because I feel that probably the only chance of her long-term cure lies with IO therapy rather than with antigen. That's what I felt. The patient has done well, whether it's because of immunotherapy or chemotherapy, I don't know.
So she's also on maintenance pemetrexed?
She's on, no, paclitaxel, that's it. Okay, we didn't give pemetrexed because the creat was 1.8. Yes.
So, Ullas, even before immunotherapy, we used to have some patients who on pemetrexed maintenance doing well.
So, can we just agree on that immunotherapy is not like an anti-HER2/neu? In anti-HER2/neu, you have to continue the anti-HER2/neu backbone and add on chemotherapies. But on this,
the pattern of our tempo of progression is very important here. This patient landed up in ICU. Correct. So relying on just immunotherapy is not a great idea here.
Immuno plus chemo.
So this is now immune resistant.
This is also now immune resistant. Fantastic.
Had it been an isolated disease progression at 1 or 2 sites
fantastic.
like you?
Yes, Nikhil. And I have a better case than this. So I'll just take 2 more minutes and then...
Yeah. So, but won't you consider for like chemo with anti-VEGF here? Yes. And again, eventually would like to re-challenge in future.
This is a good one. So let's say this, you give Pacli and...
just to get a rapid response initially.
And then give them maybe Pembro again. Will it be okay, Prabhat? Oh, that is okay. But continuing is not okay. Come on. Yes, Vishesh.
Just out of the box, would you want to add a anti-VEGF with along
he
with
was saying
Pembro
ABCP.
as a maintenance therapy?
He was saying ABCP. So the point here is, I did think about ABCP. But Pembro ke 90 days ke baad mein, I didn't really want to give Atezo at that time. That is where I actually have personally given 4 cycles of Pembro, Pem Carbo, and then because nivolumab was cheaper, we have continued and switched over to Nivo. We have done that. We have some cases that we have done that, but that's not the standard and that's not what I really want to convey to the students over here. So for the students, this is a progression. We would want to change it over to docetaxel or Pacli, plus minus anti-angiogenics. If it was an isolated progression, we could have given radiotherapy and then continued immunotherapy for the students. For the private practitioners and corporate and government academic people, you can do whatever you want. Okay, the next one is even more interesting. How much time do I have? 8 minutes, fantastic. So we have a 41-year-old male, never smoker. He came with a history of swelling in the neck. He had supraclavicular lymphadenopathy on right side. So he went to the head and neck oncologist first. PET scan was done, which basically said a right hilar lobe mass with right supraclavicular lymphadenopathy. This biopsy was done in a very reputed hospital in Delhi, where they said the cell block shows 2 distinct populations of smell. One is small cell, one is non-small cell. And the IHC was done on these, and they said metastatic carcinoma, possibility of a combined small cell carcinoma with a non-small cell carcinoma, NOS component of pulmonary origin should be considered. So let me, if a patient like this basically comes to us, what we basically do is, aapne ek second opinion le lo. So what happens, we don't trust somebody else's report. So we said just to buy time. I mean, either you send the patient out to do a CBC, LFT, KFT, or you tell them we will discuss in tumor board. Then we told him, we will get a biopsy done. We say, no, we don't trust outside reports. We get a rebiopsy done. Rebiopsy was done from a supraclav lymph node, which basically came as small cell carcinoma lung. So, non-smoker, you have 2 reports. One says combined small cell and non-small cell. At our place, we think we are one of the better institutes. We think, nobody else thinks so. It basically comes as small cell carcinoma. Final diagnosis of this patient is limited stage small cell lung cancer in a non-smoker patient. So I'll start from that side, ma'am. Radiation oncologist.
Was it not possible to do a biopsy from the primary itself?
So
why did we do a re-biopsy from the neck node?
Because, ma'am, this was accessible. There was a good 3 centimeter lymph node over there.
In a situation where we are having 2 components, why did we not try to go for biopsy from the primary site?
Biopsy from the lung was done, which also came as small cell carcinoma in a non-smoker.
Okay. Oh, then we have to go with it.
Then what do we do, ma'am? We have a right hilar mass with some supraclav lymphadenopathy in a non-smoker patient.
Then I think you have to go for a slide review and
We went for a slide review,
mid-onco.
and second opinion we sent to AIMS also. They also said small cell carcinoma.
Right side. It's on the right.
Right side, ma'am.
Okay, then I think I'll go with small cell carcinoma.
So somebody from the medical oncology said, you know, yes, Bharat, you want to take it in?
Dr. Sahu is going to hit at me, NGS kar lo.
NGS kar lo, you know. So, I mean, I have been, Dr. Sahu has been one of the biggest influences on me. So, you know, I actually said, आज कुछ तूफानी करते हैं. So, this patient came to me and I said, चलो एक काम करते हैं, इसका NGS करा लेते हैं. I mean, अब राजीव गांधी में तो NGS तो कराएंगे. And this NGS report came as exon 19 deletion with AKTC copy number gain. So, you have a non-small cell, limited stage small cell, outside non-small cell combined with a EGFR mutant, and this was my reaction at that time. अब मैं क्या करूँ, क्या job छोड़ दूँ क्या? I mean, how do I treat this patient? So let me go to Ankit here. How would you treat this patient now? CTRT alone, CTRT followed by immunotherapy, Pacific or Adriatic, CTRT followed by osimertinib, PCI, or what? या तुम भी जॉब छोड़ दो. हाँ, जो मेरे साथ आ जाओ, हम दोनों जाके कुंभ में जाके डुबकी लगाते हैं.
Sir, I would like to go with CTRT followed by option of osimertinib.
CTRT followed by osimertinib. Fantastic. Prabhat.
So now you better believe that first hospital report.
You better believe the first
was an adeno component in this patient, and I mean, this is extreme rarity. We do get, we do get.
We are actually getting more of these things right now than we were
The
getting
more you
before.
test, more you would get that some people probably had transformed even before they were diagnosed. So treat it as a classical small cell lung cancer,
Do
the
we
way
have
you
a
treat,
pathologist
without
here?
immunotherapy.
Do we have a pathologist here who can actually... Okay. Yes. What would you do? Bharat and then yes.
Yeah, so I agree with no CTRT followed by immunotherapy because small cell also and you know,
CTRT followed
it's a
by
stage, it was not limited stage, small cell, and you
Yes.
have 18, exon 18.
Del 19, I guess.
Del 19.
Del 19.
Oh, sorry. Oh, sorry. I missed that.
Okay,
Sorry.
CTRT, PCI, no immunotherapy. No osimertinib also. Fantastic. Okay. Why? Okay, yes.
CTRT like a small cell, osimertinib, no PCI. The MRI.
CTRT, this thing, and no osimertinib. Nikhil?
Osimertinib, yes.
CTRT, osimertinib, no PCI.
No PCI.
Fantastic. Nikhil?
I
Yeah,
think
it's
again,
working, Nikhil. It's working.
CTRT,
I can hear you loud and clear.
CTRT, yes. But I'm buying my time just the way you have been buying time for this case. So I would say CTRT probably followed by PCI and wait and watch.
CTRT, PCI, wait and watch.
We'll go with the CTRT followed by osimertinib.
CTRT followed by osimertinib.
And,
you know, from that side, AZ is very happy. Whether you give Durma or osimertinib, they are absolutely okay.
PCI.
Madam will say, as long as I get my RT, I am absolutely least bothered about what they do. Okay. So, you know, and just in case you hate your job, although this is a holy city, there's a support group called as, for that, which is called Everybody, and they meet at the bar. But I'm a teetotaler. That's another issue. So, Prabhat, you said no osimertinib. Why?
So this is the way we have been treating earlier if a mixed histology if you get a small cell component, that small cell component is more aggressive and they dominate.
Correct.
Here also, although you have found EGFR del 19, but this disease is probably P53RB driven. It would not get benefit with osimertinib. I mean, you can argue that, okay, it would not harm some adeno component, it may work, but
okay.
I really don't know.
Yes. So the point is, with CTRT, Prabhat, how much is the expectancy that you are actually getting? I mean, what will be a 2-year, you know, survival?
So you do not have that data. I mean, I cannot tell you for 5%, less than 5% people in small cell. But in small cell, whatever. But with osimertinib, you may or may not get that advantage.
Okay.
What we are getting with the limited stage or a locally advanced non-small cell EGFR mutated with osimertinib, this is a different disease.
So somebody will, yes, Bharat.
So we are not going to get the perfect answer through the trials. This is an individual case. So somebody is looking at it small as well as non-small cell lung cancer. It's pretty okay. He wants to treat it. But which biology is poorer? His small cell is very bad biology. That's why he wants to follow. This patient will fail small cell before no non-small cell. And close follow-up is very much important in this case. Keep on doing the MRI.
And nobody wants to give, so if you're not giving osimertinib, will you give PCI, Prabhat? Yes, okay.
So for this patient, we probably have made up our mind depending on the histopathology. It is small cell. Now the issue remains whether to add it, like work like Geriatric, where with the EGFR, tomorrow we want to go some, again, EGFR TKI and trying to mess up with the patient's immune system, getting all those hyperimmune responses, either which ways. So that is one of the reasons why I kind of thought of not offering this patient IO as at the same time, but it would be worthwhile to follow this patient for the EGFR with liquid biopsy and see what happens.
So what we did in this patient basically was we gave CTRT followed by PCI. We got the block reviewed on the initial blocks also, which also showed the same EGFR and TP53. This patient was not affordable for osimertinib, and we have given him erlotinib. So I don't know how is it going, because there's no harm in giving erlotinib, and I really felt that patient would benefit from some amount of TK, and we have done a test, and that is why. So there are no right and wrong answers, there's only intuition, and I think maybe in the next I-OSICON I can tell you about what exactly happened on that. And my last slides basically over there is, I think this is what we need to remember. Medicine is it's a science of uncertainty and art of probability. It is the art of the medicine we have to practice. And the greater the crisis, the more significant the opportunity. And with this, I would like to thank the entire I-OSICON committee and Ghanshyam Biswas for giving me a privilege to be over here. Jai Jagannath. Thank you. And thank you to all my panelists for taking this torture. Thank you.
I may now request.
So, Dr. Ullas and the team of esteemed panelists, it was really wonderful discussion, and Ullas in Hindi means happiness and laughter, and I must congratulate you and kudos to you that post-lunch session you kept everybody engaged, and all the panelists were glued to what is coming next. So that's the art of a master moderator, and you really did a good job. So thank you so much for having a wonderful session.
Request all the chairpersons to please proceed to the dais. I please invite Dr. Prasad Narayan, Prasad Narayan sir, and yes.
Okay, I forgot. Yeah, Dr. Prasad sir. Prasad, आजा. मैं तो चला गया. सोचा इम्यूनो लगाने के लिए. But I thought more than I thought you had given.
So our next speaker for the session, Dr. Aditi Chatterjee from Strand Life Sciences. She is the Director, Clinical Research, Strand Life Sciences, Bangalore, and she is going to talk about Cancer Spot, a new test on cell-free DNA methylation-based early detection of cancer. Dr. Aditi.
Good afternoon all, and thank you Immuno-Oncology and the organizations for giving the opportunity to present our study and the outcome of it. So it is a study we have done which can detect multiple cancer types in a non-invasive fashion, that is from blood, and the idea behind is to use cell-free DNA and to look at methylation patterns. So this is a shift from genomics to epigenomics because we are talking about methylation. And the assay or the product that is being used for screening of these multiple cancer types is called Cancer Spot. So as we know that our genome is the same, but epigenetically each organ could be unique. And that is the advantage or principle behind developing this assay. So how does it work? So there are like 28 million sites in our body which is methylated. That is, the cytosine in the DNA has a methyl group attached to it. And that is the signature we are studying through this assay to identify or differentiate between whether it is a cancer or it is not a cancer. And if it is a cancer, what can be the possible 2 top cancer types that the assay can recognize. So here is like a stretch of DNA. I don't have a pointer. So here is a stretch of DNA, and you can see the CGs are marked in red, on which the where the C gets the methyl group, and that is what we have to recognize. In other words, there are 4 CGs here. 1 CG is not getting the methyl group and 3 are. And so the sequencing has to recognize which one got it, which didn't get it, and that is the signature we are trying to study. So when life begins, that is at the embryonic stage, we begin at a clean slate. So when a sperm and egg comes, it comes with their own methylation, they fuse, and then it comes to 0, and then picks up again. So for an individual, methylation starts on a clean state, and so it is unique for that individual. So what happens if DNA gets methylated? So the top strand here shows when it is unmethylated, which means it is more open, and hence the transcription factors, as we call it, can walk through and your genes are transcribed. Whereas when methylation happens, as you see it's depicted in the cartoon, the DNA tightens up, and hence the transcription factors cannot walk through them, and hence there is the genes are not transcribed or not translated, letting to shut down of the genes. And this gets detrimental more so when it happens in the tumor suppressor genes. So here we just want to focus, say this is a chromosome. We take a tiny bit of area and focus on that. So if we blow that up, that tiny bit of area can code for multiple type of genes. And there, if we focus on again on a specific area, we can see here that this could be the area which is highly methylated in neurons, but it is not so in others. Similarly, there is an area which could be methylated in B cells, and so on. So in this way, one can study and identify specific areas in the DNA which is methylated for a specific cell type, and this naturally can be translated to tumor cell types. So what happens is, when we study different cell types, starting from blood to a fully developed cancer, the holistic or the global methylation actually decreases, but sections of DNA with particular CpG methylation increases. And that is the advantage that we take to identify specific or signature areas which are methylated in a cancer, or how to differentiate it from a tumor, and also to identify if that signature is specific to a certain tissue region, say it is specific to lung, to colon, to breast, and so on. So here is how the system works. Here you can see there is a C which is methylated, a methyl group has been attached to it, and here is a C to which the methyl group is not attached. So one has to sequence it and identify that this C has a methyl group. So normally when we sequence, we can't sequence with a hyperlink of M. So what happens, we would do an enzymatic conversion of the DNA. When we do an enzymatic conversion, the C which was not methylated gets translated to a T. So when you are sequencing, you are reading the C which was methylated as a C, and the C which was not methylated comes back to T. But here there is the thing, there was a thymine again, so that T naturally remains T, that doesn't change. So once we get this converted DNA sequence, which is classically called bisulfite sequencing, but nowadays people don't use bisulfite because it's harsh for it, and we use enzymatic converter. So then you align it back to the reference sequence, and you can then say which Cs are methylated and which Cs are non-methylated. But it has to be a C preceding a G, so it's a CG always. A CA is not we are aiming at, though this C will also get converted, but because there is an A after it, this is not what is considered when looking at the methylation pattern. So this is like a cartoon depicting that when it comes to cancer, there are many more methylated spots which are identified compared to a control, and that's how we are able to tell that whether the signal is coming from a cancer or is it coming from control. And while developing the assay, we took into other confounding factors, whether the like smoking or chewing of tobacco, age, gender, etc. So when control population was enrolled, we ensured that we enrolled only smokers, only chewers, or those with mixed habits and no habits, so that when the signal is identified by us, it shouldn't be something that is coming due to smoking or chewing of tobacco. So those parameters were taken into consider for developing the assay, and they were actually eliminated to design the assay or the algorithm. We also went on to match our data with sequence available in TCGA. So the area which we identified that this indicates, or methylation here indicates cancer, we studied that in the like 12,000 data sets available in TCGA, and indeed it was aligned. That means those sections in the TCGA samples showed a similar methylation pattern as we had identified from our samples, giving us the confidence of the panel. So this is from one of the publications done in 2024 by another group, which of course most of you being experts in the field know that the earlier the diagnosis, the better the cure. And that's the concept of cancer spot today, that if we can use it as a screening tool, which is a blood-based screening tool, we can identify cancer early, and hopefully that will lead to better prognosis. So what did we do? As I said, we took samples from treatment-naive cancer patients and those who were apparently normal with no symptoms of the disease and or no precancerous lesions and no symptoms of the disease. And we identified what is the difference, and we chose cell-free DNA methylation as the chosen matrix. So we had multiple cancer types. As you can see, it's traversed from breast, cervix, colorectal, to many more: kidney, liver, ovary, pancreas, and others. And we had over 5,000 treatment-naive patients, and around 48 hospitals across the country participated in this study with us. And we also had more than close to 1,200 presumed normal non-cancer subjects. And as I said, they were with no habits, with both tobacco habits, or only a chewer, or only a smoker. So as I explained, this was done so that any signal that we identify as cancer is not something of a false positive signal we are picking up due to any of the tobacco habits. So our results indicate, so it was a machine learning algorithm that we ran, and we ran about 1,000 samples, and this was the final 206th where I'm showing the data. When we use 141 cancer samples, the algorithm or the machine learning algorithm could predict 114 of them as cancer. And when we use 65 non-cancer or the normal subjects, of that, 2 were predicted as cancer. So from this, we can see that we have a 81% sensitivity and more than or close to 97% specificity for this assay. So these are the 10 cancer types which we have focused mainly on, and most of them show a 75% sensitivity in most cancer types, colorectal being not really up to 75%, but others are at 75%. And this assay, the cancer spot assay, it can identify cancers from all stages. So overall, it is able to detect 80% of the cancers with a 3.1% false positive rate, and it can well differentiate between control and cancers. So if I compare the cancer spot with some of the existing tests that is typically used for screening, we see that our sensitivity specificity is at 75 and 97 compared to the ones existing like mammogram, X-ray, low-dose CT, CA125 or FITs. And just for colorectal, if we compare with FIT, it does a much better job in terms of the sensitivity. When it comes to reporting, we would be able to give a score, either a low score, an intermediate score, or a high score. So if it is a high score, we will be able to predict the top 2 tissues of origin. These are the probable tissues of origin. The intermediate wouldn't give any tissue of origin, and low, of course, is low. So once a score is generated, the subject, of course, continues to consult his or her clinician oncologist to understand the next steps for confirmation. Because this, I need to emphasize that this is a screening test. This is not a confirmatory test. So now who can use the test? We feel that high-risk individuals where there is family history or genetic predisposition can use this. And oncologists may feel that patients with a history of cancer or elevated cancer list, adults over 40 years of age who want to undergo screening, it could be part of any employee wellness healthness program, and health-conscious individuals who might have certain symptoms and are worried that, do I have something lingering in me? So this is a test which could benefit them. It is a non-invasive test done only from blood test, and the reports available in 21 days. This is something which can detect cancer at a much early stage and can detect all the 10 cancer types simultaneously. Like it can screen for all the 10 cancer types simultaneously. So this is about cancer spot, the rationale behind it, how we build the assay, and its application. Thank you for your time. Happy to take any questions.
Yeah, Dr. Aditi, this is here. Here, this is the chairperson. Hello.
Yes.
Yeah. So I have a very simple, fundamental question. The 10 cancers which you have picked up and their early epigenetic signatures which you are looking at. Now, the changes are seen early in the blood. Cancer is primarily, when we are talking about solid cancer, the 10 solid cancers, they are organ disease. The organs undergo changes, and there are mutations, driver mutations, different kinds of mutations, and they go into different stages. But the blood cells, basically the lymphocytes and the nucleated monocytes, how will that epigenetic signature correlate tightly with the organ-specific disorders later? And how early is this early?
So we haven't looked at the lymphocytes or the blood cells. These are totally the cell-free DNA because the tumor sheds DNA in the blood, and we have taken those cells and looked at the methylation pattern there. So as I said, this is a screening test. Right now, we are not, we don't have data to say if it can help you detect on prognosis. And that's a very important and valid question, and we are working towards that, because when we had discussion with multiple oncologists, they did propose that can we follow up the patients, and that's another reason why I'm here. I mean, it is a paradigm of oncologists here.
The question here is, when you mentioned about preventive screening of employees and wellness and others, now when we talk about preventive screening, it is apparently normal people. They don't have the disease.
Yes.
So when they don't have the disease, there is no question of tumor shedding DNA in the blood.
No, so any normal person also sheds DNA into our blood. If we take our peripheral blood, you will get cell-free DNA, right? So yeah, coming to your answer. So the assay can differentiate the signature saying that this is coming from normal cell-free DNA, or it is coming from a tumor which might be lingering. So that's why it's a screening test. So the first step is a cancer, yes or no. So a no is where I showed it's a low score. Intermediate could be something probably lurking, and high definitely, maybe the person hasn't gotten diagnosed, right? But something is there. I mean, that's how people come for late diagnosis. So that's how this helps in the screening. And then if it's a yes, the signature will then tell you what could be the probable top two. If it tells you the probable top two, or it tells you it's a yes, then it is on the oncologist or who is treating the person to further diagnose and confirm it. This remains a screening test. This is not a confirmatory test.
Any other question? One more question maybe? No.
What are the false positive? False positive, you have done a test, you are told it is positive, on the score is high, and when they went and did a PET scan or MRI, we will follow it up. What was the percentage? Any studies done in that?
Sir, because it is quite new, and based on the cases that we have identified, the number of false positive right now is kind of at 5%. It's not very high. But again, this is with little over 1,000 plus data. So to answer your question, we will need much more higher data set. I agree that. But in any of the screening tests, I guess you would agree with me that we are more worried about the false negatives. A false positive you can always do and say, you know, happy, it's a no. But the false negatives here are on the lower side, but we are trying to work harder to increase the sensitivity, specificity, and make it more specific to each cancer types, especially where we don't have screening mechanisms as of today, so that the negatives are, we don't miss out on cases, because that will be a greater, it will have a greater implication on life if I give false negative data. So that is right now the main focus, that we shouldn't be giving a false negative. And that side, we are more satisfied.
Okay, thank you. Thank you, Dr. Aditi, for a nice presentation.
Dr. Aditi, good afternoon. It's a very good talk. Very good talk, very interesting topic that you have brought about. See, methylation is a very, let's say, a very signature event in malignancy. That's what you show. So my question is, if it's a signature event of malignancy, why should you say that only those top 10 can be detected? It could be any malignancy. That's one question. So have you then identified individual signature pattern for individual malignancies, and have you validated that? Number two, your sample collection was from patients who were diagnosed with malignancy, and then you showed that they have these methylation signatures. So how do you want to then, because you have really not, the control arm was apparently normal people. So you can never have a population where there is a hidden cancer, and unless you longitudinally follow them after 1 year and you show that you are right at that point. So how did you validate your signature? And I've also seen other groups working on methylation as a basic phenomenon, but instead of cell-free DNA, they are working on the stem cells and all that. So I think it's a very exciting area. My basic question is, how did you validate? And is there a threshold level of number of malignant cells needed to shed that much of cell-free DNA for you to detect it? So have you checked out on all those things?
So there are 3 questions basically, and maybe you can discuss you can have a quick point and then maybe discuss with him offline.
Yeah, so a couple of things. First of all, these were taken from treatment naive patients so that any treatment doesn't interfere and change the methylation pattern in the cell-free DNA. There was a control population that they were deemed controlled. They didn't have any symptoms of the disease or not diagnosed with anything of the disease. And we took their habits as the type of tobacco used or not used. So there was a control arm, and that's where a signature that came from a normal but was a smoker or a chewer has been eliminated to design this signature. What was the third question? How do I know it is cancer specific and only 10? Yes. So the signature identified first will tell you it's a cancer, yes or no. And you are very right. It can be anything beyond the 10. But these are the 10 focused ones we have working with. As you saw on my slide, I have others. And there are multiple others. And we are working on them to see, because see, for anything to come and present and claim something, you need a significant number. So when it is a rarer cancer type we are getting, though they are diagnosed, to claim it now that yes, my model can tell you that it is, say, testicular cancer, we don't have that data. But if it is a testicular cancer, the model can say yes to the cancer. It may not say which cancer type, but the top 10, it will say that it could be which of the top 10.
Okay. So thank you very much. I think we are getting signals from the organizers. We have to wind up. So, no, we can have it offline because we are running late. We have to close this session. So we had a wonderful session with the panel discussion, active panel discussion, and then futuristic technology being used as methylation pattern for early detection screening of cancer. And so we are in a very interesting time where technologies are evolving by the hour and the molecules are coming, options are there, information is exploding. So we are on the crossroad of technology and implementation. And this is a great time of basic scientists and clinicians working hand in hand to wisely defeat cancer precisely.
Thank you, Dr. Chatterjee, for this beautiful presentation and attending the question. We can take the rest of the question later, madam. Thank you. So for the next our symposium session, I would like to call the moderator, Dr. Vashisht Maniar sir, medical oncologist from Mumbai.
At the outset, I would like to thank the organizers, Team I-OSICON, Dr. Biswas, Dr. Jyoti, and the team for having us. I'd like to have my panelists here, Dr. Bharat Bhosle, medical oncologist, Mumbai, Dr. Ankit Batra, medical oncologist from Dehradun, Dr. Sameer, and Dr. Indu Ambulkar, please. All of them are medical oncologists. A disclaimer, this is a sponsored session and the slide sets have not been prepared by me. It's always a challenge to moderate a session after Dr. Ullas Batra has done so, more so in the post-lunch session. The good part and the bad part.
Thank you, sir. Thank you, ma'am. So post-lunch, I hope everyone is still awake. I once again request you all, please visit the industrial stalls located in the ground floor whenever you have time. So moving on to the next session, that is a sponsored symposium by AstraZeneca. It's a panel discussion, and I would like to invite Dr. T. Raja, sir. He's medical oncologist from Chennai, to moderate this panel discussion.
Thank you, organizers, and thank you, AstraZeneca, for putting us here. I'll invite the panelists. Dr. Piyush Bajpai, Dr. Nikhil, Dr. Sanjeev Kumar Mishra, and Dr. Ghanshyam Biswas. I don't know if Ghanshyam still has the energy to. Thank you. Thank you once again. So we'll move on quickly. This is a quick overview of the important studies of immune checkpoint inhibitors in small cell lung cancer. Of course, we had multiple sessions and talks on non-small cell lung cancer. Small cell lung cancer is kind of left behind, but we'll look into it. So this is an overview of the key studies of in small cell lung cancer over the years. The most important one to note are the IMpower 133, in which atezolizumab is combined with the platinum doublets, and the Caspian study in which durvalumab is combined with the platinum doublet. And these are the overall survival curves, and you can see that the median overall survival is almost identical. Median overall survival when you add atezolizumab with platinum doublet is around 12.3 months, and when you add durvalumab, it is 12.9 months. And you also see that the 18 months overall survival is at that time-specific overall survival is almost identical, 34% and 34%. But with Caspian, the durvalumab study, you also have a 36 months overall survival, so 17.6%, which is a very impressive data. So this is what we have as of now for extensive stage small cell lung cancer. So I'll begin with Ghanshyam. So today in your practice, would you want to consider all small cell lung cancer patient addition of immunotherapy? Obviously you will consider, but then how practical it is for you to offer it in your day-to-day practice. So what's your pattern, Dr. Ghanshyam?
So first of all, it is not a common like a non-small cell. Second, many patients may not have a good general conditions for chemotherapy even. And third, many patients in my setting may not be affording for that. But otherwise, given the data, given the aggressiveness of disease, so probably we have make a dent after immunotherapy with the standard backbone of etoposide cisplatin. So all comers, I should at least offer them an immunotherapy, because now with the Caspian data that has shown now, so more than 3 years, at least 3 years, there are good number of patients ongoing. So at least I'll offer all my patients.
So you would offer it to all comers. So Dr. Nikhil, so then, Ghanshyam's aspiration to offer it to everybody, you are in a much better city and a much better setup. What is your conversion rate talking to patients and bringing them on to, say, durvalumab?
So I would say maybe around still 20 to 25% max come max. Again, certain reasons, I don't know whether it's my perception or not, but most of these patients are from low socioeconomic strata, more often those BD smokers and all that. And even in the smokers, we are seeing more adenos these days. And so the numbers are small. Most of the patients are not affording even at my center, but that's what I would look at. 1 in 5 might come for this treatment.
20 to 25%. Dr. Piyush?
So I think so. We offer to everybody who can actually go for it. But yes, for those who are paying out of pocket, eventually it is around 30-40% who would be actually going ahead. And of course, the choice of therapy would depend on the patient assistance program.
So the other, the proof of concept is we already have the Caspian, which is a very powerful data. And to support that, the concept is also proven by the IM power 133. So we can almost say that addition of immune checkpoint inhibitors is a standard of care in patients who can afford in extensives. But the Delphi 301, the tarlatamab, is also showing an FDA approval in the second line. So why did I put that here? This was approved in May 2024, just to show that there is a possibility of considering continuing immune checkpoint options in extensive stage small cell lung cancer. But we leave it there. We'll go to another aspect of small cell lung cancer. In the Caspian study and in the IM power 133, it was shown that the PD-L1 status did not correlate with the response to small cell in small cell lung cancer as opposed to the non-small cell lung cancer. And when people do a good comprehensive genomics in small cell lung cancer, you often find that they have RB1, TP53, and CCND1, and this is the usual signatures that you see, and none of them specifically are suggestive or predictive of response to immune checkpoint inhibitors. So, do you think there are some reliable biomarkers to look at in small cell lung cancer, Dr. Nikhil, as far as immune checkpoint inhibitors go?
Not really. I mean, we can always look at these TMBs all the time, maybe, but beyond that, I mean, I don't do routinely the MMR also for most of the patients, for at least for a small cell. So for now, we don't have any robust biomarker for immunoresponses.
So there is nothing reliable. Dr. Piyush, you have anything to say about using genomic profiling in selection?
Except for the patient performance status, I don't think so we are there for the
Okay. Ghanshyam, Dr. Sanjeev, I'll come to you in a minute. I know I've kept you quiet.
I can share you an example. So I had a patient who was diagnosed with a small cell way back. So he was treated with etoposide cisplatin, no immunotherapy at them. Then on progression, irinotecan, then so on oral etoposide. So he went on for quite some time. So he just defied all those, the median survival. And on progression, so we did a biopsy. So we have heard about adeno changing into small. So this patient turned out to be an adeno. And I did a molecular, and it turned out to be a T790 at that point of time. We offered an generic osimertinib.
Yeah, that's a different thing, Dr. Ghanshyam.
Yeah, but he did not respond to that.
So that is a unique anecdotal progression of the disease. But per se, the small cell lung cancer, there are some literature on, if you molecularly subtype small cell lung cancer, what do we learn? So now they are classified as at least 4 different varieties based on the genomic array, or particularly these gene expression arrays can now define 4 types of small cell lung cancer. They are broadly called as neuroendocrine, SCLC-A and SCLC-N, and non-neuroendocrine, that is SCLC-P and the SCLC-Y. These are the 4 broad subtypes, and it is shown that in IM power 133 that there is a correlation between the different types and their response to immune checkpoint inhibitor. These are not yet available. These are broad broad genomic profiles. And Caspian data also shows something very similar when we look at the subtypes of small cell lung cancer. This is only a food for thought to Dr. Ghanshyam. That's what I was trying to ask. Moving on to now, early stage, limited stage small cell lung cancer. Now, generally, what do you do, Dr. Ghanshyam, when you see early stage? Do you see some patients like, when they come with, stage 1, 2A or, thoracic disease? And do you get patients who are clearly operable in small cell lung cancer? Do you see such patients? And when you want to talk about limited stage, what sort of patients do you see in small cell lung cancer?
So lung cancer itself, so very quite a few see an operable and small cell. I hardly remember anybody who has been operated or who had come in such an early stage. Otherwise, yeah, so 2A onwards, we have seen patients and they have been offered chemotherapy and then subsequent radiation.
So Dr. Piyush, what is your, how would you approach limited stage small cell? What is your standard of care options?
So, of course, limited stage, as in most of the times we give chemo radiation, if in case you are asking about the management. So, chemo radiation is what we end up with because we get somewhere in the stage 3 scenario. And depending on how the responses are, of course, PCI.
Yeah, you are right. I think unless you are going to offer them surgery, followed by, otherwise it's going to be, that's the majority. Very, very rarely you will get that in small cell you are going to know. Otherwise, concurrent chemoradiation or chemoradiation is the standard of care. That's what you emphasized. But it has not been, a great option so far, and the PFS and OS are still very limited, even though earlier we used to be excited to treat small cell lung cancer as opposed to, things have completely changed now. So now you see that they are still limited. So let's take a patient. This is a 54-year-old, very standard, chain smoker, a very common kind of patient that you will see with small cell lung cancer, cough, breathlessness, hoarseness of voice, and that's what you see. Bronchoscopy confirms that to be a small cell lung, and PET CT shows a limited stage disease. And MRI brain was also done, which did not show any other brain lesion. So, to Nikhil, what are the routine investigations? Is this okay in small cell lung cancer? What else do you do?
Yeah, this should be okay. Already the MRI has been advised and the PET scan has been done for the patient. Staging wise, and so is the immunohistochemistry. I don't think I'll be asking for any further investigations for now.
So if you don't ask for any further investigation, Piyush, how will you treat this patient?
So this patient, of course, would be started on chemoradiation. Of course, prior to that, I would want to do a PFT, and the radiation oncologist would rather ask for the health of the lung and the heart. Yeah. And chemoradiation is what I would want to go ahead with, introducing the chemotherapy along with, introducing the radiotherapy as early as possible along with chemotherapy. I mean,
now we'll turn to Sanjeev sir. Sanjeev, how often do you talk to each other, Medaonk and yourself? And when you see small cell lung cancer, obviously the standard of care is chemoradiation. All of them mentioned that. But then how would you plan? When would you plan? Would you let them do a couple of cycles and come to you, or you want to go? So how do you deal
most of the time we discuss with our medical oncology colleague, because that depends on the size of the tumor. Suppose you have a big tumor, maybe little bit poor general condition, we have offered them 2-cycle chemotherapy followed by CTRT. Because upfront radiotherapy, if you are giving such a big field, maybe you will have pulmonary compromise. So that is what we need to do a PFT also prior to radiotherapy. And second important thing is that while planning radiotherapy in such cases, like how much volume is to be encountered, that's more important, because no need of, maybe if you have a PET negative mediastinum, no need of elective nodal radiation. You go for just the gross disease with bit of margin, because it's a kind of disease which is very aggressive. So mostly you need to have a local control. Prophylactically, no need of giving to the mediastinal node and other areas.
So the broader message is you are comfortable when your oncologist, medical oncologist would give couple of cycles, and then that's for point number one. And number two, that also depends on the volume of the disease, you said too. Number three, would you routinely advise prophylactic cranial radiation, PCI, So what is your practice pattern in your setting?
Yes, yes. If you have a complete response after chemoradiotherapy, then prophylactical cranial radiation we give routinely almost to every patient.
So you will routinely offer a PCI? Okay.
Provided it to be shear.
Okay, okay, okay. Nikhil, what is your thought on thinking about immune checkpoint inhibitors in early stage disease? I mean, of course, the focus today is going to be an Adriatic study. We'll come to that. Just a broad perspective on immune checkpoint inhibitors in early stage small cell lung cancer. Do you think it's really necessary, or it is just what is your thought?
So I think all of us would agree that small cell lung cancer has been a real struggle for most of us. Although you see phenomenal responses, they are just unsustainable. And so whenever you get a disease like that, there also lies an opportunity to make a difference. And with the previous data, what we have with, let's say, Pacific or other, where post-CTRT possibility of IO, one option, and with the Caspian.
At least the effort started, way back more than 4 or 5 years ago. This paper came 2020 and 2021 on adjuvant Epi-Nivo, post-consolidation, whatever. And then came these important studies, Adriatic. And then there are other studies which are looking at atezolizumab, pembrolizumab, sermipilimab in this space, but different styles, either as consolidation or as these are all emerging. Let's look at the Adriatic, which is now presented in this ASCO 2024. So this is a very powerful data, and we are just going to look at the durvalumab placebo, that segment alone, nearly 600 patients in that. And you would see that it includes patients. PCI is permitted before randomization, and this study allows 2 cycles can be given before they randomize into. That's why I asked 2 cycles of chemo can be given before they get into the concurrent CTRT arm. So that's comfortable with this. And this is the number of patients, 200, 300 on almost. So these are the survival curves. Very, very powerful PFS curve. 16 months as versus 9 months for the placebo arm. And a very impressive overall survival curve. 55.9 months as compared to 33 months. Dr. Piyush, so is this a very good data, practice-changing data? What's your thought?
It's absolutely a practice-changing data, sir, because in such a disease process where we were seeing quick relapses, so definitely overall survival data coming up is definitely encouraging.
Ghanshyam, do you think it's a practice-changing data?
So I'm surprised when Nivo-EP has worked across all solid tumors, even in the bad subset. So here it did not work where the hazard was crossing 1 point with a PD-1 plus CTLA-4, and here we are using a PD-L1 and another CTLA-4, and that is showing absolutely a different. So why this phenomenon is happening? So that is a surprise. Otherwise, the data is absolutely astonishing.
You heard Professor Allison's talk today,
right,
that it is not necessary that, a so-called, we talk about cold and inflamed, then where we get stumped is, we think all inflamed, and see, small cell lung cancer has got a lot of mutations. That's what people thought. But then he went on to show that there is something called immune exhaustion. There are more Tregs sitting there which are going to be detrimental. So there are more things happening which we still do not know. So that could be the answer to your question. So coming to this PCI, to Dr. Sanjeev, the Adriatic showed that with PCI, without PCI, still the benefit was there when they added immunotherapy after the CTRT arm. But with PCI, the PFS was much more amplified, and the OS also is good if you have PCI or no PCI. So based on this, there is some possibility that a careful follow-up, MRI follow-up is allowed, but PCI still is, I believe PCI is still mandatory, and so that's what I think. What do you think, Dr. Sanjeev?
Definitely. And if you're
at least look at the PFS and the OS with PCI.
Definitely it's superior.
Ghanshyam, would you want to PCI all your patients or not?
Yeah, I'm a good friend of radiation, so I'll definitely
good friend, okay. So then Nikhil, carboplatinum or cisplatinum?
So contrary to the understanding, the carboplatin arm did better than the, I mean, if you really look at the comparison. And not only that, when you look at the comparator arms, can you sir, go back to the previous one? Even the comparator arm also, they were almost similar on both sides. But so we do not know the real reason why the carboplatin did better, where the assumption probably was cisplatin would have been better considering better responses are expected. But I would choose depending on the patient's normal comorbid conditions and take a call.
Platinum tolerability.
Yeah.
Got it, yeah. So, Dr. Sanjeev, you know, it is shown that, other than the conventional fractionalization of radiotherapy, if you were to do a, can I call it as BID means it's accelerated, and 45 GY is probably better than the conventional regular schedule. So, is that?
I look at the paper in detail actually. Very interesting data, really interesting, because usually we give 2 gray per fraction around 60 to 66 gray. But when we are using 45 gray, maybe 150 gray twice daily with 3 weeks.
Correct.
So it is called hyperfractionated radiotherapy. And the total dose, if you compare with the 2 gray equivalent, the 45 gray dose is a bit lesser. But interestingly, the response and the survival is better with the 45 gray. And probably the reason, because you are using immune checkpoint inhibitor along with high dose radiotherapy, the dose is around 3 gray per day. So that is why probably that has happened. Otherwise, usually what happens, we give more dose of radiation, we get better response, better result. But here it is different. Equivalent dose, the 45 gray is lesser actually, quite lesser, around 40 to 43 gray, 2 gray equivalent.
But do you practice this BID, 45 GI?
We sometimes practice when we have a big volume. That's why just to have less dose to the normal tissue, we practice sometimes hypofractionated, but hyper never.
Even the overall survival seems to be better, even though, of course, this is one study. I'm just so this patient, of course, as per the case, went on to receive durvalumab, and the patient for the brain was put on surveillance. That's what was done. So then, if we have to incorporate this particular schedule, if I were to use durvalumab consolidation in all our patients post CTRT, Dr. Ghanshyam, how much are you worried about the side effects, safety profile of this particular approach?
So we have also seen the same thing in the stage 3.
This data was presented in Astro, October 24. Right. So please go ahead.
Yeah, so we have got used to the Pacific in adenocarcinoma, where even patients are enrolled from day 0 to day 42 days. And I've been part of that. So for occasional patients, otherwise, who had a symptomatic pneumonitis, who are on steroids, otherwise most patients sail through, sir.
Dr. Piyush, comfortable with adverse events if you want to go full throttle all along with concurrent CTRT followed by immune checkpoint durvalumab? What will be your thought?
Of course, the thought of pneumonitis is definitely there to expose it immediately. Now the data is one of the forest plot analysis of Geriatric did show that, you know, the earlier you're introducing it, the forest plot is more favorable. But having said that, we are probably seeing patients who are recuperating and the lung is recuperating. So I think so around 3 or 4 weeks is the most of the times which come to our mind.
Okay. No, that, I mean, on a practice point, I'll just come back to your, this one, okay. Now, do you anticipate more pulmonary toxicity?
Yeah.
And in that case, what would you want to do especially? Is there anything that you want to tip the patient? What do you want to do, Dr. Sanjeev?
See, pulmonary toxicity in such case of 2 types. One is maybe immunotherapy induced or some things like radiation induced. If you talk about radiation induced pulmonary toxicity, that is what I told you give 2 cycle chemotherapy followed by CTRT, okay, because you will have a smaller volume, so that toxicity will be less. Again, if you are using the dose of 45 gray in 30 fraction.
The radiation pneumonitis is 22.9% in the durvalumab arm and 23.4% in the placebo arm.
So it is same. So whatever pneumonitis probably was due to radiation itself.
So anyway, it's going to happen.
Yeah,
right.
That is what, if you are using that 45 gray dose schedule, no, probably it will be less.
But the only good thing is the treatment discontinuation was not very huge, but still 8% of the patients on durvalumab arm can have difficulty and may have to be discontinued for pulmonary toxicities, but the placebo arm also had 3% discontinuity. But if you look at any grade, it's 38 to 30%. So this is one thing that these are the important things. You may encounter grade, some pneumonitis, some anemia, neutrophil, and esophagitis, of course. So is there anything that we can do specially to mitigate these toxicities, Dr. Sanjeev?
The only thing, as I told you, you have to reduce the
maybe
volume.
the volume. That's
what the volume.
Giving couple of cycles, bringing it.
Slow
so
down
when you radiate, you target the original disease volume, or you look at the new volume.
Usually, we should target the GTV pre-chemotherapy volume along with
Correct.
some margin.
So how does that change then?
So then what happened after 2 cycle or 3 cycle chemotherapy, the size regressed. But what happened? No, you will get some dose in the microscopic area where it was there earlier, and more dose in the central area where it is there.
What do you do? That's all. That concept is understood. What do you do in practice? You target the original, what do you call the CTV, treatment volume?
Yeah,
or
when we are going up to 60, 66 grade, no, that's what we give more dose to the central one, the
now, if you
residual
want to do the BID dose, you want
the BID dose will be different, because in BID dose it is safer actually, because the total dose is less, it is 45 gray. So when total dose is less, and at the same time we are giving 1.5 gray per fraction, and this, the difference between the two doses is more than 8 hours. That is what happened, the toxicity will be less. That is called
the ASCO practice guidelines now would recommend durvalumab as post after the concurrent CTRT for about 2 years. This has now come into the latest version of NCCN. Category 1 recommendation for limited stage durvalumab, that's the standard of care. PCA is also a standard of care, but you can also have an alternative to consider MRI surveillance. This is the current standard of care for small cell lung cancer. So I can say, based on this data, that probably consolidation durvalumab will become the new standard of care for patients who have early stage small cell lung cancer, with a very impressive median overall survival of 55.9 months. Nikhil, do you agree?
Completely agree on this.
And the last word always to Ghanshyam. What should we do, Ghanshyam? You will take it home and do it on Monday, or what do you want?
Absolutely, sir, absolutely. So Monday I will take leave, this Monday.
You are granted leave with a lot of thanks and appreciation from all of us. Congratulations to you. And thank you for bringing this panel. Thanks AstraZeneca for bringing. Thank you.
Thank you, T. Raja sir and the panelists. So we'll proceed with the photograph first.
Photographs are allowed?
Just a gentle reminder that we have our industrial exhibition hall on the ground floor. Please do visit. For our next symposium, symposium number 13, which is sponsored by Roche, we have panel discussion on the management of metastatic non-small cell lung cancer and role of Tecentriq, latest case studies discussion. I would like to call upon the stage moderator Dr. Sushant Kumar Paikre sir, medical oncologist from Bhubaneswar.
Good afternoon to all. Good afternoon to all. That I call my panelist here, Dr. Srigopal Mahanti, Medical Oncology from ACG, Dr. Prashant Kumar Parida, Medical Oncology Consultant, Acharya Harrier, Dr. Tanushree Mishra, Radiation Oncology, Bhubaneswar, Dr. Dipti Rani Samant, Medical Oncology, Acharya Harrier, Dr. Samarendra, Radiation Oncology, Apollo, and Dr. Tamojit Chaudhary, medical oncologist, Jamshedpur, and Dr. Saurabh Radhakrishnan, medical oncology, Thrissur. I think Dr. Sri Gopal, he is coming, and Dr. Saurabh. No, Dr. Samarendra, Dr. Saurabh Radhakrishnan. Oh, Sri Gopal, that's it. Okay. Huh? No, it's Sri Gopal. Saurabh Thrissur. Okay, so one panelist short, like Dr. Saurabh Radhakrishnan, Thrissur. Okay, so not too late. So we'll discuss today about the immunotherapy. What is the importance of immunotherapy in metastatic non-small cell lung cancer? So before that, how we evaluate our patient when a metastatic lung cancer presented to us. So what we see, Dr. Sri Gopal, we'll go for FNAC, biopsy.
We do biopsy, true cut biopsy mostly in practice, and then most of the cases as we do the true cut biopsy because next we go for the genomic testing. If it's a non-small cell lung cancer, we go for genomic testing straight forward from the biopsy histopathology sample if it's a confirmatory of non-small cell lung cancer, just to preserve the tissue. Then we subject the tissue for NGS if it's available, otherwise if affordability is there, otherwise minimum 12 gene panel we do.
Dr. Tamojit, what NGS panel routinely you are sending?
So if means logistics are not an issue, then always a broad-based panel as per the current guidelines. But if usually most commonly in practical scenarios, we do either a 12 gene panel along with PDL1, but preferably is a broad gene panel, which is a hybrid NGS platform.
Okay, thank you. Madam, Dipti Madam, should you test NGS panel in squamous cell carcinoma in lung cancer?
You see, always we do not know NGS panel can be tested in squamous cell lung cancer because sometimes we see patients who are adenosquamous also.
Exactly.
We cannot just leave them. We have to do NGS in every case before going into details. And whatever you discussed, like in all patients, we of course not able to do broad-based gene panel, but maximum case where feasible, we have to go for broad-based gene panel. That will help us in our clinical practice.
Dr. Prashant, along with NGS, do you sending PDL1 assessment?
Yes, PDL both in squamous as well as non-squamous NSCLC. Even though we'll get PDL because it is a IHC test, we'll get a report within 1 week. So, but still, if you have a PDL1 report in your hand, you should wait for the NGS report to start some IO-based therapy.
Okay. So that the conclusion from our medical oncology is that we have to do a biopsy. No need of FNAC. You can to start therapy. You may do FNAC and biopsy same time if you see that patient is in shortness of breath or required immediate treatment. So you can do FNAC and biopsy simultaneously. Otherwise, for proper assessment, we need biopsy. We need genetic assessment, NGS for lung panel, at least 12 to 13 gene panel, for which it cover at least ALK and EGFR ROS like that. And along with that, we need PDL1 assessment. So, so my question to Prashant sir, that when you tell it is PDL, you start immunotherapy upfront in case of advanced lung cell cancer.
So if a targetable mutation or NGS report biomarker negative, then I decide my therapy based upon this PDL1. If someone have high PDL1, more than 50%, then I have option of using monotherapy, pembrolizumab, atezolizumab, or cemiplimab. If less than 50%, though the guideline says even after more than 1%, you can use monotherapy, but I always use some sort of chemotherapy along with IO.
Thank you. And Dr. Dipti, is there any specific marker that platform you need to know that whether the PDL1 is more than 50% or any specific marker for specific molecule?
Definitely, because whatever you are doing on the different platforms you are using, but that is SP221C3, and but specifically for this molecule like we are discussing today, for atezolizumab we have to SP142 platform is desirable, and we have to ask for also, because presentation or whatever expression will definitely differ according to platform. And for atezolizumab, definitely SP142.
Thank you, madam. It is correctly answered that for atezolizumab is 142, SP142. Dr. Tamojit, can you tell that what are the platform for to assess the to give the immunotherapy? What are the platforms?
Yeah, so it depends. You want to use a PD-1 inhibitor or PD-L1 inhibitor. Usually for Nivo and Pembro, which is PD-1 inhibitor, we use a DACO platform. The antibody is different. For Nivo, most of the trials have been done with the 28-8 antibody. For Pembro, it's 22C3. And similarly for PD-L1 antibodies, you want to use a Ventana platform. And again, according to the drugs, the antibodies are different. Like just said, for Atezo, most of the trials done with the SP142 platform. For Durva and Ave, predominantly SP263 platform. But newer trials with Atezo are done with, means more preferable is the SP263. So gradually, probably we are moving from SP142 to SP263 for Atezo and other PD-L1 inhibitors.
Thank you. Dr. Srigopal, that it is here is written, and Prashant sir also answered that if PDL1 is more than 50%, is we have to give that monotherapy. You have to give immunotherapy as a single agent. But what is 50%? What is that score? It is combined positive score or TP score or IC score. What is this?
This is what about PDL1 TP score. So TP is more than 50%, so we go for immunomonotherapy just to avoid chemotherapy associated toxicities. There is no added benefit, and we are in plus going to give more toxicity. So there is no point of adding chemotherapy when we are having a PDL1 more than 50% high PDL1 score.
So it is CPS score is more than?
It is TPS score, TPS,
okay.
tumor proportion score.
Okay. So just to review that if it is CPS score is 50%, we have to give IO monotherapy, and different molecules are recommended like pembrolizumab, atezolizumab, cemiplimab, and nivolumab and ipilimumab. To see already it is discussed for atezolizumab, we have to request for SP142 based result before initiating atezolizumab. So these are the that I collected from that that thing is that for assessment, for immunotherapy assessment, to give immunotherapy in different organ specific cancer, we have different platform. So as per the trials, so it is based upon which organ you want to use, which molecule you want to use, on that basis, and which score you are want to use. On that basis, we have to perform the assessment for the PDL1. It is mostly based on the that is it is only by the ISC. And another thing, to use immunotherapy, we need not only the PDL1 assessment, it is also tumor mutation burden and MSI scoring. So for non-small cell lung cancer, we are discussing today. It is the for atezolizumab is Ventana SP142. And 22C3 pharma, the DACO platform, it is the score is TPS, it is for the pembrolizumab. And if you want to use nivolumab with ipilimumab, it is 28-8 by DACO platform, it is TC expression. And accordingly, I mentioned gastric, cervical cancer, urothelial cancer, head and neck. So for this, for pembrolizumab, we have to use 22C3 by DACO platform. So like triple negative breast cancer, also we need 22C3 by DACO platform, and Ventana SP142 for the atezolizumab. So these are depends upon the which score we want to use and which organ we have to use. So this is the recommended guideline. And you see, if you advising the SP142 or 22C3 or 28, the scoring is based upon the organ and the platform. So these are the different definition of PD-L1 scoring. That tumor population scoring, that is percentage of viable tumor showing partial or complete membrane staining relative to all viable tumor cells present in the sample, positive or negative. The combined positive scoring is PD-L1 positive divided by total number of viable tumors. So the TC score is tumor cell score, that is percentage of PD-L1 positivity cells in any intensity, and immunocell score is proportion of tumor area occupied by PD-L1 positive immunocells at any intensity. So these are the different definitions. Sometimes we are confused, but before advising the PD-L1 scoring, we have to see what type of molecule we want to use in this patient and in which organ. So already it is discussed, if the patient is high PD-L1, all the meta-analysis showing that all the trial favors immunotherapy upon the chemotherapy part. So this is the trial. Here they used chemoimmunotherapy versus chemotherapy immunotherapy plus chemotherapy combined. That they shown that there is no added benefit. As already panelist mentioned, there is no added benefit if the PD-L1 scoring, CPS scoring is more than 50%. So these are the different trials here. As we know that IM power 110, it is for the atezolizumab monotherapy. And IM power 130, it is the steroid sparing chemotherapy regimen. If I ask to Dr. Prashant, in IM power 130, that how they spare the steroid?
Yes, in this IM power 130, non-squamous, non-small cell lung carcinoma, so platinum and nab-paclitaxel, where we can use steroid, because we know using IO drugs in immune suppressed patient or patients taking steroid, these are contraindications. So this is a steroid sparing regimen chemotherapy along with atezolizumab in IM power 130, where there was OS and PFS benefit.
Which combination we can use?
Yes. So platinum, cisplatin, carboplatin plus nab-paclitaxel plus atezolizumab.
Madam, about steroid sparing regimen.
Whatever Prashant highlighted, the steroid, we should not give steroid for immunotherapy, and it is a very good combination because nab-paclitaxel not having any anaphylactic reaction, and you can spare steroid here. And that is a steroid sparing regimen, and patient, if the patient is diabetic also, you have to think of regarding his hyperglycemia condition. In those conditions also, we can spare the steroid. And this is a very good trial to give us this, there is OS and PFS benefit also. And this is a combination of nab-pacli, atezolizumab and C-SER carbo combination. It when compared with only with chemotherapy, good PFS and OS.
Dr. Tamojit, is what is your dose of nab-paclitaxel in when steroid sparing regimen?
So either weekly or 3 weekly, I'm not remembering what is used in this trial, but usually what I use it for Caucasian population, if you want to use 3-weekly schedule, then 200 mg per meter square. For Indian patients and South Asian patients, usually we use 175 mg per meter square. If the patient is not tolerating, it is always advisable to convert to a weekly schedule.
I am asking about nab-paclitaxel.
Yeah.
The nab-paclitaxel and paclitaxel is same dose, or it is different? Because if you
weekly is preferable.
Weekly preferred. Dr. Srigopal.
The dose we use based on the patient profile, and 3-weekly dose we go for 175 to 200 mg per meter square. There is a comparison between 200 mg per meter square versus 260 per meter square. There is no added benefit of 260 per meter square in spite of higher toxicity. So 200 per meter square, and in Indian context what sir has highlighted that 175 per meter square is also a fair option. So we go, yeah.
Nab-paclitaxel can be given 3-weekly dose 200 mg per meter square.
Can be given, yes, safely can be given.
Okay, then my question to Dr. Tamojit, what about the 4-drug combination like IM power 150, atezolizumab, bevacizumab, paclitaxel and carboplatin? Where you will use that combination of drug?
Yeah, so it's again for metastatic non-squamous patients, number one. Second thing, for practically if you want to ask, then it is practically for all comers who are either wild type for oncogenic driver mutation, or this trial is very significant in terms of showing that even immunotherapy combinations can work when the common EGFR or ALK mutation positive patients which have been enrolled in this trial, and after the exhaustion of the TKI options, if you use the arm B of this trial, which is the ABCP regimen, means atezo, bevacizumab, paclicarbo, then there is a significant PFS and OS benefit, and that is irrespective of the PD-L1 expression. So practically that is a very important statement, and a very important core group of the patients can be offered this ABCP regimen.
Exactly, rightly said.
Again, just if you look into the subset analysis of that ABCP, although we use in the PD-L1, irrespective of PD-L1 subgroup, we use this ABCP regimen in presence of also EGFR ALK mutation. So subsequent progression to NDEGFR, commonly we practice ABCP. But if you look at the forest plot, the subgroup analysis, the magnitude of benefit was more when the PD-L1 score was higher. And if you look at the PD-L1 negative cohort, the hazard ratio again was approaching 0.80. So definitely in ITT population there was a benefit. So although we are using, but still there is a better response, better survival in PD-L1 positive cohort.
Dipti madam, I want to tell something.
Actually here in this regimen, whatever we discussed now, this EGFR ALK, when they have progressed, they have taken into consideration. And when the patient is intolerant to TKI also, those patients have been included also. And the beauty of this trial is that when atezolizumab has been added with bevacizumab, that is having good response along with chemotherapy.
Exactly.
But when you have removed bevacizumab from atezolizumab, only BCP we have given, bevacizumab, carbo or cis-pacli, not having more benefit when you are comparing ACP versus BCP. When atezolizumab along with bevacizumab, along with platinum and chemotherapy, it is having good combination to give OS and PFS benefit.
So I will conclude that if PD-L1 is high, so you can use that immunotherapy alone, like atezolizumab or pembrolizumab as per the trial. And if the PD-L1 is the ALK and EGFR negative and PD-L1 is non-conclusive, the score is not high, then we can use 4-drug combination like atezolizumab, bevacizumab, paclitaxel and carboplatin. And if it is 1 to 50, then we can use atezolizumab, carboplatin, nab-paclitaxel combination in steroid sparing in case of where we want to spare the steroids. So this is the data that already we discussed, that 142 SP142 needed for atezolizumab, but it can be used in other platform. That data was showing that 22C3 and SP263. Here also the curves are separated. So in any platform among three, we can use atezolizumab. So then coming to our radiation oncologist, Dr. Samrinder, is there any benefit of immunotherapy in brain met patient when you don't want to radiate, or is there any interaction with radiation and between immunotherapy?
So according to the current literature, if you move forward the Keynote 001 secondary analysis and the Pembro RT trial, where they have used pembrolizumab, and that is valid for both extracranial and cranial and extracranial sites. If you're treating with radiation, these patients tend to do better in terms of PFS and OS. So if there is a brain mets and if you are using a IO, I will be definitely inclined to treat the metastatic sites first, as early as possible. Of course, after some cycles or in between. But I would not delay the radiation both for the cranial and extracranial sites if you are using IO in these cases.
So if any brain mets with lung cancer, there is no driver mutation, so you have to proceed with radiation and no concurrent immunotherapy?
So that scenario is different. If the patient has a driver mutation, there the question arises
no driver mutation.
So if there is no driver mutation and you are using an IO, then I will be inclined to go with radiation.
Tanushree madam?
Previously, it was said that if the brain met is not symptomatic, you can avoid and you can go with systemic therapy. But now new papers are coming up that radiation creates a tumor environment that favors the immunotherapy drugs to act in a better way. That's the immunogenic potential of radiation. So we must use radiation in any brain met patient with non-small cell lung cancer that we are planning for IO or that are on IO. We should not delay or you should not give any gap. It can be also used concurrently if the patient's general condition is good.
So just to clarify on this point, just before this presentation, we had a lot of presentation regarding treating the cranial sites or not. See, you have to differentiate between the driver positive patients and the non-driver patients. That scenario is completely different where you have the Adura trial where you give osimertinib which has cranial activity. Exactly. But if you are using an IO, there you should and you must as early as introduce the radiation because as Tanushree said, there is a change in the microenvironment, there is a modulation, immunomodulation, and in these scenarios, IOs combination work better. That's why.
Okay, and to our medical oncologist, Dr. Srigopal, is there in ABCP trial, is there anything that they include brain mets, I think, and they are asymptomatic? And what is your opinion regarding that, whether you advise brain radiation or not?
Asymptomatic brain mets, if it's very small size, not symptomatic, I'll still go ahead with the chemoimmunotherapy if any time still be vigilant although. But if patient is patient is responding well, still okay to continue ABCP, but any times to discuss with patient, if they're okay, we can go for radiation and you can just continue the immunotherapy part.
Yeah. So to conclude that if there is no driver mutation and patient is symptomatic brain mets, we definitely need palliative radiation therapy to brain. And sometimes as our medical oncologists tell that in ABCP trial that IM power 150, there is few patients are asymptomatic brain mets. In that case, they are responding to the ABCP, atezolizumab, bevacizumab, that 4-drug combination. So in that case, we may delay, but it is again divided. The debate is divided depending upon the physician who is seeing the patient or to take the decision of the radiation therapy if patient is asymptomatic and small brain mets. So this is the different trials. My question to Dr. Prashant, that if the patient is many comorbidities and is not eligible for chemotherapy and patient is no driver mutation, what to give in that case, non-small cell lung cancer?
So you have not mentioned the PDL1 status.
PDL1 status is less than 1%.
So definitely there is no role of IO monotherapy. We have several agents like frail patient morbidities, single agent platinum, weekly, taxane platinum. Based upon histology, you can choose your regimen. So these are the options.
It is adenocarcinoma and the patient is comorbid PS2-3 and patient has a lot of comorbidities and it is not platinum ineligible.
So you can add platinum, carboplatin ineligible. So weekly carbo or
Exactly.
gemcitabine or pemetrexed. So these are the options. You can use IO also.
Exactly.
IO in these subgroup patients. So single agent IO you may not use because we have no evidence of single agent IO less than 1% PDL.
Dipti madam.
IO combo you can consider double, dual.
But patient is not eligible for chemotherapy.
No, chemotherapy, dual IO combination can be considered if it is less than
Nivo
1%.
and
Yeah, Nivo and EP combinations. If the patient is financially.
Financial is okay.
Yeah.
There is no financial.
There is no strong benefit, whatever Prashant highlighted, but it can be considered. And whatever he is told, if the patient is not affordable for those, then carboplatin, the alternative only.
Dr. Tamajit.
Driver mutation negative, not fit for full dose chemo, PDL1 less than 1%. There is no right answer, means depending on the fitness. If you want to use dual IO, then also the issue is in that trial also 2 cycle of chemo is there.
Toxic.
So yeah, so
Nivo
depend on the choice,
Nivo
but
IP
there is no
also
right answer in that. Probably low dose chemo.
Exactly. Physician supportive care, best supportive care, or physician choice. What if, Dr. Sri Gopal, what is your answer?
Moonshot already highlighted that elderly frail, if not fit for not platinum eligible, then okay, Nivo EP is the way to go. But if you found it's eligible, then go for Nivo EP. Otherwise, best supportive care.
Okay, Nivo EP also very toxic protocol. Even if it is IO, that it's not like that. IO is always toxic free. There is definitely there is many side effects of the immunotherapy there. And Nivo EP also there. But yesterday I reviewed that one trial, that IPSOS. In that case, they taken the because of that paid. In that article I reviewed that patients, those are more than 65 or 70, and those have chemotherapy ineligible. In that case, they use first line immunotherapy like atezolizumab versus gemcitabine, single agent, or like single agent carboplatin also. They saw that the atezolizumab arm was doing well because of there is less adverse effect compared to chemotherapy, and the survival also good in that trial.
For the gemcitabine, we have to be much careful because in elderly frail patient, it causes thrombocytopenia.
Exactly. They, because it is platinum ineligible, so they are using gemcitabine. They compare gemcitabine versus, and that full article is not here. So these are the summary of the different trials. They are showing that even if the pembrolizumab and atezolizumab can be used in high PD-L1 scoring, even if visceral mets. So these are the summary of the data, all the trials. So the meta-analysis, that this analysis showing that different IO molecules favors over the chemotherapy. So this is the summary of IM power 110, that it is a positive study. In the TC3 and IC3 population, atezolizumab showing meaningful improvement, PFS, ORR, and durable response, and promising first-line treatment for the PD-L1 high metastatic non-small cell lung cancer. Then that already this part was discussed. If the patient progress on ALK, EGFR, TKI, then what is the best choice for us? So already I think it is discussed. That is the atezolizumab, bevacizumab, carboplatin, and paclitaxel. During discussion, we already discussed this part. And this is that showing that the 4-drug combination is better than the triple drug combination, that is atezo, bevacizumab, CP versus bevacizumab, CP. So these are showing that the 4-drug combination is better than triple drug combination. This is showing that the response rate also higher in the 4-drug combination. So already this type this discussion was done. Even if liver mets, due to lack of time, we can, that summary is that even if the visceral mets, that liver mets or brain mets, we can use atezolizumab we can choice, or the pembrolizumab also our choice if the PD-L1 is very high. So this is the curves showing that the 4-drug combination is better. In 18 months, it is the PFS is 23.3% versus 1.8%. So with this, I conclude my discussion, and thank you all my panelists.
Thank you, sir. I would invite Dr. Sushant Kumar Paike, sir, and all the esteemed panelists for the photo. For the next talk, I would like to invite Dr. Amit Dilip Bhatt, sir. He's a medical oncologist from Pune. Please, sir.
Can I have my slides? Thank you so much, the organizers, for the opportunity. I'm going to talk about esophageal cancers. Let's just change gears from lung cancer to esophageal. Esophageal cancer always has been the proverbial neglected child, because we all talk about breast cancers and and lung cancers, and a lot of sessions are devoted towards that. But if you look at the Globocan 2022 data, you will see that esophageal cancer has jumped from number 9 to number 5, more than any other GI cancers. Now, esophageal is now a significant cancer to deal with. We have seen the increasing incidence, and it's important for us, it's food for thought why it is happening, but it's very important for us to know about treatment patterns in esophageal cancers. So unfortunately, chemotherapy always has been the backbone of esophageal cancers, and we did not give very great survival. The usual survival overall 5 years was less than 20%. 1 out of 5 did not see more than 2 years. And this gave us the need for having good therapies, and better tolerated therapies. And here was the need for immunotherapy. Now, if you look at treatment protocols today, almost every protocol incorporates an immunotherapy in the protocol. Today, what I'm going to speak about is a newer immunotherapy agent, apart from the routine ones which you have been using. And we'll look at a trial which shows its data for esophageal cancers. We spoke about toripalimab yesterday in head and neck NPCs, and toripalimab, this is data for esophageal squamous cell cancer. It is advanced treatment naive disease, Jupiter 06 trial, toripalimab plus chemotherapy. Before we go on to the actual trial, let us just have a small discussion about why toripalimab and compared to the other existing nivolumab. So if you look at the data for the pharmacokinetic data, toripalimab has a different epitope. So toripalimab engages more targets, it's better associates with the tumor, and the dissociation is also very slow, which leads to more efficacious and lesser side effects. So that is how toripalimab is. There is no head-to-head comparison, but if you look at pharmacokinetics, it is a little better than the existing immunotherapy molecules. Now, this is the Jupiter 06 trial. It was a multicentric phase 3 trial. All adult patients, locally advanced or recurrent metastatic esophageal squamous cell carcinomas were enrolled. They were treatment naive, and they relapsed more than 6 months. If it is if it was TP previous regime, more than 12 months. For non-metastatic, there was no prior use of ICI. No immunotherapy was involved. These are all immuno-naive patients. And good measurable lesions must be present, and obviously good performance status as well. These were randomized 1:1 to the toripalimab arm, which was 240 mg fixed dose. Another advantage of toripalimab, the vial comes in 240 mg,
and you use the entire vial. There is no drug wastage like happens in other immunotherapies. Toripalimab 240 mg. Toripalimab 240 mg with chemotherapy. The chemotherapy regimen is what we normally use, paclitaxel plus cisplatin, this 3-weekly regimen for a repeat of 6 cycles, followed by toripalimab maintenance for every 3 weeks, single agent toripalimab. The second arm was placebo with the same chemotherapy regimen, paclitaxel plus cisplatin, given every 3 weeks for 6 cycles, and followed by placebo maintenance. Co-primary endpoints were PFS and OS. Secondary endpoints were PFS and PFS by the investigator, overall response rate, duration of response, PFS safety, and quality of life. So looking at the basic demographics, most of we see in our practice routinely, most of them were elderly. Median age was 63 in both the arms. Male predominance, again a very common thing which we see in our routine practice. Most of them had 13% had previous radiation. We use radiation quite often in treatment of early esophageal cancers, and most of them had radiation. If you look at metastatic disease, almost 80% were metastatic disease and treatment naive. PD-L1 expression, we have been talking about PD-L1 throughout the yesterday and today. We all know PD-L1 is not a very specific marker and it has a lot of fallacies, but we still use and classify as done in all clinical trials. We look at PD-L1. We are now wiser that the patients show response irrespective of their PD-L1 status in most of the trials. The CPS more than 10 in this trial were around 44% and CPS less than 1 were around 16%. So if you look at the efficacy, the progression-free survival, this is the blinded independent central review assessed PFS. So again, the Kaplan-Meier curves, nice separation at the onset in the first 2 months. Yesterday we were discussing about immunotherapy, and if your patient finishes the first 2 months of immunotherapy and does well, probably is going to do well later on as well. And that is usually most of the immunotherapy curves. Toripalimab is no different. There was a 42% reduction in the progression or death. And the PFS was significant, 5.7. The 1-year progression-free survival rate was 6.1 versus 27.8%. So again, it's a significant amount of difference when you add toripalimab to a chemotherapy backbone. The subgroup PFS, again, males, irrespective of age, males, they did better. Females, unfortunately, if you look at most of the immunotherapy trials, females didn't do better. You always have the forest plot crossing 1. If you look at any random immunotherapy trial, most of us, we don't know the answer to this, but yes, that is what we see. Irrespective of metastatic status, patients did well. And PD-L1 who had more than 1%, they all showed response, and significant amount of HR ratio rate is ranging from 0.58 to 0.65. Efficacy, the overall survival rates, again, this is the data intent to treat population, data cut off in March 21. And if you look at the 1-year overall survival rate, it was 43.7 versus 66% for the toripalimab arm. And the 2-year overall survival is not reached. If you look at the Kaplan-Meier curves, again, like we see the plateau in immunotherapy trials, after 1 year, the people who are responding continue to response and the overall survival plateaus off. You see the tail is virtually flat, and there is 42% reduction in the risk of death. So again, there is good PFS benefit, there is good OS benefit when you add toripalimab to a chemotherapy regime for esophageal squamous cell carcinomas metastatic. Subgroup OS, again, if you look at the metastatic status, locally advanced or metastatic, both did pretty well. PD-L1, if it was more than 1%, they did well. If it was more than 10%, they did very well. The median was around 17 months versus 11 months for PD-L1 less than 1 and more than 1. Again, if you look at the forest plot, it's always that females, the ratios are crossing 1 and females don't do well. Tumor response rates, obviously when you are dealing with a metastatic esophageal cancer, you need a good response. You want your patient to start eating as early as possible and good symptomatic relief. Complete response was seen in 11.7% patients, and the partial to stable response was seen in most of them. So almost 70% people had some kind of objective response. as compared to only half in the non-toripalimab arm. Disease control rate was almost 90%. So again, this is a good take-home message that when you add immunotherapy to your chemotherapy backbone in metastatic esophageal squamous cell carcinomas, you get some kind of disease control, and obviously this leads to a good quality of life because patients are able to eat well, they start gaining weight, they start gaining their wellness and their confidence as well. Median duration of response was 5.6 versus 4.2 months. The safety results, nothing abnormal in this. No red flags over there here. Anemia, leukopenia, neutropenia, most of the things were probably because of the chemotherapy. The immunotherapy side effects were always there. Immune-related adverse events in almost 37% of the toripalimab arm, and leading to discontinuation, it was 11.7%. So out of 10, 9 people will continue toripalimab because it's very well tolerable. Only one might have severe enough side effects so that you'll have to top toripalimab. So my last slide, I'll summarize quickly. So toripalimab, so again, summarizing this data, toripalimab, here is a new immunotherapy option for using in your esophageal metastatic squamous cell carcinomas where you need quicker response and good quality of life. The 1-year overall survival rates, there's a 43.7% benefit. 1-year PFS was 27 versus 6%. So that is in fact probably good enough for us to get convinced. A PFS survival of 27 versus 6. And there is objective response rate, again, which helps maintain good quality of life. So Jupiter 06 showed that addition of toripalimab to the paclitaxel cisplatin TP backbone of chemotherapy for first line for advanced and metastatic esophageal squamous cell patients showed superior PFS and OS than only the chemotherapy arm. And the PFS and OS benefits were observed in all groups. If they're irrespective of the PDL1, if a PDL1 more than 1%, the results were better. If the PDL1 was more than 10%, they were even better. But there is some kind of response in all the PFS was 5.7 versus 5.5, and overall survival was 17 versus 11 months. Significantly impressive HRs of 0.58 both sides. And obviously there were new safety signals identified with toripalimab when added to chemotherapy. So this gives us a new option, a new armamentarium in our treatment of esophageal cancer metastatic. Thank you so much.
Thank you, Amit sir. So for our session 5, we have IO in rare and challenging situations. For this, I would like to invite our chairpersons, Dr. Sameer Khatri sir, medical oncologist from Delhi, Dr. Harit Chaturvedi sir, surgical oncologist from Delhi, and Dr. Niharika Patnaik ma'am, pathologist from Bhubaneswar.
Good evening, everybody. Without wasting much time, I would like to invite the first speaker for today's topic. Geriatric is age only a number for IO, and for this, I would like to invite Dr. Aarti Kannan. Dr. Aarti, please. She is a geriatrician at Mumbai. Over to you, ma'am.
Thank you, sir. Hi, everyone. Good evening. I'm Dr. Aarti. I'm a practicing geriatrician. I'm a US board-certified internal medicine and geriatric specialist. I studied at University of Connecticut and Stanford University before I returned to India and started my practice in Apollo Hospitals, Bangalore. I then moved on to my own private practice earlier at the end of last year, and I plan to start in a clinical administrative role in an upcoming hospital in Bangalore. Today we're going to be speaking about a very interesting topic. I'm one of the few people I feel very massively outnumbered by oncologists here. But is age only a number for immuno-oncology? So when I got this topic, I thought about answering it as one or the other. Is age just a number or is it not a number? But then I thought, why can't it be both? There are situations where age is just a number, and then there are situations where it is not just a number. So before we go on to the presentation, there's something very interesting I noticed today in an NEJM editorial that I came across. In October 2024, in the editorial in the New England Journal of Medicine, there was an article about the therapy of Hodgkin's lymphoma. Can it get any better? So the comparison was done between brentuximab vedotin with AVD versus nivolumab and AVD. And it showed that nivolumab actually had better outcomes in terms of 2-year progression-free survival. But what was interesting in the 60 and above age group was that there was an 88% progression-free survival at 2 years in the nivolumab group, as opposed to the brentuximab vedotin group, which had a 65% progression-free survival at 2 years. So there was a whole 23 percentage point improvement. And not just that, nivolumab also had a better tolerability profile, barring neutropenia. So the reason I'm bringing this to the forefront at the initiation of our discussion is older adults typically seem to behave differently and unpredictably to immunotherapy. And it throws light on why we need more research and more stratification, age-based stratification in the publications that we bring out in terms of immuno-oncology. So age is not just a number. We'll start with that. The paradox that older patients exhibit in cancer immunotherapy. So we all know that immunosenescence is at the center of an aging immune system in an aging individual. So you have immune dysregulation, you have tumorigenesis on one hand, and we say that older adults are typically at a higher risk of developing tumors. On the other hand, in certain situations, we see that they respond more favorably to immune checkpoint inhibitors. And some part of this immunosenescence or older aging system paradoxically seems to contribute to these somewhat favorable outcomes in some situations. So immunosenescence is typically a reduction in adaptive immunity, where the naive T cells drop, you have memory T cells that go up, and you have reduction in resistance to infections. You have increased risk of autoimmune diseases, which is also paradoxical. And it's associated with the process of inflammaging, which is a chronic low-grade inflammation driven by senescent CD8 cells, an activated stress response with increased catabolic hormones and a decrease in anabolic hormones, and an inflammaging phenotype with pro-inflammatory cytokines, interleukins, TNF-alpha. So in a study that was conducted at UC San Diego by Castro-Carter et al., titled "The Strength of Immune Selection in Tumors Varies with Sex and Age," they went through retrospective data of several thousand cancer patients from the NIH Cancer Genome Atlas and the International Cancer Genome Database Consortium, studied over 1,000 driver mutations in these cancer patients. And they found that there were no age or sex differences in the major histocompatibility complex function. But the younger and female groups had a poorer response to immune checkpoint blockers, but the older and male groups had a better response to immune checkpoint blockers. Now, why did this happen, or how did this happen? Through a process called as immunoediting. So if you see the green cells or the normal cells on the right top of the slide.
Dr. Aarti,
Yes.
Here. Sorry. Can somebody, these slides are not moving here. Yeah, no.
Okay, thank you. So the normal cells which are on the right top of the slide, because of any mutagen, would get transformed. Some of them would get transformed into highly immunogenic or the orange-colored cancer cells to the top left of the slide. And then they undergo an elimination process by our immune system, because of which you have the extrinsic tumor suppression that happens. But there's an alternate pathway that it can take, where these highly immunogenic orange-colored cells sort of really start getting attacked by the immune system, and then they reduce in number. And then you have these poorly immunogenic cells, which are pink and gray in color in the middle and to the right bottom of the slide, with they're increasing in number because they remain invisible to the immune system. So there's a selective elimination of the cells that are very good at presenting their mutagen, as opposed to those that don't really are really poorly visible to the immune system. So in better words, female younger patients have the strongest and most robust immune response. Driver mutations are more invisible to the immune system. There's stronger immunoediting that happens. And then the tumor retains fewer driver mutations which are presentable to the host T cells by MHC. And then they escape the immune mechanism. In contrast, the older patients have a mitigated immune selection process by the MHC2 presentation of driver mutations by a reduced CD4 to CD8 ratio, higher telomere attrition in CD4 than CD8 cells, and accelerated senescence. This somehow seems to work to their benefit in some of these situations. A few studies that I would like to bring forth to your notice would be, one of them was dostarlimab for primary advanced or recurrent endometrial cancer. What was interesting was in the patients who had, in the results, the ones who had mismatch repair deficient, the DMMR microsatellite instability high tumors, when their progression-free survival at 2 years was compared between the dostarlimab and the placebo group, it was actually about 4 times higher. So you had a 61.4% progression-free survival as opposed to 15.7% in the placebo group. In the overall population, the 2-year survival was 36% in the dostarlimab group and 18% in the placebo group. And the overall survival at 24 months was 71.3% in dostarlimab and 56% with the placebo group. What was interesting about this was that they had a representation of older adults in their clinical characteristics at baseline. So this was one of those studies that actually did, if you look at the highlight in yellow, under age, it says greater than or equal to 65 years, that's the geriatric age group. And they looked at what percentage of these patients were under the dostarlimab versus placebo groups in both the DMMR MSIH population as opposed to the overall population. So this is really important. What I did not see in the study was the subgroup analysis based on age. That would have been very interesting to see if there was an actual difference in the geriatric age group outcomes as opposed to the younger folks who were in the study. The second one was overall survival with pembrolizumab in early stage triple-negative breast cancer. Now, triple-negative breast cancer, typically the median age of presentation is much younger than the ERPR-positive breast cancers, which tends to happen more in the 60s. The median age would be close to 60 is what I'm assuming. But these breast cancers are more common in younger women, but that does not mean that there is not a significant cohort of older women who do have triple-negative breast cancers. So even though there was an improvement with the pembrolizumab plus chemotherapy group, there was an 86% estimated overall survival at 5 years as opposed to an 81.7% in the placebo chemotherapy group. So like a 5% point increase, which is quite significant. But what they did not do was they didn't do a age subgroup analysis, or they didn't even characterize the baseline data to my understanding. So we'll pass this. Elderly patients and immune checkpoint inhibitors. So there was a study that was done by Agnes Biliary et al., which was published in Current Oncology 2021. The safety of immune checkpoint inhibitors in elderly patients, an observational study. So they cohorted patients to less than 70 and more than 70. So the younger folks were actually considered to be less than 70 years of age. The older folks were 70 and above. What was noticed was interesting. The dermatological or skin-related immunological adverse events, immune-related adverse events, were 3 times more in the older patients. Whereas the endocrine, like adrenal insufficiency, thyroid insufficiency, were all more prevalent in the younger cohort, in the younger population. There was an overall lower incidence of all-grade toxicity in the elderly. Those who were more than 70, there was a lower incidence of all-grade toxicity. Now we'll speak about why age is actually just a number. We spoke about why age is not just a number. Now, a 65-year-old with type 2 diabetes, triple vessel, atherosclerotic cardiovascular disease, maybe has fallen twice in the year, is on 12 prescription medications, is not the same as a 65-year-old who's in the pink of their health, who's running a marathon every year, and who does strength training every day. That's why age, that's a situation in which age is just a number, needs to be seen only as that. So you have the, the basic assessment of older patients for cancer chemotherapy. The simple way to look at it would be, even though there's a lot of guidelines that are now coming up saying the comprehensive geriatric assessment is a best practice, it would be good to have. It takes time and it takes skill to do the CGA. It takes about an hour to perform a comprehensive geriatric assessment, something that many oncologists don't really have in their clinic. And there's also not enough trained professionals to conduct the CGA in many of their older patients. So the G8 screening tool for frailty is very quick and easy. If they screen positive, then it's better to consider a CGA. If they screen negative, then we can go ahead and use whatever we use, such as the ECOG performance status. Frailty assessment tools are very important. So sometimes not doing a CG and just looking at frailty assessment could be a great step towards understanding whether a patient is, like what we could do to optimize a patient before chemotherapy or immunotherapy. So the simpler assessments are, for example, a gate speed of less than 0.8 meters per second has 99% sensitivity for detecting the frailty phenotype. And then you have the frail questionnaire and the clinical frailty scale. They're all question-based. And a lot of the response really comes from the patient's subjective understanding of where they are at. Multi-domain frailty assessments, Edmonton Frail Scale and the Deficit Accumulation Frailty Index are actually very useful multi-domain frailty assessments, which would reveal reversible conditions and target domains for those interventions. So, for example, whether it's a physical therapy-related issue, psychology, or social supports, we can actually improve these patients' frailty status and then optimize them for the right kind of therapy. Rethinking what we do with frailty assessments, we should not use frailty assessment as a way to withhold potentially effective treatments, but as a tool to facilitate patient-centered care. So we try to increase physiological reserve and build robustness and resilience and mitigate stressors. That's the whole goal of frailty assessments. So this quick slide shows that there is a spectrum of fit to end-stage frailty. The goal, lifestyle intervention, disease management, preventive care all differ across this spectrum, which is why when we take a look at a slide like this, we understand that all patients of the same age do not get the same types of interventions and they don't have the same goals. Aspects to consider during treatment discussion: safety, tolerability, financial toxicity, percentage risk of hospitalization due to this particular immunotherapy agent, and documenting adverse effects on the registry. Current challenges are that most studies don't actually have enough older patient representation in their data, even if it is a pan-age group study. And there's also a fear of enrolling frail and pre-frail patients, which shouldn't really be there. I think we should be enrolling more of older patients, regardless of their frailty status, into appropriate studies. The solutions would be application, use of multi-omics, multidisciplinary, high-powered prospective studies in RCTs, including frail and non-frail older adults. In research publications, requiring authors to submit age distribution of study population and age-based analysis, adding geriatric oncology experts to journal reviewers, and among patients older than 65, we have stratification of data for incremental age group for subpopulation stratification of outcomes. The Gospel study is one of the studies I came across that has it's an ongoing clinical trial protocol, which focuses a lot on the quality of life outcome. It's very interesting to study and learn from. And other than the quality of life, which is a primary outcome they're measuring, they're also measuring overall and disease-free survival, adverse events, and hospital admissions. Thank you for your time.
Thank you, Dr. Aarti, for this wonderful presentation and enlightening us about the frailty assessment tool in geriatric age groups. So we'll take the question at the end of the session. Next I'll call our next speaker, Dr. Bharat Bhosle, Medical Oncology from Mumbai. He'll be talking about applications of I-O in immunocompromised patients.
So this is a difficult time to talk on the challenging situations. First of all, I would like to thank the organizers, Dr. Ghanshyam, Dr. Jyoti, and Dr. Malhotra. And thanks for giving this topic, because I read a lot about immunology. So the topic is to talk about immunotherapy applications, practical applications in transplant, post-transplant setting, HIV positive patients, and steroid. And all these are the exclusion criteria of all standard pharma-driven trials. And I didn't come across any principal investigator trial which there is a level 1 evidence. So I will sell you through whatever I have read. These are case reports, small case series. And at the end, you are wiser enough to decide. Because immunotherapy is an integral part. Yeah. Now, immunotherapy is the integral part, and in the morning, Dr. James Allison enlightened us how the priming happens, and we knew about it. But I am a firm believer we should go into the depth of immunology And every patient, be it on steroid, autoimmune disorder, HIV positive, or post-transplant, they should know what treatment options are available for their colleagues who are healthy.
The screen is not showing.
This is also a challenging situation. You have to fix it. Yeah. So, okay. Thank you. So, as I mentioned, the immune check inhibitors have redefined therapeutic landscape of cancer management. There are hardly any trials to address these situations, and these are the conditions which are really challenging. So first of all, I would like to start with patients living with HIV, because after 90s, after the discovery of the virus, we had a really tough time addressing that issue, and then these patients are living beyond decade, 2 decades, and facing increased incidence of cancer. And they are definitely at increased risk of cancer as compared to the healthy counterparts. And there are clinical trials, level 1, level 2, phase 1, phase 2, but there is no phase 3 trial addressing. And conventional chemotherapy, yes, we are using it, but these patients do develop toxicities. They are on ARTs, which have no interactions, drug-drug interactions. So what are the important determinants for this? Thankfully, because of the ART, the viremia is controlled. The viral load is essentially important. We do interact with our internists who are treating these patients. CD4, these are the helper T cells, and CD4, CD8 ratio, and the drug-drug interaction is very, very important. So if you know the cancer biology or cancer immunology, here exactly same thing happens. So what is happening in what kind of immune dysfunction happens in RBD patients? There is an alteration in T cell immune response. It is called as the immune exhaustion. So I will not go into the immune editing, because the previous lecture she has mentioned about immune editing. So it's immune exhaustion happens in these patients, and similar kind of phenomena happens with the tumor. So there are several mechanisms which lead to T cell exhaustion. Cell-to-cell signals, including prolonged T cell receptor engagement, and there are co-stimulatory and co-inhibitory signals. There are receptors apart from CTLA4 and PD-L1 which are acting as positive or negative control. Soluble factors in the form of various cytokines, and the microenvironment. It is very important. So when I was a student, Banawali sir used to talk about microenvironment. That time and there is a good example at Classical Hodgkin's, and he has been instrumental in bringing the low dose and practically what we can do in our country. So this immune exhaustion is very important to understand how we can modify it. And if you see this retroviral disease infected cells also express large amount of increased expression of CTLA4, PD-L1, PD-1, along with there is TIM3, LAG3 and TIGIT. These are the co-stimulatory positive and negative regulatory receptor, co-receptors. So this immune exhaustion is because of there is a prolonged and high expression of CTLA4 and PD-L1, and that leads to T cell exhaustion. PD-L1 expression is high on these HIV infected cells, which correlates with the high viremia in the beginning. So where does this fail? The CD8-4 cells fail. So in the initial part of the viremia, the cells try and control the viremia, but because of the prolonged exposure or prolonged viremia, they do fail at some point of time. And there have been attempts to actually block this as a treatment part of HIV. So immunotherapy has been used at initial trials, phase 1 trials, to actually revert this exhaustion. And immune checkpoint inhibitors have been tried. I think BMS trial is going on. Early initiation of this combination of ART is very, very critical to control this viremia and increase the CD4, CD8 ratio, CD4 cells, and that can revert this immune cell exhaustion. So this is the trial I was talking about. There is a trial of anti-PD-L1 in HIV positive patients to reverse this exhaustion. So is there any data about safety activity of immune checkpoint inhibitors in retroviral disease positives? Yes, there is a retrospective data of 100-odd patients. It is called as CATCH IT Consortium. I will not go into details. There are 40 slides I have to finish. That's why I have numbered over here. And the purpose was here to compare these patients living with HIV, how they behave as compared to those patients who are living without HIV. So they looked at 390 patients, of which among these patients, these immune checkpoint inhibitors demonstrated differential activity across cancer types with no excess toxicity. And safety and activity of these agents were similar between match cohorts. So they tried to compare with the matched cohorts as well. So out of 400 odd patients, there were 111 lung cancer patients, total 378, that is apart from lung cancer, there are other cancer patients. And this is cohort A. And cohort B, they tried to take 61 lung cancer, this is metastatic lung cancer patients, and they looked at 110 healthy, not healthy, the diagnosed cases of stage 4 lung cancer who did not have HIV. So those people living without HIV. And this was, the cohort B was 1:2 matching was done. The median age was nearly 60, and from the diagnosis to cancer development, it was, median was 17 years, 17 years, not months, and majority of the patients were male, 85%, and the number 1 cancer, that is 30% of the cases were lung cancer. Now, they have used monotherapy as an immune checkpoint inhibitor, combinatorial PD-L1 with CTLA-4, but majority of the patients were on monotherapy. The regimen for ART was NRTI and integrase strand transferase inhibitors. 80% of the patients were on the first combination. Look at the CD4 count. Majority of the patients had good, that is more than 200 CD4 T cell count, and the ratio was more than 0.4 in majority of the patients. And the viral load was well controlled, that is below 400 copies in 94% of the patients. So they selected among the HIV positive patients, those who are patients who are behaving good in terms of the HIV exhaustion. As I mentioned, the viremia causes HIV, CD4 exhaustion or immunoexhaustion. So what are the clinical outcome among different cancers? If you see what patients did well, you can see the response rates is the Kaposi sarcoma, Hodgkin's lymphoma, which is beyond 50%, and melanoma. So skin cancers did well. Safety, these patients, no, there is always a fear of, apart from no efficacy, the next point is safety. Immune related, these are already, no, environment is immune exhausted, you are activating the immune systems, what happens to the safety? So immune related adverse event rate was more in those patients with a higher ratio of CD4 to CD8 and CD4 counts, but the discontinuation rate was more in those patients where the viremia was not well controlled, that is CD4 count was less than 200 and the ratio was also 0.4. And there are different kind of toxicities, and main toxicity is skin toxicity, and there are differential response rate, and the maximum responses were in Hodgkin's and cutaneous malignancies. The cohort B, if you remember, 1:2 match, they tried to do with people living without HIV, and there is no differentials in terms of the outcome. So even patients living with HIV have equally good outcomes as compared to patients living without HIV with cancers. So these are encouraging results where no, in clinic, we don't have to look at the level 1 evidence. We have to look at this retrospective data and discuss all the pros and cons of this treatment with patients rather than saying there is no level 1 evidence, because it is difficult to have in near future to have a level 1 evidence phase 3 trial. So next thing is a transplant. So now we have stem cell transplants and solid organ transplants. So I was supposed to, as per the organizers, I was supposed to talk on stem cell transplants, but now immunotherapy has been part of Hodgkin's lymphoma, relapse refractory, post-autologous maintenance, for allogenic transplant as a bridge therapy. So now immunotherapy has been used again for the graft versus leukemia lymphoma effect. So I'll include some of those slides, but main challenges in our practice are post-transplant like kidney transplant, liver transplant, and now we are seeing more and more heart transplant patients. So here, at the moment, there is no published level 1 evidence, and these patients are on immune suppression. So they are immune suppressed, so itself is a high risk for development of a cancer. Having to decide between the effective tumor control and at the same time avoiding the organ rejection is a critical step and a big challenge for a treating oncologist as well as the organ transplant physician involved here. And immune checkpoint inhibitors in this subgroup is a problematic because of 2 reasons. The immunosuppression is a challenge for the immunotherapy drugs to act, and immunotherapy may result into failure of immune suppression that may lead to organ rejection. Now coming to stem cell transplant and immune checkpoint inhibitor. So as I mentioned, they have been tried in relapse refractory classical Hodgkin's and other lymphomas. If the relapse happens post-autologous stem cell transplant, before going for allogenic transplant, and as a maintenance, or sometimes no breach. Activating allogenic donor-derived T cells, exerting a graft versus lymphoma effect, which we want actually. And this has been used in the literature where on the follow-up, you see the chimerism we are losing. Immunotherapy has been actually used here to get this effect, graft versus lymphoma effect. The other problem is graft versus host disease, acute and chronic, non-infectious febrile episodes, which require steroids. Again, using steroid is a problem, as we know, and other immune-related adverse events are increasingly seen in these patients. So this is the published data. Most common indication for checkpoint inhibitor usage here is Hodgkin's. 5 minutes? 1 minute, 2 minutes. Okay, so these are the acute GVHD and chronic GVHD percentages, and these patients do respond, and they are alive. This is again one more series where you have PFS at the end of 1 year, nearly 70%. OS is also 70% in couple of trials where it is used as pre and post transplant. So timing of the immune checkpoint inhibitors in allo setting is very, very important. These are the safety efficacy data of pembrolizumab. And here they have showed that it is not inferior. So you have to discuss with the patient. I'll just quickly move to the last part. So this is about solid transplant, kidney transplant patients, 100 odd patients. And you can see the rejection rates are also not bad. So practically, when you theoretically think of a rejection, you get a robust immune system, you should get more responses in those patients. In this trial, they showed those patients who had organ rejection had poor responses as compared to those patients where the organ were retained. And they have 30 to 56% of the responses across the different cancers and different kind of transplants and cancers as well. The kind of immunotherapy used, monotherapy or combinatorial therapy, and type of immunosuppression, again 40 to 50% of the responses. The organ retention rates with different kind of immunosuppressions were more than 70%. So it is possible to retain the organ at the same time to get the responses with immune checkpoint inhibitor. The only thing is you have to work in a team with the transplant physicians. Again, the cause of death here is not the rejection. It is the cancer in 40, maximum number of, out of 48, there are 40 deaths were because of the cancers. So you have to give this option to your patients. This is one of the case where, in a case of transplant on immunosuppression, combination of immunotherapy is used, and you see over a period of time, the tumor going into complete remission and the organ is retained at the end of 2 years. So the thing which I want to reiterate here, if a patient of transplant is with you, be it a stem cell or solid organ transplant, you discuss all the possible side effects. If the patient does not have, he or she, any other alternative option, it is best to go ahead and use it in combination, but keep a watch on the side effects and the biomarkers we don't have for predicting the organ rejections. Now the last part is steroids. We know that steroid is a big challenge, and for various reasons we use steroid. One is autoimmune. It's a complete contraindication, absolute contraindication to use immune checkpoint inhibitor. The patient has to be in remission of steroids. Still, the patient has chances of flare. The second thing, the patients are on steroid for supportive care, symptoms, or brain metastasis. So brain metastasis, we know you have a data where steroids are detrimental. Again, these are confounding factors. These are bad biology patients. They do anyways bad. So better you taper the steroid as early as possible. Meanwhile, use alternative chemotherapy. And if the patient is off steroid, you can offer immune checkpoint inhibitors. There are various trials showing use of steroids and immune checkpoint inhibitors. The outcome is bad when the patient's on steroids. So coming to the summary, immune checkpoint inhibitors, either monotherapy or combination, has expanded its use across cancers. There are challenging situations which I have discussed. Till the time we have solid evidence of poor efficacy, at the cost of major toxicities. These agents should be used, but with discussion with the patients, family, and keeping the other specialties who are involved to have a better outcome. There is urgent need to have a predictive biomarker. If I can predict this patient's organ is getting rejected or toxicity can be predicted, the things will become easier to choose the agent. And careful monitoring, as I mentioned, we have to be a good internist, better internist, not only oncologist. And this careful monitoring can save the patients landing up into grade 3-4 toxicities. That is very important. Thank you.
Thank you, Dr. Bharat. Thank you. And now moving from one challenge to another, the immunotherapy in rare tumors and hard to treat tumors. And for this, I would like to invite Dr. Bhavesh, who is a medical oncologist at Namakal. And over to Dr. Bhavesh.
Thank you, Chairpersons, and thank you, Dr. Ghanshyam, Dr. Jyoti, Dr. Hemant, for inviting. And I'm Dr. Bhavesh. I'll be talking about one more challenge which we see rarely, but yes, it is there. Everybody must have seen some or the other rare tumor in their practice, and you always puzzle how to treat them. So whether immunity comes to our help, whether it is an untapped opportunity or it's an impossible challenge. So we understand that cancer is one of the leading cause of mortality globally, and that is why we want to understand how the biology is, how the efficacy is going to be, how to investigate them. And this is possible for common cancers because we do have an opportunity to gather them at one center or multiple center, understand the biology of the disease, do some intervention, try to prove that yes, that intervention works well, and hence we have a good evidence and we can, scalable to the global level. But that's not the case with rare tumors and rare diseases. So by definition, the rare disease is something which will affect less than 5 people per 10,000. But if you come to rare cancer, it is much more specific, less than 6 in which is a European diagnosis, the definition, and less than 15 in US cases per 1 lakh individuals. So that is how the rare cancers are going to be. But the rare is not actually rare. There are a lot of rare cancers which are not in the common group, and that amounts to almost 200 to 230 cancers, which when clubbed together has a 5-year survival, which is not as good as the common cancers, but yes, it is good, decent enough if we treat them well. In one of the meta-analysis, what they saw in the Europe, that when we included all the rare cancers together, actually it forms a big chunk, almost 15 to 20% of all the cancers. So if we include all of them, it is not a small number. And we already know there are many modalities of treatment. The conventional modality in the form of surgery, which is the most important, followed by or replaced by radiation or chemotherapy or combination of both. And then we have certain other therapies, including immunotherapy. So immunotherapy itself is an important agent against the rare cancers, and it is potentially going to improve the outcomes in this kind of cancers. So a lot has been spoken about immunotherapy, so I'll not go into the detail. What I understand and make you understand in a simple word is, it's a treatment which uses the body's own immunity to fight against cancer. So how to modulate that, how to tame that, we have various agents, including monoclonal antibodies, ICIs, cancer vaccines are being developed. We have adoptive cell therapies, and there are many more which are in pipeline, which on the first day, yesterday, we have heard in details regarding CAR T cells, BiTEs, gamma delta, etc., and alone and also in combination. So the first and the foremost thing which comes to the problem or the challenge is to diagnose the rare cancer. So if you go from the top, that is a conventional diagnosis. So we do our conventional diagnosis and we understand, okay, this is not the common thing which we are looking for, and definitely it will require something else or something different. So we run the genomic sequencing, the RNA sequencing, and the amount of information what we gather from the genomic and the RNA sequencing, we put it into omic analysis. From this omic analysis, we try to understand what are the available anecdotal study, case studies, case series, and we understand the functional studies which are available globally. And integrating this functional study and omic analysis, the integrated analysis will give us the diagnosis and a probable opportunity of treating the patient of this rare cancer. But it has its own challenges, multiple challenges, and how does it impact and what can be done for that. So obviously it's rare, so the incidence is low. The number of clinical samples are going to be low, and hence many a times even if we start a trial on such patients, they are, because of the lack of participation, these trials are terminated early. So the solution for this is to have an intercontinental or a global clinical trial and integrate them so that we get a good number of patients for the trial. Second is lack of standardized protocol. Since it's a rare tumor, there is no homogeneity in the sample, and again here the collaboration comes to our help. So if we can collaborate amongst health professionals, researchers, and various organizations and set an international guideline, then this rare cancer can be treated more uniformly. So I think in next couple of months, ESMO is coming up with the rare cancer event. So probably we'll have some more guidelines coming out of that symposium. Delayed diagnosis due to rarity. Again, this is one of the problem. We keep looking for the diagnosis. We fail to get a particular diagnosis and we run test after the test. And in meanwhile, the patient who was probably curative has advanced, and then we have a limited therapeutic option for such patients. So the outcome for that is you have to use some novel diagnostic tools and probably integrate intelligently with the AI so that we get this rare diagnosis early. So we have to understand the pattern which is already available globally, make it feed to the learning AI system, and probably that will decrease the time period with which we can diagnose these rare tumors. Economic challenge in developing cancer drugs. Again, it is a very important thing because we do not have adequate number of ongoing trials for that. Even if the trials are there, the recruitment is very slow, and probably the outcomes that we are going to see will be in half a decade or a decade later. So here, US FDA actually gives an Orphan Drug Act, and if the patient, if the diagnosis is going to get a drug which is having a breakthrough effect, it has been designated as an orphan drug and it can be used. So these are the conventional modalities: surgery, radiation, chemotherapy, or combination of chemoradiotherapy. And there are certain other things which we have started using, like immunotherapy, targeted therapy, transplants, and last but not least, the combination of all the things what we know. Chemo with immuno with radiation, chemo, immuno, radiation together with cancer vaccines, etc., etc. And coming to more efficacy and more hard data, if you want to see, all these trials which I'm going to go for each and every subsite is going to be less than 100 patients in each of them. Merkel cell metastatic in second line, you see the ORRs are close to 30%, 32% with the use of avelumab. Coming to first line, with the use of pembrolizumab in advanced Merkel cell, your ORR is going to be 56%. So probably what it tells that if you can use it in first line, probably your ORR is going to be better. There will be a good chance that there will be a complete remission also. Coming to another skin cancer, squamous cell carcinoma, again a use of pembrolizumab has given a clinical benefit ratio of close to 40% in second line. And if it can be used in first line, and especially those patients who are harboring PD-L1, the ORR goes high up to 55%. If it is negative, it is 42%. One more study, the semiplimab, again one of the common immunotherapy what we use with advanced cutaneous squamous cell carcinoma. And there are two cohorts which tells that in this we get an overall response rate of close to 50%. Coming to another adenocortical carcinomas, use of pembrolizumab gives a CBR rate of 54%. Adenocortical carcinoma with the use of NEO and EP combination pushes this further, and we can cross maybe 66% of the CBR. Coming to paraganglionoma, pheochromocytoma, again a rare condition where pembrolizumab has shown a CBR rates of close to 75%. So this is something encouraging, probably will be substantiated in future trials. Mixed bag of metastatic sarcoma. We know that sarcoma is not one disease, there are multiple diseases in sarcomas, and I think probably the best one is the alveolar soft part carcinomas, which has a maximum overall response rate close to 50%. But if it is a mixed bag, the combination of NIVI-EP gives close to 16% only. Coming to the CUPs, again, if we have exhausted all other options of surgery, radiation, chemotherapy, targeted therapy, then immunotherapy comes to our help, and with the use of pembro, they have a CBR rates of 54%. And there are many more tumors: medullary renal cell carcinoma, vascular sarcomas, penile carcinomas, GCTs, where pembro is being used, and probably we'll have answers in a couple of years or maybe half a decade. So there was a plethora of data, and this is one of the picture from the meta-analysis done in 2-3 years back. And what they have come out with the Spearman coefficient correlation, and they understand when they plot this on this OS versus the ORR chart, if it is 0.69, that means 70% of the time the therapy is going to translate into the benefit and into lead to the overall survival. Squamous cell carcinoma, Merkel cell tumors, sarcomas, these are the ones which are going to do very good according to this correlation studies. What we have in future, so we do have all these rare tumors which are going to be treated with the combination of immuno plus radiation, immuno plus targeted therapy, immuno plus chemotherapy, immuno plus cancer vaccines, and we have CAR T cells. At the beginning of the conference, we had a big lecture on CAR T cells, the BiTEs, the gamma delta, etc. So I will not go into the detail of this. These are again all the different strategies to use CAR T cells in different rare tumors and get the outcome out of it. And obviously the vaccines, which can be either nucleic acid based or dendritic cell based or peptide based. So we do have vaccines which are going to be integrated into the main armamentarium, maybe combined with immunotherapy, and get the best outcome out of it. So my conclusion can be conclusion also and can be question also, that do rare cancers have a similar outcome as common cancers? So whatever data or whatever understanding we have till now, it says that yes, the mechanisms are same, and probably the pattern of resistance also is going to be the same. What about the biomarker? So do we still do some kind of biomarker in this rare tumor before giving immunotherapy? So we try to do PDL1, MSI, TMB, and sometimes we see that whether combination is available, and probably if there is a good combination or a good algorithm of biomarker which is available, then we'll be more confident in treating these rare tumors. What is in future? So as I already mentioned, probably combination of immunotherapy. We have seen that many of these rare tumors, when we use Nivo alone, the response rate are close to 20-30%. But if we use Nivo-EP, it jumps by around 10-15% more. Then there will be a combination of immunotherapy with targeted therapies or radiotherapies, as we know the abscopal effect, or with chemotherapy also. And definitely there are many newer therapies which are coming for our armamentarium, including CAR-Ts, BiTEs, vaccines, and various adaptive cell therapies. So I'll stop here, and that's my team from Tangam. So warm greetings from my place, and thank you so much for the presentation.
Thank you. Any one or two quick questions? So if there are no questions, then we can conclude.
Thank you, sir.
Thank you. Thank you.
Thank you, Chairperson and Speaker. I would like to request all the speakers to just come up front to take a picture, sir. No. So for our next session, I would like to call upon the stage the chairperson, Dr. Jyoti Bajpayee ma'am, medical oncologist from Mumbai, and Dr. Shekhar Patil sir, medical oncologist from Bengaluru.
So good evening, everyone, and thank you very much for staying with us a bit late, though. I hope you enjoyed the sessions. So with this, I will hand over to my co-chair, Dr. Shekhar Patil, to introduce the topic.
So the next topic will be on the biliary tract cancers, real-world data in advanced and raising the bar in HCC. So speaker will be Dr. Ghanshyam Biswas, the organizer of this conference. He is a medical oncologist practicing at Bhubaneswar. It is over to you, sir.
So good evening. Thank you, Shekhar sir and Dr. Jyoti. So in next 10 minutes, I do justice or injustice, but TP Sahu will follow the justice from here. So going to BTC, so we are in a state where BTCs are common, but we see most of them are gallbladder cancers. So nothing was happening much before Topaz 1. So the standard of treatment was Gemcis. And so after Topaz 1, so Gemcis plus PD-L1, that is durvalumab, combination became a new standard. Unfortunately, India was a part, and 4 of our colleagues from India were a part of this team. So there are around 700 patients. So Gemcis in the standard dose up to 8 cycles in the standard arm, and the experimental arm had durvalumab followed by maintenance. The primary objective was overall survival followed by many other secondary endpoints. So coming to the primary endpoint, which was a 3 years OS, and you can see there's a starking difference. We have raised the bar in a BTC. So at 36 months, even you can see 14.6 versus 6.9 with the hazards of 0.7. So if you see this, so all the subgroup benefited with Gemcis and durvalumab. So now moving from randomized control trial to real world data. So these are few of the real world data. So let's see one of the Indian data from a Vamsi group, and there are other 12 centers. So this is one of the real world data which had a good number of patients, around 700 patients again, 20% of them were GBCs, and for 39 centers. So you can see the BTC location. So here extrahepatic did the best, followed by gallbladder, and intrahepatic probably was the worst. If you look at the median overall survival of 15 months and a median PFS of 8.2 months. If you look at the response rate, which includes a CR and the PR, which was around 30%, with 2.6% having a CR. If you look at the overall survival, so you can see, so the hazards of 0.59 and a PFS of 0.57. So this was from our country, which had 12 centers led by Vamsi and the TMH group, which has again more than initial was 70 odd patients, then they included more than 100 patients. And you can see, so of course we have a good amount of patients who are GBC, then there was a different with the Topaz, and so significantly higher proportion of GB as compared, and this had, since it is a real world, so we had good number of patients who were symptomatic, who are beyond PS1 also. The median OS in this real world was 12 months, and the median PFS was 8.2. So the survival benefit is consistent with the randomized control of Topaz 1, despite the heterogeneity in the trial population. So now we have been with immunotherapy quite a while, and we have used this drug in many indications, and we know that it's not very difficult to handle when you are either using the drug alone or in combinatorial with cytotoxics. So these are other real-world data which I show. So OS hovering around 15 months and PFS hovering around 8 months. So to conclude from the real world, so appears to be a mirror survival of the pivotal Topaz 1, which was a randomized phase 3 trial, and there appears to be no safety, new safety signals, is tolerable, and the Indian data also confirms that so GB patients are also doing good. So now raising the bar in unresectable SCC. So in our part of this country, so we don't see much of SCC as we see GBC. So Himalayan, so fortunately I was a part of this Himalayan trial, and we have recruited four patients from Sparsh. Then we'll discuss on the LEAP 012 and the Checkmate 9WD. So the Himalayan trial had 4 arms. So subsequently, the only durvalumab part was withdrawal. So these had a new CTLA-4, that is temolumab, but only a single dose. So you need to have, and now that is approved in DCGI by Indian DCGI also. So you give 1 dose of temolumab, and then you follow it up with durvalumab. So the updated exploratory analysis of the Himalayan study evaluated the 5 years OS of participant with unresectable SCC receiving the STRIDE, so that is known as STRIDE regimen, and assessed survival by multiple tumor responses, including the depth of response. So prior to this, we are talking about depth of response with anti-EGFR, like in colorectal cancers. So the 5-year updated OS with the STRIDE, you can see, so the graph has been absolutely separating. So this was never thought of or never seen at 6 months, so 20% versus 10%. And if you see the OS survival analysis, so the patients have been doing really good across all aspects. So the STRIDE demonstrated a sustained OS benefit versus sorafenib with an OS of 20% versus 10% at 5 years, and the OS ratios of STRIDE versus sorafenib increasing over time. So if you come by OS by disease control and OS by depth of response, so OS benefit with STRIDE was enhanced in participants experiencing disease control as per the RECIST 1.1 with OS rate of around 30% for STRIDE and around 13% for sorafenib at 5 years. STRIDE arm has a deeper response, that you mean that more than 50% of tumor shrinkage, and deeper responses were associated with an overall improved survival. Then comes the LEAP 012, that is TACE with or without lenvatinib plus pembrolizumab for intermediate stage hepatocellular cancers. And so here the primary endpoint was a co-primary endpoint of PFS and OS. So we can see there was a statistically significant difference in PFS between the 2 study groups, with a median PFS of 14.6 months in the lenvatinib plus pembro plus TACE, whereas it was 10 months in the standard arm. So coming to the efficacy results, so OS data was immature, but there was probably a trend towards benefit with the lenva, pembro and TACE versus the standard arm, and a numerical benefit in OS rates at 12 and 24 months. Mostly the OS survival curves for the lenvatinib, pembro and TACE versus the standard arm meet at 35 months and crossover at 39 months, suggesting this OS benefit may not be sustained. So efficacy results, overall response rate assessing up to 5 regions in the liver was higher in the experimental arm. Median duration of response was 2 months longer in the experimental arm, and disease control rate was around 90% versus 81% respectively. So ORR remained higher in the experimental arm, and ORR were higher in the both arms when assessed by the modified RECIST as compared to RECIST 1.1. Then coming to Checkmate 9DW, so where Nivo plus the high dose of EP for 4 cycles, then Nivo maintenance versus either lenvatinib or a sorafenib. So the primary endpoint was here OS, and if you see the OS at 24 months, better 36 months, and even if you see there is a widening of the survival curves. So statistically significant and clinically meaningful OS benefit with IO versus standard lenvatinib or sorafenib TKI. So longer median OS and long-term survival benefit was higher OS rates at 24 and 36 months. So if you see this, so at the progression-free survival at 18 months and 24 months, so again, so there is a wide separation of curve with a median PFS of 9.1 in the experimental arm. So now treatment-related adverse events, so there were no new safety signals. And to conclude, so advanced SCC, unresectable SCC, Himalayan 5 years OS. So since I was a part of this Himalayan, so now, once there was a virtual meeting, so we saw that one patient has completed seven years and continues to be in a CR. So first global trial evaluating immunotherapy in first-line unresectable SCC with longer median duration of follow-up and around 60 months plus versus 59 months, reporting a 5 years OS rate of 20 versus 10 in the STRAD. And remember here that tremelimumab is only a single dose. In the intermediate SCC, our LEAP-012 updated results. So pembro plus lenvatinib combination with TACE intervention in intrahepatic SCC had made of its one primary endpoint with a median PFS of 15 months versus 10 in the placebo, whereas OS data is still to be immature. Thank you so much.
Thank you, Dr. Ghanshyam. So it was a nice talk, and any questions? Will you take in the panel discussion? Yeah. So it is over to you, Dr. Sahu, for the panel discussion.
Good evening. So I can call upon the panelist, Dr. Mubina, a medical oncologist from Mumbai, Dr. Tamojit, Medonk from Jamshedpur, Samir, again from Nagpur, Dr. Saroj Das Majumdar, Senior Radiation Oncologist, AIMS, Bhubaneswar, Dr. Alurkar, again a dear friend, Medonk from Ahmedabad. So this is a sponsored session, but I think we would be speaking science, and if we have anything which we can add on, please, the house is also open for discussion. So let's move on until the panel settles down. Why is this a different slide set? This slide galat hai. This is the wrong one. Twenty number ko dalo. Yeah. So, yeah, it's on. Please make it full screen. Okay. So, can we start? Okay. So this is the case, a 58 years old male with a history of chronic hepatitis B infection. Image reveals a large lesion in segment 7. It's a 6 into 5 centimeters, some satellite nodules in 5 and 6 with a portal vein invasion. And there is a metastatic deposits even in the right lung. And the lab investigation showed a bilirubin of 2, AST, ALT mildly raised, ALK phos of 280, and the AFP is grossly up at 1200 nanograms, and it is a child PUX A and BCLC stage C and ECOG performance status 1. I hope I'm pretty clear on this part of it. Okay. So just a quick thing, in such a case, does the house believe that they would go for a biopsy, or if there's a classical radiological picture on the MR or a CT scan with the early light up and the washout, we understand that the hepatitis B infection is there, with that alpha fetoprotein of 1200, Anyone wants to go for a biopsy? Please.
Yes, so I am usually for biopsy in any hepatocellular. The reason is because I, sorry, so want the tissue, and I also want to know whether there is a mixed, histology as far as the cholangiocarcinoma is concerned.
So you do biopsy in any liver suspected HCC, irrespective of the stage, irrespective of anything, you would be comfortable with the biopsy. If that's what I'm getting from you.
That's right. Yeah.
So Tamujit, any different from him?
No, this patient fulfills the non-invasive diagnostic criteria, but in practically I would like to go for biopsy.
Why?
Because negative point for biopsy is the risk of tumor seeding, needle tract seeding and bleeding. These are negligible.
What extra thing would you get?
There is not always possible radiologically differentiated intrahepatic cholangiocarcinoma or mixed intrahepatic cholangiocarcinoma HCCs, which can.
So would you want to add any further investigation, which is much simpler for you to even think of a biopsy?
Maybe serum CA19-9.
Maybe. So you are not sure. Do you do a practice of such a case? You do a CEA and a 19.9 routinely in your practice?
Yes.
And if that is high, that gives a trigger for you to go for a biopsy?
Yes.
So that could be one of the reasons. Anyone wants to add and something else?
I wouldn't biopsy this patient.
You would biopsy?
No, I wouldn't.
You would not?
Yeah, I would like to get a CA 19.9.
Okay.
If the CA 19.9 is elevated.
Only if the tumor markers are raised, you will go for it?
Yes.
Okay. Saroj bhai?
No biopsy. Biopsy is not mandatory.
Samir?
No biopsy.
Okay. So I'll tell what it is all about. The panelists put up some points, but what the literature says and how we normally can practice in a much more safer way for us and the patient is, yes, it is a classical picture. You would not. But if you look at the literature, if you are inviting a systemic therapy is your go-to therapy, which is most likely in this case, NCCN even recommends that it is probably better to do a biopsy. And if you are having a limited liver disease and it is something which you're looking at loco-regional therapies, most of these we do not advocate biopsies. So point 2, we have to start looking at patients who have a limited liver disease and loco-regional therapies are going to be advocated. Such pictures, high risk like hepatitis B or C or high alpha-fetoprotein, chronic liver disease is there. You have a classical radiological picture. CA 19.9 CA not raised, alpha-fetoprotein high, you are very within the rights not to, but in a metastatic, most of the cases are done. And to favor why we should do a biopsy, there's actually a case series from UK, where they looked at a retrospective analysis of around 450 to 500 patients, and to your surprise, they found 7% of patients had a different diagnosis than HCC. So if you're inviting and you want the patient is eligible for a systemic therapy, I think it's advisable for us to have a biopsy. You are right in most of the cases, but in 5% you might have a change in diagnosis. And actually the panel told the CA 19.9 and CA, if it is high, it does invite you for a biopsy, and then you can run and you would be not missing out the cholangiocarcinomas, which are sometimes mixed with HCC, or you have intrahepatic cholangio. I think this covers the whole thing. Anyone on the panel wants to add something else? Okay, we'll move on. So in this case, we had a biopsy. The alpha 19.9 and CA was normal. The alpha was very high, HbSAg positive. And this patient, I think most of us agree, would go for a systemic therapy. Okay. So which is the regimen you go to? I'll start from Samir this side.
So sir, single agent, sorafenib and lenvatinib, I think the patient is affording are out.
Patient is affording. He can afford anything.
Yeah. So for me, atezo-bev and durva plus tremelimumab, both are the equally good options.
So for you, you're telling me that although patient is eligible for more than one regimens here, atezo-bev, I am brave versus Himalaya. That is where you will go to. And among those two, which, if you have to choose one, please pick up. I'll ask you later why.
Atezo-bev.
So you will go for atezo-bev. Okay?
Our pattern of practice is lenvatinib, common practice.
So for affordable patient.
No,
Saroj bhai.
Yes.
So let's say you have the best of your patients, you have a health secretary of some state, not this state, some state coming to you, and he himself or she himself is a patient. Would you still give a sorafenib lenvatinib single agent? And if yes, what are those patients, in spite of having deep pocket, you will still give sorafenib lenvatinib?
No, I told about pattern of practice, what we do. Because most of the patients, they are suitable for that. Okay. Otherwise, if you go to like literature and all, I think all the options are good. I will personally prefer atezolizumab and bevacizumab, which has superior, I think, we have evidence in favor of that.
So 2-0 in
Yes.
favor of I am brave. I hope people are listening down there. Their field work has to be done more. Okay. Now can we move on and we'll come to why and dissect each one. Mubina.
I would go for atezo-bev because this patient has SGOT, SGPT, which is elevated.
Just it is 2.5
4
times.
times the upper limit of
It
normal?
is to 3 to 3.5. Yeah, come on. Yeah, please.
And my only concern would be immune checkpoint inhibitor related hepatitis.
So anyway, atezo-bev also has immune checkpoint
Yeah, but
itself.
it
So
was
you are not
higher.
giving an immune-free regimen.
Yeah, but it was higher in the dual immune checkpoint inhibitor.
Okay, so you are concerned because of the so-called perception that it has a borderline elevated, although the child PUX was A. A.
Yes.
So still you would be very concerned.
Yes.
And you are concerned because a dual IO has more liver possible toxicity than atezo.
Yes.
That's what I get from you.
Yes.
Okay, we'll come down to that. Tamuje.
So both option 3 and option 4 are okay for me.
I know, but you have to choose one.
Yeah, this is a high volume patient with probably VP3 or VP4 because of portal vein invasion. So I would prefer to go for atezo-bev in this scenario.
So you would prefer to go for atezo-bev, and because of there was
high disease burden, both extrahepatic spread and major macrovascular invasion, and probably it's a VP3 or VP4 patient because right arm of the portal vein is
Yes.
invated. So these sort of patients are excluded from Ruva-Tremeli or EP-Nivo trials. These sort of patients.
And 40% of the I am
Yeah.
brave had this patient.
Actually,
So
the-
that's what you are telling.
Yeah.
That's the inclusion. I'll come to that also in a minute.
So I think we are spoiled for choices now gradually.
Yeah,
So
agreed.
if the patient fulfills the safety criteria for using a VEGF inhibitor, bevacizumab, then I would go for atezo-bev because I'm more used to it.
Okay.
I have used them, so I feel safe. I have never used number 4 because we don't get TREMI. Combination of...
It's very much there. We have the thing in now.
maybe,
we
yeah.
have access to that.
So I think atezo-bev
So,
would be my provided
okay,
safe.
okay. We'll have the chair opinion from chair, and then I'll
So
ask.
why you don't want to discuss about any regional therapies in this case because it is a liver limited disease?
It is not, sir. We have a metastatic deposit in the lung also.
Lung also is
Yeah,
okay.
we have metastatic. Yeah. So we have a liver metastatic. So we don't want to go into, because the time was for systemic, so I want to go directly to that. So the impression I'm getting, okay, just a question which I wanted to ask you. Which patient, irrespective of the finances, would you go for and not offer any immune checkpoint? Although they are eligible, but which are the patient load which you still would like to go for a single agent TKI? Let's answer that.
Post-transplant.
Post-transplant. Okay. So basically, the point is if someone has a deep pocket and if you have to see and then wants the best of treatment or has insurance covering it, there are very few patients today who would be eligible for single agent TKI. There would be those who have contraindications to immune checkpoint, and transplant is one of them. Bharat spoke about HIV. If it's a very uncontrolled, high viral load with a very low CD4 count, you would be still very skeptical of using an immune checkpoint. Although if it is well controlled, the CD4 count is okay, then you can go for immune checkpoint. He showed us, but you don't have level 1 because the trials exclude such patients actually. So this is point 1. Yes, sir.
NASH also you can consider.
I'll come to that. Is NASH concept true or false? Also, I'll answer that. So second point.
Hep B is one of the points which favors atezo-bev here. Though viral means the benefit is in both for Durva and Trem.
I'll tell you actually, because you have opened this can of box, I didn't have the slide. Actually, I did a presentation few months back on this. If you are talking of Hep B, Hep C, and there is a meta-analysis and you can find it on the net, it's free of cost. And if you do it, there are viral and non-viral literature. I'll come to viral, non-viral, but Hep B and Hep C, I'm touching on that because you opened it up. Does anyone in the panel has an opinion on that before I just tell what it is?
TKIs were favoring like sorafenib in HCV and lenvatinib in hepatitis B positive.
And what is your evidence to back it up?
I think it was a meta-analysis or retrospective study.
So I'll touch the meta-analysis. I think,
yeah, please. Actually, sir, all this means perception about this, that in NASH-related HCC is actually immunotherapy.
No, I'll come to that. First, I want to answer the hepatitis B and C theory. Then I'll go to the viral, non-viral.
Actually, immunotherapy works similar, but TKI works less in
Okay,
Hep B.
we'll come to that. So basically, there is a meta-analysis. You have your own issue. You can take it up with its limitations, but it tells you that hepatitis B actually both these regimens work. Point one. If hepatitis C you are looking at specifically, and if you look at the forest plot and hazards for that matter, I don't have it in this presentation, in the other presentation, actually Himalaya did not do well. So it is something which is counter. If you look at B, both of them are doing well. If you look at C specific, and with its limitation of it, it should not be a take-home conclusion. That's point. Because you opened this, I'm just answering that the best evidence is there is little bit lesser benefit in the Hep C, which you can see it in the forest plot also actually. So coming down to first thing, where do I use a single agent TKI? That is clear. The Hep C, Hep B will take it apart because you told that I'd put it up. But the point is, which Shirt told, NASH or a non-viral etiology versus viral. So do you believe in the concept of treating patients differentially if they have a viral etiology versus a non-viral etiology?
So all these data which are available as of now, which is supposedly says that the immuno-oncology drugs work less in NASH-related HCCs, these are basically post-hoc analysis of an exploratory subgroups.
Okay.
So these are not statistically powered enough for any robust
Okay.
conclusion. That is
So-
number one.
so would
Next,
you
if you
treat them?
focus on the forest plot, you can see that
Would you treat them differently?
No.
So
Answer is
you
no.
will give them any one of the regimens, irrespective of it is.
Absolutely.
And what Samir is speaking about, he spoke twice about it, he wanted to speak, is the I am brave, the forest plot, which we'll see in a minute, did show that, actually, this is not again, this is blacked out again, please. Yeah. It did show that someone has to look into this. It did show that the non-viral actually did not do well on the forest plot and the viral did well. So that is where all the people are saying. So you are telling that no.
Yes, sir.
You would treat them?
Two reasons. For this no answer, there are two reasons.
Exploratory
Number one,
analysis.
exploratory analysis. Number two, if you focus on the duration of response, what you can see is in the NASH-related HCCs, it's not the duration of response for immuno-oncology drugs is less. It is actually the comparator arm who behaves better so that the hazard ratio is not significant.
So the point they're telling is why not give something which is cheaper and probably doing as good. So that's what this meant. Yeah. Okay, so I take your point. So you would not differentiate viral, non-viral. Dr. Alukar, you would not differentiate. So 2-0. To that, anything can be given, irrespective of it, irrespective I am brave, 150 regimen. Please. Saroj bhai? No difference. Samir, you told you will differentiate.
No difference as of now, but I would be tempted to use Durva-Tremi.
You would be tempted to use. What is your take?
One more question I have. That's infiltration to the vessels. It will dictate about bevacizumab?
No, I don't think there is a contraindication to that. Infiltrating vessel is not a contraindication. Actually, I am brave. Had 40% patients had a major vessel infiltration.
Yeah, they had a
So
major...
you have to look at the esophageal varices and should have done an endoscopy within last 6 months.
Yes.
And should have been controlled. It is not that the varices is there, you cannot give it. You should have a controlled varices or banded it. Yeah, please.
I think...
I know your answer. You told you would differentiate.
Yes, I would, in a fatty liver disease associated cirrhosis.
So, sir, your question, it comes through, there was the best level of evidence, there's a propensity score matched analysis which came up in annals. And this showed that if you have a NASH, or if you have viral, non-viral etiology, or a viral, if you have a non-viral, actually TKIs do better. But this is not the best form of evidence. And to be fair to Tamojit, which he said first, that the I am brave was not powered to look at this viral versus non-viral because of the first data set. In the next trials which have been done, the Himalaya and the Nivo EP1, they were powered for that, to look at the viral versus non-viral. And both the trials showed that immune checkpoint giving or non-giving in the viral and versus non-viral does not matter. So as of statistics and evidence, in today, you are okay to give and not differentiate as per viral and non-viral. The concept which we have been learning for last many years, the viral and non-viral was not based on a good level 1 evidence. Last thing, Himalaya, if you look at the data set from the single agent Durva also, there is an arm of single agent Durva versus sorafenib, which we have the forest plot, you would find there is again no difference between a viral and non-viral. So actually this was an incidental finding which you could take, and I think that is where this science would be. For the point of Atezo-Bev versus Tremi-Durva, I totally agree that the, again there's exploratory analysis of invasion, the VP4 and 3. If it's VP4, actually the IMBRAVE subgroup analysis told it did not help, but it was exploratory again. So take with a pinch of salt. So I feel the panel is now more towards a regimen which we have used for longer time. But the evidence is shifting, and actually the evidence is more looking robust. And to be fair to both the regimens, there is a much longer follow-up for Himalaya. While the IMBRAVE does not have a longer follow-up as of now, and the follow-up last which I am aware of is 18 to 24 months, a median, and this is a 60 months, and that is a lot of difference, and I feel the graphs are now well settled. So this is the 4 regimens which you spoke of, and if you look at it, the hazards is nearly the same as it looks like. The regimens look good. The CARE is one more regimen which is a positive trial, and that is where it is. But this is the things which I wanted to discuss. The IMBRAVE we spoke about, the stratification is very much there, but if you look at it, all of us know the things what is there, but the short follow-up is relatively much shorter, and this is what actually I was speaking about. It's exploratory analysis, but if you look at it, yes, I get what you're telling, but if you look at this point of the p-value is insignificant, but the numbers are so less, it was not powered to answer this. So I think we should not take it as a conclusion. The checkpoint, the only point I have, do you have anything to say on checkpoint, my panel?
So this study excluded main portal vein invasion, VP4.
Okay.
So
anything on the curves you want to say? The curves which I showed you? This one.
I don't know, I think the control arm is rather weak. Here you have a double IO agent versus a single agent TKI, so that may be one of the factors also. Okay,
the only point which I have is again a positive, it's a very encouraging data set, is the pattern of the Kaplan-Meier which I'm looking at. And if you look at it, there's a crisscrossing which has happened at around 1 year for a 3 years curve, means 1/3 of the area of the Kaplan-Meier, the immuno arm is done bad. So, and that is also reflected in the PFS curves. So, in such a curve, for me, learning statistics, I would be more comfortable with the RMST also given. I look out for the full publication, and I look out for that. But this curve has 1/3 of the time where the patients on the immune checkpoint plus immune checkpoint have done worse than the standard control arm. So this is my one look at it, but otherwise it has the highest numerical OS in numbers. That's also something we have to remember. So this is again something which I felt on the curves. It is very classical standard of crisscrossing, and that you see in both the things of PFS and OS. And it is happening till 1 year of point. The Himalaya, the PFS we leave apart. In immune checkpoints we don't see. In contrast, look at the curves. They do separate, and the separation happens in 3 months or so, and that's what you see. And the separation is happening, and even in a prolonged follow-up, it is still there. So this is a point which I wanted to discuss, and this is the 5 years updated, and still you see the graphs separating, and the delta only getting better. The difference is getting better. Okay, so we spoke about lot of things. Just one pointer on the ALB. So what do you use, a child books, or do you think the ALB should be the way to go forward? Anyone has shifted from the child books to the ALB?
So still we are using CTP.
Okay.
But ALB, it is a fully objective score. There is no need for assessment of ascites or encephalopathy. So that is the advantage. Easy to use in clinics, but probably as of now we are using CTP.
So I think the point that is going home is the world is shifting towards ALB, because it is more of a two thing which you need, and which is a part of the child book. The other thing, the assessment part, that is taking it out, which, and in multiple publications they have shown to be inferior also to ALB. So I think this is where it is the meld, the child books and the ALP, this is where it is moving. And if you look at it, if you look at across the grade 1, grade 2, grade 3, the Himalaya looks better versus the control arm. So that's point number 2. So I'm just going to this question. Thoughts on monotherapy of durvalumab? Anyone? Finances little restricted, I'll still go for durvalumab versus the STRIDE regimen. Any thoughts on the panel? Would anyone go for a single agent durva?
Yeah, there is a contraindication to use BEV. I would like to offer.
No. I'm talking of Tremi Tremi, Durva versus Durva alone.
Yeah, that's what. I wouldn't be able to give single agent AT. So I would, yeah, when...
Durva is the IO, AT
yes,
is the
that's
IO.
where...
So I'm talking of a Durva alone versus Durva plus Tremi. Would any one of you go for and think of giving Durva alone?
Yes, sir.
Why?
So it has got a 48 months OS rates of 19.3%.
The stride is better.
Yeah, when you said the finances are not in favor, then I think
only one dose of Tremi. It's not that you have to give every time.
I don't think stride is a better.
Okay, that is better. I just want to point out one quick thing. Just look at this and look at the OS curves. Till 24 months, dot on, the both are same. Post 24 months, the separation happens. And then you find the stride doing better than Durva alone. So the plateauing of the curve happens, and it happens at a much higher level for the combination versus a single agent. So if one has to choose, I think it has to be a combination rather than a single agent. Just for this reason, although the initial 2 years, it just looks similar, and this is telling you, just look at the 24 months, it is 40% versus 39.6. And then after that, look at the upper curve, 36 months, it is falling from 30 to 24 in the single agent Durva, and 25 to 19. So that sustenance of the plateau is not happening, so I think a single dose of Tremi does help. This is the etiology, sir, which we did, and sir, to answer your question, this is what it was, that except for the I am brave, every one of the trials which were powered to look into this did find that it does not matter. So take home, for evaluation, alpha-fetoprotein viral markers, CA 19.9 and CA, other risk factor HCC should be part of it. We should not just stop at alpha-fetoprotein. Biopsy in a select few, especially in the localized, you don't need to. But if you have a systemic therapy, I think all of us should do a biopsy. Treatment IO versus IO-BEV versus TKI, my small take is the evidence is now growing with a longer follow-up, and the curves that are still matured, curves are looking very good for Himalaya. I was one who was a very strong opponent in opposition to Himalaya. But the 5 years data set does tell me it looks good. And I am more confident and comfortable. Yes, if cost is an issue, you are not wrong in doing IO-BEV. That's sure. Because cost does fall down with IO-BEV. TKI for a select few. Viral versus non-viral, we have spoken. Quickly, anyone wants to add something? No, we'll move on. We have last 7 minutes.
One more point, sir. One more marker we are not doing routinely, PEVCA. So that also helps. Sometimes if the AFP is on lower side and you are not confident enough whether we should label it on SCC or not, PEVCA can help us to diagnose that. So many gastroenterologists now...
is there a randomized way of, is there high level evidence of diagnosing it? So what I mean to say, Samir, we may believe our colleagues, but I would like to have a literature supporting that and a recommendation of a diagnosis. So, okay. So we'll case 2 quickly, 5 minutes. It's a intrahepatic cholangiocarcinoma, very quickly, and not amenable to surgery. It is a metastatic disease. So any one of you do a NGS at the baseline for a gallbladder / biliary tract cancer? All of you do that? Sir.
Prevalent for cholangiocarcinoma, especially intrahepatic, I would do a full genomic profile.
So would you do anything in the front line with that report?
I don't get you. Like, as far as the NGS is concerned.
So after NGS, you found a IDH1 mutation. Would you act on it in the front line?
Not for that, no.
So you won't act on it. So but you would like to do it because they have a nearly 40 to 50% patients have some target.
As per recommendation, you do the complete profile.
So then, okay, that's fine. Anyone? Same thing for all of you? Okay. So if you have HER2 new, it's a gallbladder. I'll shift the case. It's a gallbladder. It's a HER2 new positive. What is your go-to regimen? Number one, is it as Topaz? We'll go for a immunotherapy plus chemo. Or is it that I will add a HER2 target therapy to the Topaz regimen, just like the gastric cancer 911, that addition does help? Or is it that I will just do a targeted trastuzumab plus chemotherapy as Tata Memorial does it? Or is it chemotherapy alone? Quickly. Samir.
So textbook wise,
now what would you do?
Topaz followed by HER2 target therapy followed by maybe TDXT.
So you do it as a maintenance only, without progression? No. On progression. So you are going to do Topaz, even in your practice, not add HER2 frontline. Okay.
In practice,
I will speak with Anand after this. Frontline, and you will you do IO and anti-HER2 and immunotherapy frontline? So anti-HER2 chemo, you will do topaz and then follow it up. All are right actually. Jaldi.
I think chemotherapy with the dual anti-HER2 per2 trastuzumab.
So no IO?
I think.
IO plus GemCs in first line.
So topaz again?
Yeah.
Sir?
Yeah, I would like to go for chemo backbone with either single agent TRAS2 or TRAS2 per 2. No IO.
Well, dual HER2 again.
Dual HER2 or a single HER2.
So actually there is no level 1 evidence for this. Actually the alone evidence is with topaz alone. The IO plus chemotherapy. Although the percent of patients, the HER2 were very small. And they did not benefit much in that forest plot, but they were not powered for that. But the data is evidence is there. You are going to use a target therapy, and trastuzumab is probably the way to go forward. I spoke with a lot of my colleagues and good seniors who are very academics, and all of them felt that although the data set is not there, they would like to add the IO plus trastuzumab plus chemotherapy in the front line alone. So I asked them, don't ask me why, but this is how I will do it. And the go-to thing for all of them was stomach, the 911. That the responses were high, the PFS was good, and I will like to do irrespective of the PD-L1. So that is what it is. Okay, now we come down to this patient who was not a HER2, there was no mutation. Okay, so what is your go-to regimen? All are with IO. Number 2, do you differentiate between a gallbladder versus non-gallbladder when you are looking at biliary tract cancer when you want to choose IO? Is the question clear? Sir, gallbladder versus non-gallbladder biliary tract, the use of IO, would you differentiate?
So cholangiocarcinoma IO, gallbladder maybe no IO. Predominantly if it's...
So you are not pushing gallbladder immunotherapy?
IO for gallbladder no.
You are not pushing?
So I would like to use IO, but global trials, exploratory analysis suggested that gallbladder patients will not have a significant OS benefit.
Same answer for you. Yeah. Anyone who is a different answer?
I think Dr. Biswas presented real world data from India, and there was significant gallbladder cancer patients in the real world.
This is what happens when you, Dr. Biswas did not emphasize on that slide actually. In his slide, and Vamsi is a very dear friend of mine. I speak every day nearly with him. So they had also the same conclusion, gallbladder did not benefit much.
Okay.
They had that every patient, it was not a gallbladder alone, it was not a gallbladder, it's everyone. And they had the same as topaz, but the gallbladder did poor. So what they're saying, actually their trial mirage, it was a mirror image of the topaz one. So, Samir?
I would not differentiate as such.
You will give to everyone. Okay. So that point is you can give. The second point is what both my colleagues felt. I also strongly believe that 25% of both the Pembro and the Durva had gallbladder, and both the forest plot was not in favor of the immune therapy for gallbladder. So that is a hint for us. But if someone wants to give it, he or she is scientifically within his rights. But be careful in the gallbladder scenario. Okay, which regimen would you give of these? If it is not a gallbladder, it's a cholangio. The topaz or the keynote? Topaz.
Topaz.
Topaz. Why not keynote? क्या पाप किया उन्होंने?
So the amount of benefit, I think slightly less.
कैसे? Quantum of benefit, can you stratify?
Just which I remember.
Yeah, just half a minute.
Hazard ratio is better for
Okay, this is not how you look at trials कि उसका hazard थोड़ा मेरा बच्चा तेरे से थोड़ा सुंदर है ऐसा नहीं आता. So to be fair, can anyone else tell for hazard? It is 0.6 or something, 0.06 better actually.
So both the trials, the comparative arm is different. In Keynote 966, you had gemcitabine as maintenance, whereas in the Topaz trial, it was placebo.
So that's one point.
Median OS hazard is comparable, but if you focus on long-term OS hazard, particularly 3-year hazard, then Topaz will score better than...
Actually, if you look at the OS for both, this is there on the left arm. I'll tell you both the trials on how statistical power looks similar on the OS point of view. My point is something very, very different on the thing that, yes, the Topaz curve looks little bit better, but the patient at risk is nearly the same if you look at down. The chemotherapy arm is something that concerns me, that if I have to use a pembro, as of now I have to give a gemcitabine on and on till progression. So the last question that brings me, do you practice, if you're not even giving immune checkpoint, do you practice giving a maintenance chemotherapy till progression in your patients? Frontline, all of you give that?
I do. If patient is not affordable
What is the level of evidence you have for that?
There is retrospective data set available for that.
Okay, so again there is only a retrospective data which is a Tata Memorial publication. You don't have any randomized trial as such. So my take home would be that yes, we should be pushing for an immune checkpoint plus chemotherapy in this space of biliary tract cancer. Gallbladder do benefit lesser than compared to non-gallbladder. Pembro versus the Durva, I think the skeleton of gemcitabine giving which has been practiced in Pembro is something, why do you want to give added toxicity? And the benefit is, or you are getting similar benefit with Topaz. So this is where I'll stop.
One more.
Yeah.
The Sarlo maintenance was study from TMH.
So what happened?
There was some EFS benefit.
I think the small things, I would not change my practice on that, based on that. So thank you panel, thank you everyone, and if there is something, nothing there, we'll stop here. Thank you. Thank you, sir.
Thank you. Thank you. So, the only thing I'd say is in the HCC and biliary cancers, better to add multidisciplinary other groups also, so that it will become more.
Thank you, sir. I would request Dr. Shekhar Patil sir also to please join for the group photo, and Dr. Ghansham Biswas sir to please join for the photo. Thank you, sir. Thank you, ma'am. Now we quickly move on to our last session of the day. I would like to invite Dr. Surendranath Senapati, sir. He's a radiation oncologist from Cuttack, and Dr. Shitish Mishra, sir. Okay, for the next talk, I would like to invite Dr. Tamojit Chaudhary, sir, from Kolkata. He's a medical oncologist. For chairing this session, I would like to invite Dr. Ghansham Biswas, sir.
Yeah, so good evening, and I believe everything has been discussed in the previous panel discussion. So thanks to organizers for this opportunity, thanks to Roche for this slide set. So for the next 15 to 20 minutes, we'll focus on the atezo-bev data, which somewhat have been discussed in the previous panel. What are the myths and facts about this regimen, and some real world data also I would focus in the later line, along with some high risk population data, including the high tumor burden, the BP4 patients, as well as the elderly population or the geriatric population. So this is my disclaimer slide. Hepatocellular carcinoma is the third leading cause of cancer-related death worldwide. So that signifies the disease-specific mortality of this particular disease. And we are all aware of the BCLC or Barcelona Clinic liver cancer staging. It's basically a 5-tier staging system which would signify or help us in stratification of the what therapy to be given for which patient. When we talk about systemic therapy, it's predominantly for the advanced stage disease. Now, how to classify advanced stage disease? It's very simple. It's either a BCLC stage C patient, that means macrovascular invasion or extrahepatic spread, but ESMO guideline also mentioned that it may be an early stage disease or intermediate stage disease. That means BCLC stage B or A patients which are not amenable to loco-regional therapy. This also has to be regarded as an advanced stage disease. So as of today, as per if you focus on the NCCN on ESMO guideline, there are 2 regimens which are approved for an advanced stage hepatocellular carcinoma, which are unresectable and metastatic, with a category 1 recommendation. One is atezo-bev and the second one is the durvalumab tremelimab data. Although the CheckMate 9DW, the EP-NIVO data is very much encouraging with the longest overall response and overall survival, but still the FDA and DCGI approval is pending for that regimen. So this is basically the landscape of unresectable hepatocellular carcinoma treatment agents. We are all aware that sorafenib has been approved in 2007. 2018, we have the REFLECT, which showed that non-inferiority of lenvatinib in comparison to sorafenib and got approval. The current category 1 standard recommendation, which are either atezo-bev, which approved in 2020, and then durvalumab, tremelimumab as per the Himalaya data, approved in 2022. And there are separate TKI monotherapy or IO monotherapy or combination IO approved in the second line regimen. So IMBRAVE 150, it's basically a 2:1 randomization, including patients with locally advanced or metastatic or unresectable hepatocellular carcinoma, predominantly BCLC stage C patients, roughly around 80%. 20% have BCLC stage B or A patients, which are not amenable to roco-regional therapies. Open label design between experimental arm, which was atezo and bev at standard doses, and sorafenib, which was the standard of care at that time. Primary endpoint, core primary endpoints are overall survival and progression-free survival. Now, interestingly, this trial has been designed in an open label design just to avoid every 3 weekly 2 placebo injections for the patient, and just to remove the bias which is associated with an open label design. The both co-primary endpoints, the OS and PFS, has been assessed as per Central Independent Review Committee assessment and not as per the investigator assessed methods. So this is the baseline demographic characteristics, which are very much well balanced in the ITT population. We can look into the details that BCLC stage C included roughly around 80% and 20% patients having an early disease but not amenable to loco-regional therapies. Predominantly patients with viral etiology associated HCCs enrolled, 1/3 population non-viral or NASH related, and roughly around 30 to 40% patient enrolled with a high volume disease or which are poorest subgroups like macrovascular invasion or extrahepatic spread. So this is the updated overall survival Kaplan-Meier. It clearly suggests that separation of the curve starts very early. It's roughly around 1 month after the treatment initiation in comparison to the comparator arm, which is the sorafenib monotherapy. And the difference maintained in a longer follow-up. Median overall survival is roughly around 19 months versus 13.4 months with a very significant hazard ratio of 0.66. Now, in terms of response assessment, again, just I have said for the co-primary endpoints, overall response rate as a secondary endpoint, and to remove the bias associated with an open label design, here also for response assessment also, the investigator assessment has not been followed. Primarily, the Central Independent Review Committee assessment has been followed. 2 different response criteria has been used. One is the standard RECIST and second one is the HCC related modified RECIST. Both suggested almost 3 times higher response rate as well as roughly around 10% CR rate favoring the experimental arm. Safety summary, no new safety signals obtained. Grade 3-4 treatment-related side effects roughly around 35 to 40% in both the arms. In the atezo-bev, the predominant side effects which are expected for an atezo-bev combination are: number 1 is hypertension, proteinuria and upper GI bleeding, and as well as some sort of diarrhea and rash, which are predominantly due to IO related. So now we'll focus on more on the specific subgroups. We are all aware about for the CLD or upper GI bleeding is an important complication, CLD related HCCs, and if we focus on the exclusion criteria, then this IMBRAVE actually entails that all the patients has to undergo an upper GI endoscopy screening before the inclusion, and patients with an untreated or incompletely treated esophageal or gastric varices or high risk for bleeding as per the Bevano 6 criteria have been excluded from the study. But if you focus on the upper GI bleeding risk, particularly the high risk criteria, there is no significant difference, 6% in both the sorafenib versus atezo-bev arm, and which was again comparable from the historical TKI monotherapy data. So if you focus on the patients with varices, which are properly treated or with a low risk for bleeding as per the Bevano 6 criteria, the patient with varices, again, the incremental benefit, both in terms of numerical and statistical benefit, was well maintained in the atezo-bev arm. Although the bleeding risk is slightly higher as expected in patients with varices. Now, as I have discussed, that patients considered for atezo-bev has to undergo an mandatory upper GI endoscopy screening before the enrollment into the trial to assess for the what is the actual bleeding risk. Bevano 6 criteria, which is not validated for hepatocellular carcinoma, predominantly used for the CLD patients, can be used in practical sense, and if the optimal treatment for large esophageal varices or for a high risk for bleeding varices, although it's not known, but guidelines recommend that at least 1 session of banding or alternatively carvedilol can be used before the initiation of this experimental regimen. So I think all this confusion and perception about this viral and non-viral etiologies has been very well described. So as of now, all this perception about this non-viral etiologies, particularly NASH-related hepatocellular carcinomas, whether really the immuno-oncology drugs work and inferiorly, the response rate is inferior, that all this concept started from an 2021 Nature publication, which is basically a meta-analysis sort of thing, including only 3 randomized controlled trials, which suggested that probably the NASH-related or non-viral etiology-related hepatocellular carcinoma, the immuno-oncology drugs are not the best. But subsequently, there is a updated meta-analysis, including almost most of the contemporary recent trials, which suggested that basically these subgroups are exploratory analysis of typical post-hoc analysis of the exploratory subgroups, and these are not statistically powered enough to show that whether immuno-oncology drugs are actually work less in NASH-related HCCs. Moreover, if you focus on the duration of response and forest plot, it suggests that the TKI arm actually works better. And the same thing is showed in the subgroup analysis of the IMBRAVE 150 in patients with viral versus non-viral etiologies, that at 6-month or 12-month overall survival difference is only numerical, and there is no absolutely statistical difference. And as I've discussed, this updated meta-analysis also confirms that in terms of response of immuno-oncology drug combinations, either an IO-IO or IO-VEGF combination, there is absolutely no difference in terms of duration of control or duration of response. So now few real world practices. This is basically from AIG Hyderabad and Mahatma Gandhi Hospital Jaipur data, including 67 patients of unresectable HCC treated with Atezo-Bev to assess the survival parameters and adverse events among different child PU classes, which has been suggested that probably the child PU class is the biggest predictor or prognosticator for assessing the outcome of the standard regimen. The second is basically a single-arm meta-analysis from the global real-world studies, including almost 23 studies, roughly around 3,000 patients. The pooled median overall survival is 14.7 months. Median PFS is 6.6 months. Duration during the treatment, roughly around 30% patient having grade 3-4 treatment-related adverse events, which are again quite comparable to the IMBRAVE 150 and the Himalaya study, the global phase 3 data. So in conclusion, Atezo-Bev showed good efficacy and tolerability in the treatment of advanced unresectable hepatocellular carcinoma. Now this is a very interesting network meta-analysis, which with an endpoint of risk of death has been taken as the primary endpoint, and it has been performed with a fixed effect statistical model, including 9 different phase 3 randomized controlled trials, including patients of first-line unresectable hepatocellular carcinoma. And what has been shown that if you focus on the hazard ratio, then all the contemporary other first-line agents which are approved, including the TKI monotherapy, including the other IO-IO combo, the Atezo-Bev somewhat statistically is superior, although we are all aware about this network or IPD meta-analysis data. So next we'll focus on the heavy burden disease, and if there is a tumor thrombus or invasion directly to the main trunk of the portal vein, which is commonly known as the VP4 patient population, then again the subgroup analysis suggested that the hazard ratio is quite comparable for patients with this VP4 subgroup versus the rest of the ITT. The hazard ratio is 0.62 for the BP4 patients. As we have discussed during the panel discussion, this is a very high risk population. We know that these are going to be, not going to be do good with any form of therapy. And all the other contemporary trials, the CheckMate 9 DW, the Himalaya study actually excluded this patient population. They have not enrolled a single VP4 patients. Roughly around 15% of the whole ITT population of this IMBRAVE 150 included in this BP4 population, and which suggested that the incremental benefit was well maintained favoring the experimental arm. And similarly, like VP4, the other high tumor burden patients, like direct invasion to the biliary tract, direct invasion to the with extrahepatic meds, particularly the macrovascular invasion or extrahepatic spread positive patients, again the hazard ratio is favoring for the Atezo-Bev combination. Now, almost 1 hour earlier, we have heard about the geriatric population data, how the appropriate geriatric assessment to be done. So next, the focus should be what is the actual subgroup of the patients which are enrolled in this geriatric population in the IMBRAVE 150 and how they fared. They fared well or they fared worse. So there is a specific subgroup analysis for the IMBRAVE 150 to answer this question, and it suggested roughly around 30% of the population enrolled in IMBRAVE 150 are actually having an age of more than 65, roughly 20% in the age group of 65 to 75, roughly 10% enrolled above 75 years of age. And if you focus on the toxicity parameter of this subgroup analysis, that suggested the treatment is very well tolerated, and actually the grade 3-4 toxicities of the atezolizumab arm are not different than the whole ITT population. And similarly, like the toxicity, like the response rate also, if we focus on both the RECIST as well as the modified RECIST assessment, if you compare the ITT population with this above 65 years of age group population, then again the objective response rate, the CR rate, all are quite comparable to the ITT population. Objective response rate is again more than 30% with a CR rate of roughly around 9%, which is comparable to the ITT population. So this is my last slide. In summary, there are notable advances in the systemic therapy with the introduction of immune checkpoint inhibitors. Atezolizumab is probably one of the preferred first-line systemic therapy option in patients with high disease volume patients, difficult to treat population, which is FP4 patients, and also heavy burden and extrahepatic spread. NASH etiology patients, as we have discussed, that there is no convincing evidence to suggest that immunotherapy combinations don't work in NASH-related HCCs. Probably child PUB in real world practice, because IO combinations can have potentially more hepatotoxicity, which is difficult to manage in a child PUB patient. So in a child PUB patient, particularly for B7 or B8 score, if you really want to use a doublet, atezolizumab is probably the safest regimen, and as well as the elderly population. So thank you. I'll stop here, and thank again to organizers for this opportunity. Thank you.
So thank you, Tomajit. So Tomajit, so are you able to give 15 milligram, or so you give a lower dose?
Actually, sir, we use 7.5 mg per kg, most of the patients.
Okay, thank you. So now we move to the last talk of the day, and this symposium is sponsored by Bayer. So role of darolutamide in the management of non-metastatic CRPC and metastatic HSPC. So Dr. Saurabh Mishra, so our medical oncology colleague from AIIMS Bhubaneswar.
Good evening, everyone. So, changing from GI to GU and non-immunotherapy, right?
So are you also part of the metastatic hormone-sensitive prostate cancer trial?
Okay.
So one of my patients is still ongoing on darolutamide. So it was unblinded some time back, and then I could have found that the patient who is doing good is actually on a darolutamide.
It's great, great. It's a good drug. So the role of darolutamide in the management of non-metastatic castrate-resistant prostate cancer and metastatic hormone-sensitive prostate cancer. So this is a molecule which is a androgen receptor antagonist, and its structure is a bit different from the other two androgen receptor antagonists which we are using, enzalutamide and apalutamide. Now when you have a different structure like this, it gives it a more polar structure, a more flexible structure, and as a result, it has very limited penetration into the blood-brain barrier, and it also gives it a more potent androgen receptor inhibition. GABA receptors are present in the central nervous system, which are responsible for the toxicities associated with the androgen receptor antagonist. This is less with darolutamide. So this structure provides efficacy. This structure provides also limited toxicity. So this is the spectrum of prostate cancer, from localized disease, biochemical recurrence. Then there can be non-metastatic or a metastatic setting. So then we have to define whether it's a progression is hormone sensitive or if it is a hormone resistant setting. So in this study, which was the Aramis trial, it was a non-metastatic castrate resistant prostate cancer, PSA doubling time of less than equal to 10 months. So high risk population, and they wanted to find out if combination of androgen deprivation therapy with darolutamide leads to improvement in the metastasis free survival or the overall survival. Now for such patients, what would be our clinical relevant endpoint? I believe even it's a non-metastatic setting, we would like these patients to live longer. Although metastasis free survival, other surrogate endpoints are welcome, but for non-metastatic CRPC, if I want to use this drug in my clinical practice, I would want that these patients live longer. Now, did that happen? We have to see in inclusion criteria. As I said, this was the non-metastatic castrate-resistant prostate cancer with a PSA doubling time of less than equal to 10 months. There were certain exclusion criteria. So the primary endpoint was metastasis-free survival, which was met, significantly improved. Now, secondary endpoint was overall survival. It was a hierarchical analysis. So if you met a primary endpoint, you would go and analyze the secondary endpoints. And here again, the secondary endpoint was extended overall survival with darolutamide. In spite of many patients, almost 55% of the patients in the placebo arm receiving subsequent life prolonging therapy, darolutamide in the front line could lead to improvement in survival, showing that this is a robust molecule to start in this setting. Subgroup analysis, as always, not very clinically useful for us to make decisions, but then it favored for the use of darolutamide for overall survival, as well as more important, more robust was the metastasis-free survival. Other relevant endpoints which we also see, like the time to pain progression, these are clinically relevant to us. More time to pain progression, more time to use of cytotoxic chemotherapy, more time to symptomatic skeletal events with use of darolutamide compared to placebo. Subsequent antineoplastic therapy also, this was with use of darolutamide. Now, when you are using such a drug in the non-metastatic setting, we have to justify to the patient that yes, your quality of life also need not be impaired, because doesn't make sense using a drug and impairment of quality of life. So better quality of life or comparable quality of life with use of darolutamide as compared to placebo. Similarly, when we are using in a non-metastatic setting, these patients, mind you, are going to survive for very long period of time, and therefore the toxicities like CNS related adverse events or any other toxicities were also less. There are potential drug-drug interactions with all androgen receptor antagonists, and we have to keep a watch over that when we are using them in clinical parlance. So the conclusion from this study was that darolutamide used in the non-metastatic castrate-resistant prostate cancer significantly reduced the risk of death, and the safety was well tolerated, and the quality of life was maintained. So I think with these results, we can use this drug in this setting, and we can justify it to the patient why we are using this drug. So if you go to the real world, so there are 3 drugs which are approved in this indication in the non-metastatic castrate-resistant patients. So apalutamide, enzalutamide and darolutamide, and therefore the patients who progress to metastatic CRPC, when you are comparing this, is less with in darolutamide compared to enzalutamide, apalutamide. Mind you, these are across study trial analysis. Still something to say that yes, which agent are you going to use? Probably here it shows that darolutamide probably would be the choice. Now switching gears, we are now coming to the next setting where this drug is approved. That is the metastatic hormone sensitive prostate cancer. Again, metastatic hormone sensitive prostate cancer has undergone a sea of change in the paradigm of treatment. We don't use only ADT anymore. We use a second agent, either docetaxel, or we use 3 drugs. So this study, which is known as the Allison study, it compared the combination of androgen deprivation therapy with docetaxel, which had by then become the standard of care with a triplet drug regimen, docetaxel along with darolutamide. And again in this setting, as we have seen, we need an overall survival analysis as the primary endpoint, and the combination of darolutamide with docetaxel and ADT in comparison with only ADT, docetaxel and placebo led to a significant improvement in the overall survival. 4-year survival rate increased from 50% with docetaxel compared to 63% with the combination of darolutamide. Now, when you see whether de novo metastatic hormone sensitive prostate cancer, mind you, these are bad subset of patients compared to only recurrent metastatic. So these patients did also good, and also in the recurrent setting also. And coming to the definition of high volume Chartier criteria or high risk latitude criteria, either the visceral metastasis or more than equal to 4 bony metastasis with 1 beyond the vertebrae, or high volume, either subset of patients more benefit in the high volume of subset of patient compared to low volume subset of patients. Similarly, high risk and low risk also benefited equally with this drug. Secondary endpoints, time to castrate-resistant prostate cancer, time to pain progression, time to subsequent anti-neoplastic therapy, all of these were well tolerated. Robust PSA were better with darolutamide, PSA response also. Toxicities, docetaxel in addition to when you add darolutamide, you have some more fatigue. So in patients with metastatic, non-metastatic castrate-resistant prostate cancer and metastatic hormone-sensitive prostate cancer, darolutamide is now approved in the non-metastatic castrate-resistant prostate cancer based on improved overall survival, also in patients with metastatic hormone-sensitive prostate cancer based on improved survival. Before I conclude, I would just say one thing. This drug combination of docetaxel, darolutamide compared to docetaxel, do you have any data saying that docetaxel, darolutamide and ADT does better than only darolutamide plus ADT? We don't have that data. We have comparison of triplet versus docetaxel. We don't have data of triplet versus only ARPIs. So we have to think about that thing, and we can appropriately choose that for our patients. Thank you once again, the organizers, for this opportunity.
So thank you, Saurabh. So thank you, Bear. So all darolutamide trials, so ARROW-NET, ARASEN, ARASEC, so all starts from A. So thank you. So now, so that's the last of scientific session. So we have a GBM. So we meet next. So we'll take 1 hour to organize the stage. Please. So we'll have a gala dinner here and a Abhijit Ghoshal night. We have also asked the
Abhijit Ghoshal from Mumbai, and I'm so happy and elated
Nobel
to be
laureate for
performing,
harmonica
for 6th annual Congress of I-OSICON in Bhubaneswar on 1st of February under Dr. Hemant Malhotra, Dr. Jyoti Vajpayee and my dear Dr. Ghanshyam Vishwas Dada. And meeting so many oncologists, such top people of the medical fraternity under one roof in itself is a very rare opportunity, and we have one special guest from US also. So I am waiting to meet you, sir, also. And I will mostly perform Bollywood and probably 8 to 10 languages, Indian languages, and a couple of Western songs also. So I'm literally looking forward to meet you all on 1st of February by evening at the venue. So let's have a wonderful, wonderful musical time there in Bhubaneswar.
थोड़ा सा तेरा सा होगा, थोड़ा मेरा भी होगा, अपना ये आशियाँ।
दादा माइक फाइक ले लीजिए ना। हाँ अरे उसको उठाए ना, अभी तो ये होगा ना।
नामी नहीं, सारे उतार देते हैं, सब बंद कर दीजिए, नामी निচ্ছে, सब तो नामी ही तो নিতে হবে। পোডিয়াম পোডিয়াম সবই তো নাম
হ্যাঁ বার করবে ওইটা নিয়ে না ভাই তো রিপিটার হেডফোন ওটা
বেরিয়ে যাবে আজকে আসলে বেরিয়ে